Good morning. Welcome to join this session on hypertension in young adults, when, why, and how. I'm one of the chairperson. My name is Jail Shin from Yonsei University of College of Medicine, and co-chair.
I'm Joseph Flynn from University of Washington in Seattle.
Yeah, first two talks are by Professor Joseph Flynn and the others of mine. Okay, could you introduce the first?
All right, so our first speaker is Dr. Hak Won Kim from Seoul National University, who's going to talk to us about optimal initiation age for hypertension screening in young adults.
Thank you, Chairman. The number one cause of death mainly contributed to the high blood pressure. This is worldwide data. Also, the risk of high blood pressure for the cardiovascular risk increased from systolic blood pressure from 115 and diastolic blood pressure 70. Blood pressure elevation according to by aging process is evident. So hypertension prevalence is continuously increased by aging. So the young adult, the hypertension prevalence is relatively very low. USA data showed that only 7% of adult hypertension prevalence in young adult. Korean data also showed the similar findings. The prevalence of hypertension in young adult is very low. However, the risk of hypertension in young adult is more prominent compared to older ones. In this cardiac study, the patient with hypertension younger than 35 years old had more target organ damage compared to older people. Another study also showed more stronger correlation between hypertension and poor cardiovascular outcomes in younger people compared to the elderly hypertensives. The similar findings, as increased the blood pressure, the risk of cardiovascular event is significantly increased even in young people. Recent Korean data also showed similar findings. You can see here, they studies Korean young adult aged between 20 and 40, and their impact of blood pressure on cardiovascular event in long-term clinical follow-up. You can see here strong correlation. So although this a strong association between high blood pressure and cardiovascular risk in young adults, their hypertension awareness and treatment rate is very low. You can see here, this is data from the Korean fact sheet 2020. And the hypertension control rate is also very low in young adults. This is the Korean data. The more recent Korean fact sheet data show the similar findings: lower awareness, lower treatment rate, and lower control rate of hypertension in young adults. So it is natural to think about the frequent BP monitoring and screening is useful because it can identify the hypertension in earlier stage, but we should think about the cost effectiveness in terms of nationwide screening concept. Cardiovascular primary prevention guidelines recommend the hypertension should be screened among all adults. This means that age more than 18 or 19 years, all adults should be screened the blood pressure for the hypertension screening purpose. In Korean guideline, also the same principle to recommend to measure blood pressure to all Korean adults more than 20 years. And then every 2 years, the blood pressure monitoring is needed. However, if the patients have some risk factors like obesity, LVH, or family history, in the case, the annual BP screening is needed. Also, after 40 years, annual BP screening is also recommended. However, there is limited evidence how many times, how long intervals we should check blood pressure in young adult between 20 and 40 years. Current European guideline also suggests the hypertension screening for all adults, and they also emphasize the regular BP measurement if they have some risk profile or aged more than 40. More recent European Society of Cardiology Hypertension guidelines, they recommend BP screening for all adults, and they also some new recommendations. If the patient's less than 40 years, then every 3 years BP measurement for hypertension screening is enough. However, after 40 years, the annual BP screening is recommended, and in patients with risk factors, they also received annual BP measurement. Another important finding is that opportunistic screening concept. They recommend to measure blood pressure as a screening tool. They recommend opportunistic screening. Blood pressure measurement in the clinic or during the health checkup, in the pharmacy or citizen service centers or elderly people in some centers or fitness centers, if we can measure blood pressure in this facility, this BP measurement is acceptable for the screening purpose. Most of BP screening recommendation mainly based on this US Preventive Service Task Force recommendation. It's the same. They recommend the BP screening for all adults. However, if the patient is aged between 20 and 40, their recommendation is 3 to 5 year interval BP screening. However, if they have some risk factors or after 40 years, annual BP screening is recommended. This data showed that the correlation between office blood pressure measurement and ABPM or home BP monitoring. The correlation power is acceptable. So for the screening purpose, office BP measurement or one-time BP measurement is enough. However, recent recommendations, so some worry about the use of office BP because of lower sensitivity compared to the ABPM. ABPM is until gold standard method to measure blood pressure because ABPM data is more strongly associated with cardiovascular risk. So recent European guidelines recommend the screening of hypertension by office blood pressure and then confirming hypertension with ABPM and home BP monitoring. Also, the guideline usually emphasize the use of validated blood pressure measurement device and proper positioning for the blood pressure measurement. There is lack of evidence with RCT data, but some observational studies, this pooled analysis of several observational studies, and they show that increased the hypertension risk in patients with the 3-year interval, and between the interval time 3 years and 5 years not difference. So this task force recommendations based on this study data and the regular follow-up between 3 and 5 years. It's the same result shown in another study. The hypertension risk increased after 4 years, so between 3 and 5 years recommendation may be acceptable. This is Canadian people data, elderly people. So the nationwide screening program for the hypertension significantly reduced the cardiovascular events. Also in Taiwan data showed that this nationwide hypertension screening program is effective. So this task force recommendation is all adults should be screened BP, and every 3 to 5 years in patient aged between 18 and 35 years, and out of BP monitoring should be performed before confirmed diagnosis of hypertension and starting medications. This data was from the meta-analysis or pooled analysis of many clinical trial or observational studies. They also showed that there is a very limited harm to measure BP screening. Recent data performed by Hae-young Lee from Seoul National University, the result showed that from the 40 years and every 3-year interval BP screening is most cost effectiveness. However, consider the risk of blood pressure elevation. After 40 years, annual recommendation is also acceptable. Adolescents, BP screening, there is limited evidence, but routine screening is not recommended, but just increase the low salt diet or exercise. But in patients with risk profiles, LVH or obesity, family history, or suspected secondary hypertension, and then BP screening is recommended. However, some pediatric guidelines, they recommend the BP screening from at 3 years age and every 2 years. For the children with high-risk features, they recommend annual BP screening. What is the evidence from for our Korean guideline every 2 years? This may be based on the national health screening every 2 years in Korea. This is my personal opinion. even in young adults, the more aggressive or BP screening is maybe acceptable because the lower awareness, treatment, and control rate in young age hypertension or more risk of untreated young age hypertension. And also, early detection is very important. And screening purpose, office BP screening or opportunistic BP screening one time is acceptable. So it is very cheap, there's no harm to the patients. Some studies show that some risk stratification is needed. And if the patient is high risk, and then BP screening more early time and more frequently. This is my take-home message. Despite the higher cardiovascular risk, young adults with hypertension have lower awareness, treatment, and control rate. Evidence is limited, but the BP screening for all adults is needed. Most of guidelines recommended the BP screening for all adults. And the annual BP screening is recommended for patients above aged more than 40 and patients with risk factors. However, in younger adults aged between 20 and 40, there is some debate for the BP screening intervals. In Korea, 2 years, and European guideline, 3 to 5 years. We need more data about the BP screening in young adults. Thank you very much.
Great, so thank you for that, and we'll do questions and discussion at the end with the panel. Our next speaker is Dr. Ji-Yoon Lee from Korea University Guro Hospital. She will talk to us about masked hypertension in young adults.
Thank you for the introduction. I'm Ji-Yoon Lee, and I'm very pleased to be here today with distinguished professors and colleagues to share my presentation. My topic is masked hypertension in young adults. The term masked hypertension was introduced by Thomas Pickering in 2002. It was defined as normotensive by clinic measurement and hypertensive by ambulatory measurement. Until then, masked hypertension was called as reverse white coat hypertension or white coat normotension. Then Thomas Pickering mentioned in a review article in 2007 about the definition of masked hypertension as normal office BP and elevated out of office BP. But there are some issues. First, when masked hypertension is diagnosed by home monitoring, there is no consensus about which time of day the measurements should be performed and the reproducibility of measurements. And then Franklin in 2017 mentioned in the article about 24-hour ABPM as being the gold standard for diagnosing masked hypertension. Until from 2002 to 2016, masked hypertension was also called as isolated ambulatory hypertension, white coat normotension, and reversed white coat hypertension. Let's look at the definition of masked hypertension in the different guidelines. 2022 KSH guideline mentioned about definition as normal in the office with elevated measured by HBPM or daytime ABPM. But in the 2023 ESH guideline defined masked hypertension as normal in the office with elevated when measured by HBPM or ABPM and added the sentence of prevalence of masked hypertension varies when different ABPM periods, which is daytime, 24 hours, or nighttime are used to define out-of-office hypertension status. And the 2024 ESC guideline also defined masked hypertension as BP below the hypertension diagnostic threshold in the office, but above the hypertension diagnostic threshold in home or ambulatory settings in daytime or 24-hour BP. Lastly, 2025 AHA-ACC guideline also defined masked hypertension as high BP outside of the office, but not high BP in the office. But as you already know, the hypertension diagnostic threshold in AHA-ACC guideline is lower than other guidelines, which is 130/80. So the corresponding BP values of daytime ABPM, nighttime ABPM, 24-hour ABPM is lower as 110/65 and 125/75. Let's move on to the prevalence. There are no definitive data of prevalence, and it varies considerably. The first study was the Owasama study, which shows a prevalence of 10% of subjects with normal screening BP and ambulatory blood pressure as a borderline hypertensive range. The second one was the Pamela study, which showed a prevalence of 9%. But as you can see in here, the ABP criterion of all the studies are different, and the prevalence also varies. The 2022 KSH guideline mentioned about prevalence being 9 to 30% of individuals with normal office BP, and core ABP registry data showed around 17% of individuals who underwent ABPM for the diagnosis of hypertension. The 2023 ESH guideline described the prevalence as 10 to 20% of patients attending hypertension clinics. This is the first US prevalence data, which estimated the prevalence of 12% of the adult population. And they defined the mass hypertension as non-elevated BP in the clinic and elevated awake ambulatory BP. But when you apply the different guidelines, the prevalence can vary. The prevalence can be twofold higher under the ACC-AH criteria than under the ESH criteria. As you can see here, the 33% and 60% because of the lower diagnostic threshold for hypertension, and the use of the min 24 BP criterion in contrast with min daytime BP also increases the prevalence. So this is the Jackson Hart study conducted on African Americans, and the prevalence varies from 15% to 30% when defined by elevated daytime BP or 24-hour BP, and the prevalence can go as high as 60% when nighttime BP is included in the definition. The African Predict study was conducted on apparently healthy black and white South Africans aged 20 to 30 years, and the prevalence of the young individuals in South Africa was around 17%, which is a similar prevalence with all age groups. But when you look at the table, the majority of the classification was based on nighttime ABPM, and another 24% was based on the all-time ABPM. And this is the study by Professor Lee Moo-young estimated the prevalence of hypertension in South Korea, Goyangsi, and the prevalence of Goyangsi's the mass hypertension was around 16%, and this study defined hypertension by ABPM as 24-hour average, not by daytime ABPM. Around the same time as the Professor Lee Moo-young's study, this prevalence of the worldwide prevalence study was published, and as you can see here, the prevalence varies from 8% to 30%, with overall prevalence around 17%. Let's move on to the determinants. Pickering mentioned in 2007 article about the causes of mass hypertension, but the physiological mechanisms explaining the development of mass hypertension are not well understood. But we can think of the first factors as reduced clinic pressure, could be relatively low in relation to the ambulatory pressure, maybe because of the low anxiety levels. And second one can be factors which selectively raise the ambulatory pressure, which includes smoking, alcohol drinking, high physical activity, and stress level. And other factors such as male sex and younger age can be factors of mass hypertension. And 2022 KSH guideline mentioned about male sex, smoking, drinking, stress, DMCKD, obstructive sleep apnea as determinants of mass hypertension. And 2024 ESC guideline also mentioned about an exaggerated BP response to exercise can be associated with an increased risk for mass hypertension, as well as women with gestational hypertension can have higher risk of mass hypertension. The 2023 ESH guideline strongly recommended smoking cessation to avoid ambulatory BP increases, reduce the risk of mass hypertension, and improve the cardiovascular health outcomes. And also, attention should also be given to passive exposure to smoking because it can be a risk of cardiovascular disease and a 24-hour BP elevation. And e-cigarettes also increase BP and heart rate and may be associated with the increased risk of cardiovascular disease. In African PREDICT study, the profiles of mass hypertension groups share the similar factors to the other age groups, but this article also mentioned about waist circumference and elevated 24-hour heart rate in mass hypertensives, which can be related to increased sympathetic nervous system activity, which may contribute to obesity-related hypertension. In young adults study, the prevalence of mass hypertension was higher among individuals with clinic BP of pre-hypertensive range. In other study conducted in young to middle-aged individuals, they suggested an exaggerated SBP response to standing can be an independent determinant of mass hypertension. And another study showed the factors associated with mass hypertension, and an Italian population and Danish study also mentioned about ambulatory pressure being much less increased with age than the clinic pressure, so the mass hypertension would be less prevalent with increasing age. So the determinants of mass hypertension contains male, sex, and higher levels of physical activity and DMCKD, and individuals with African inheritance. And for the environmental factors can be mental stress and smoking, alcohol drinking, obesity, and obstructive sleep apnea. And also poor exercise tolerance can be the factor of predominantly selective daytime mass hypertension. What about the cardiovascular risk? The IDACO study showed the instance of cardiovascular events according to the 4 BP classification groups. You can see here the instance of cardiovascular events increased from normotension to white coat hypertension to mass hypertension and through sustained hypertensive patients. The 2023 ESH guideline showed that mass hypertension can be associated with hypertension-mediated organ damage such as impaired kidney function, LVH, increased carotid intima media thickness, and large artery stiffness. And it can be associated with developing metabolic abnormalities and sustained hypertension. In 2025, AH guidelines show that mass hypertension can be associated with an increased risk of cardiovascular events similar to sustained hypertension. In the Jackson Heart study, showed that regardless of whether it was defined using daytime, nighttime, or 24-hour BP, mass hypertension can be associated with an increased risk for cardiovascular disease. There are other studies about cardiovascular risk of mass hypertension, and Pamela data show the higher LV mass index in the mass hypertensive group than the true normotensive, and similar to that to the true hypertensive. And the Japanese study showed higher carotid IMT and PWV than normotensive patients. And the studies of young individuals also showed higher PWV and higher LV mass index and increased cardiometabolic risk profile in young mass hypertensive patients. And this African PREDICT study also shows that young adults from 20 to 30 also show the retinal artery narrowing, which can be predictive of cardiovascular disease. So the conclusion is that the definition of mass hypertension is normal office BP with elevated out-of-office BP, and the prevalence varies considerably depending on the regions or the diagnostic threshold. And it can be approximately 9 to 30% in individuals with normal office BP. And the factors including male sex, stress at work or home, smoking, alcohol drinking, obesity, obstructive sleep apnea, African inheritance, diabetes, CKD, and poor exercise tolerance are associated with masked hypertension, and the risk of cardiovascular events in masked hypertensives can be higher than normotensives and similar to that in those with sustained hypertension. Thank you for your attention.
Yeah, thank you so much. The next speaker is Young-woo Jang from Gachon University. Yeah, he will talk on nocturnal hypertension in young adults. Yeah, please.
Thank you, Chairman, for your kind introduction. Hi, my name is Young-woo Jang from Gachon University. It's an honor, true honor, to be presenting at Hypertension Seoul 2025. So today I'm going to be talking about nocturnal hypertension in young adults. My presentation is going to be a little more relaxed and fun, more animations involved. So please relax. So the definition of nocturnal hypertension, I'm sure you all may know, but is defined as systolic blood pressure over 120 and diastolic pressure over 70 millimeter mercury. And these are the blood pressure patterns during the nighttime. Usually you have a dip, which means a more than 10 to 20% reduction in your blood pressure during your sleep. But in subtypes called non-dippers, which is less than 10% drop in your blood pressure, is called a dipper, which is also associated with bad outcomes. And if your blood pressure tends to rise, we call this a reverse dipper. And an extreme dipper is patients who have populations that have a huge drop in blood pressure. So these are the definitions. Early morning BP surge is when your blood pressure rises in the morning, and it's also associated with bad outcomes. So in young adults, I would define young adults between 20 to below 60. And as you see over the time, hypertension, the incidence of prevalence of hypertension is pretty much stable. But if you can see within Korea, probably because Hypertension Seoul and the academic societies, the awareness of hypertension is on the rise. And the treatment rate is also on the rise. So I think it's a good thing among young adults that hypertension is a very big issue, and we're pretty much doing a very great job on treating them. If you look at the prevalence of nocturnal hypertension, there are very many studies. In this study, particularly isolated nocturnal hypertension was found in around 22.8%. Many trials and cohorts data showed that the prevalence of nocturnal hypertension might be around 10 to 30% in young adults. So what are the factors that might contribute to the development of nocturnal hypertension? Well, there are many studies, but this is the CARDIA study, which was a multiracial cohort, multinational cohort. And you can see that these two cohorts showed that apart from traditional risk factors, maybe some other socioeconomic factors might be associated with the development of nocturnal hypertension. So in this cohort, the coronary artery risk development in young adults study, you can see that they measured the behavioral scores, and if you have a poor behavioral scores, which might be a stress factor here and also other components there, you can see there's a trend of rising. The P for trend was less than 0.001, which means that if you have a poor socioeconomic health behavior score, you will have a higher chance of developing nocturnal hypertension, which is a bad thing. If we look at Korean data, this was published by one of our own, Byung-sik Kim and others. You see that, look at the age, and the higher the age, you had a higher chance of developing non-dipping patterns. And if you look at other factors, so if you looked at non-dippers and reverse dippers and did a multivariable analyses, there's no association, but female patients were less likely to have nocturnal hypertension. If you had an ambulatory blood pressure of hypertension, you had a higher chance, 51% higher chance. And if you had a better sleep quality, you had a very less chance of developing reverse sleeping patterns of hypertension. In a meta-analysis, you see that short sleep, so this might be related to stress, short sleep was associated with a higher chance of developing nocturnal hypertension. So there are many risk factors involved in developing this type of phenotype. Another Korean data showed that they looked at early morning BP surge, and they found that age was also a factor, which I previously showed in Dr. Kim's paper. So age was a independent factor that can predict the risk of nocturnal hypertension. So what really develops nocturnal hypertension? We looked at the clinical risk factors, but let's try to look at the underlying mechanisms here. So this is a very legendary paper in my mind. This was published in the Science in 1965. They did some experiments, surgical experiments on dogs and cats. They looked at the carotid artery and nerves that denervate to the carotid artery and the nerves that denervate to the aortic artery. They did a surgery and did some denervations here. So they cut the baroreceptors. So the denervation procedure was carotid sinus nerves bilaterally, strip the carotid sinus wall, and then several aortic nerves also. So this would cut the baroreceptors and saw what happened. So this is a table. I made a graph out of this, and you can see that in the dogs and cats that did a denervation process, you can see that there was a huge drop in blood pressure during a deep sleep. So this probably means that sleep-related BP fall is controlled by intact baroreflexes that prevent excessive hypertension during sleep. So the baroreflexes would be one of the mechanisms. Another experiment I'm going to introduce to you is they looked at mice and injected some medication into the peritoneum. What they gave was atropine, atenolol, and prazosin. Atropine, as you know, is a parasympathetic block. Atenolol is a beta blocker, which is the adrenergic blocker. Prazosin blocks alpha blockers, right? So they gave this and saw what happened during wakefulness and non-REM and REM sleep. And looked at the EEG and the blood pressure. What happened was, when they gave atropine, nothing happened to the blood pressure. When they gave atenolol and prazosin, what happened was there was a huge drop in blood pressure during REM and non-REM sleep, which means that there's a sleep-dependent BP decrease results mainly from reduced sympathetic vasoconstriction, not from the parasympathetic sympathetic activity. So in a nutshell, I think stress, sleep deprivation, and circadian rhythm disruption might cause sympathetic nerve activation and disruption of baroreflexes. And this might also cause nocturnal hypertension in the end. So we could apply this into the general population in our society. So there are some proposed treatment strategies, but we're not really perfect on this, and we don't have a lot of data. This is the most recent data that was published in the JAMA Open this year. It was a study conducted in China, and they compared evening doses and morning doses in hypertensive patients. They randomized patients. The patient population is around 55 years of age. And the male was around predominant 57 to 8%, and the BMI is around 26, which is similar to Korean patients. And when they did a bedtime dosing, they had a significantly lower blood pressure throughout the day, regardless of systolic and diastolic blood pressure. And also a higher achieved rate of blood pressure target when they did a bedtime dosing. So this might be maybe a solution. In an Asian expert panel consensus statement, they also suggested that we might have to use antihypertensives that have a longer half-life, like the amlodipine or the chlorthalidone. And what else? Other things do we have to do? Maybe after a quality sleep, it's a stress reliever. You see, after a quality sleep, the stress factors reduces, as you can see in this cohort. And the cohort age was only 51 years of age, so this might apply to young adults. So going back to 1994, there was the huge LA earthquake, right? LA Northridge earthquake occurred in January 17, 1994, and it was a huge disaster, as you see in these pictures. Family lost homes and loved ones, and it was a huge stress, I'm sure, to them. And in the New England journals at that time, they reported that there was a huge increase on the day of the earthquake, probably caused by, these were after excluding all the traumatic cases, the number of deaths, there was a huge rise. And we might look into some mechanism where you see that they did a brain MRI, and the amygdala, which is associated with, is activated when you have fear and emotional stress. There was a significantly higher chance of developing cardiovascular disease. So my suggestion is that due to these emotional stress that the younger generations, young adults are going through these days, there's a higher chance of developing atherosclerosis and probably nocturnal hypertension. Because of these, more inflammation may probably poorer CV outcomes. This is a picture from the 1996 Chicago Bulls. I'm a huge fan of Michael Jordan, and this is the Phil Jackson, who was a head coach at the time, and he's known as the Zen master who does meditation. And he implanted meditation and mindfulness into the team, which was a very new concept back in the days. So he had an Indian philosophy because he was raised in North Dakota, I believe. And so stress relief is the key factor in meditation. So in stress situations during the NBA finals and such, because they all practiced and did mind training of these stressful situations over and over again, teammates said that they had a very easy time in playing in the finals. So you can see Michael Jordan here. They're all doing stretching and yoga and meditation. I think the younger generations these days are facing, there's a huge volatile market of the stock market and the real estate, and this is very, very frustrating. As you may know, these days, trying to buy a house in Seoul is almost impossible. Almost costs in the Gangnam area costs $5 million US. It's almost impossible. So no matter how hard we work, it's really hard to buy a house. Stress at the job, and don't even get me started on raising kids. So there's so much stress in the younger generations. There's no hope. That's what they say, man. These might be a huge factors for developing nocturnal hypertension. So we have to do a better job. There are some novel perspectives regarding nocturnal hypertension. A paper published recently has proposed that maybe nocturnal hypertension is just a fluke. So if your blood cuff is lower than your heart, there might be an overestimation of blood pressure. The level of blood cuff has to be same as your heart level. There might be some errors here, and what they suggested was that there was a 49% chance of error of detecting nocturnal hypertension, probably due to the height of your blood cuffs. So the conclusion of my talk is the definition of nocturnal hypertension. I'm sure you all know. The prevalence of nocturnal hypertension in young adults might be 20 to 25%. The key mechanisms are suggested are stress, sympathetic overactivity, short or poor quality of sleep, and the clinical significance is that they can probably develop a higher chance of cardiovascular disease. And the practical message here today is we might have to do a better job and relieve stress and probably do more ambulatory blood pressure monitoring, and maybe evening doses are better. Thank you very much.
Thank you for the very comprehensive lecture on nocturnal hypertension in young adults. Okay, the next speaker is Dae-young Chun from Hallym University. He will talk on the strategies to improve adherence to antihypertensive therapy in young adults. Please.
Thank you, Chairman, for kind introduction. And my name is Dae-young Chun from Hallym University, and it is very honor for me to present my topic, the strategies to improve adherence to antihypertensive therapy in young adults. I have nothing to disclosure, and there is a clear difference in cumulative incidence between adherent and non-adherent young patients, as you see in these pictures. And as expected, the more consistently patients take their medications, and the lower their hazard ratio becomes. And the hazard ratio are almost 1.0 only when adherence exceed approximately 0.8. It means 80% of taking medications. This is why we generally define good medication adherence as taking at least 80%. So improving adherence in this young age group is not, it may be a key preventive strategy. And when comparing medication adherence by quartiles, and higher adherence is consistently associated with better outcomes. And this relationship is not only for composite cardiovascular disease, and each of the components, myocardial infarction, stroke, and mostly high in heart failure, and even in cardiovascular death in young adults. In recent European Heart Journal study among young adults aged 18 to 39 years, the adherent group showed a significantly lower risk of cardiovascular related hospitalization, and numerically shows much more better than all-cause death, but not statistically improvement. And there was, due to very low event, because the young adults have very low event about cardiovascular death or all-cause death, but we can suspect that poor adherence was associated with worse cardiovascular hospitalization and mortality outcomes even among young adults. This chart is from 2024 Korean Hypertension Fact Sheet, and the dark solid green line at the bottom represent individuals in their 20s and 30s. And thanks to the dedicated efforts of many clinicians here and nationwide campaigns led by Korean Society of Hypertension, and both hypertension awareness and treatment rate in this age group showed gradual improvement from 1998 to 2021, and followed by a marked acceleration in 2022. And the two upper graphs show that blood pressure control rates have improved in parallel with increased awareness and treatment rate. But however, the lower graph, representing treatment persistent, it is a little bit different from adherence, but not identical. It reflects that adherence remains sluggish when limited progress over recent years. And young adults continue to rank at the lowest level of the adherence across all age groups. And this is 2025 data from using national data from Korean National Health Insurance Service. 140,000 participants aged 20 to 39 years who had hypertension without prior cardiovascular disease, and start antihypertensive medications, and only 43% demonstrate good adherence. It means more than 80% of taking medications, and just 6% maintenance good treatment persistence. And this is another study, and in New York City found that over 10% of the were not taking antihypertensive medications, and key predictors of non-adherence is most are younger age and neighborhoods. Some others are neighborhood poverty, diabetes, or lower household incomes, and so on. And by identifying these characteristics, the investigators were able to classify adults with hypertension into 10 subgroups, and lower age and no diabetes, and the ethnicity meant non-adherence rate almost 48%. And we have to know about what is the contributing factors of medication non-adherence. In 2000, 3, WHO classifies 5 broad domains of non-adherence factors. These are socio-demographic factors such as age, ethnicity, income levels, and healthcare system-related levels such as patient-clinical relationships, patient-centeredness, or therapeutic inertia, and therapeutic-related factors such as choice of complex regimens or treatment changes or adverse effect. And condition-related things are multiple comorbidities or psychosis or drug abuse. And patient factors are patient misunderstanding or lack of knowledge or poor perception and so on. In a recent Korean nationwide study, several determinants of antihypertensive adherence were identified, and social demographic factors, older age, and male sex, and higher income, and urban residents are associated with better adherence. And lifestyle factors, non-smokers and physically active individuals showed higher adherence, and whereas frequent alcohol consumption had a modestly negative effect. And on metabolic risk factors, there was a dose-response relationship. A patient with 1 metabolic risk factors or more than 2 risk factors had much more good adherence. And in therapeutic regimen, below the table, combination therapy is better adherence than monotherapy. So we divide into the monotherapy group and combination therapy group. And most of the trends are consistent of all subgroups. The use of single pill combination further improved adherence and persistence. And in drug classes, comparing with diuretics, beta blockers and calcium channel blockers and RAS blockers is much more adherence compared to diuretics. And most of doctors complain that the adherence is just a patient problem, but many of the articles insist that this is not just the patient's problem. In fact, patients often hold the smallest share of the control among multiple stakeholders, and patient, clinician network, pharmacy, or health insurer in some country governments, they all have the stakeholders, and they have to working together to achieve sustained adherence. And shared accountability means aligning patient motivations and clinician simplification and pharmacy coordination and insurance support. Now let's take a closer look at each of these strategies in detail. First, the patient education and counseling. Providing patient for education is very important, and information about structured consultation reports sent to patient primary care physicians, or modifying treatment regimens, or strategies to promote adherence, including text messages and pill boxes, or follow-up consultations, will increase 4.7% higher adherence rate compared with the control group. Unfortunately, there are very few studies specifically evaluating adherence interventions in young adults. So these studies are not young adults. Almost mean age is 50 to 60 years. And medication regimen management is also very important. Modifying the way to medication is a key factor, and as we are well known about that, consolidating dose or FDC, fixed dose combination or extended release formulations are much more better than FEC, free equivalent combinations. And these 44 studies, meta-analysis show that it is increased adherence very high and also increase in persistence, and non-inferior or almost similar in systolic blood or diastolic blood pressure reductions and achieving blood pressure target. So we are recommended to adherence and to control blood pressure. Fixed dose combination is much more better. And synchronization is a little bit interesting things, because most hypertensive patients take multiple medications, not only hypertensive medications, and aligning refill or clinic visit dates so that all prescriptions are filled at once. It means synchronization. And in large study, nearly 23,000 patients in US, those medication synchronization program had a mean proportion of they covered PDC 8.6 0.7 and versus 0.84, 3% point improvement. So synchronization will be improvement the adherence. And benefit was 3 times greater among patients who with low baseline adherence and more than 9 unique medications. Too much medication takers will be affect from the get some effect for synchronization. And reminders. In this randomized trial on automated adherence support program using SMS text or interactive SMS texting, there was only modest improvement in systolic blood pressure, but not significantly a difference between informational just SMS texting and interactive SMS texting. And devices that are integrated into the care delivery system and that are designed to record dosing event are most frequently associated with improved adherence. And these electronic monitors combined with reminder message for patients who have missed dose is the best effect for adherence. But in contrast, lower cost devices are not so good. So we need to use a little bit expensive devices. And smartphone apps have been tested in these studies. Patients manually enter their medication list and dosing times, and the app automatically populated them via linkage to the medical records, and the app provide time alerts and weekly adherence summaries. And after 12 weeks, adherence is improved. The mean adherence scale, this is 0.4 point compared with no changes in controls, but no changes in between systolic blood pressure. So smartphone reminders may enhance self-reported adherence slightly, but are unlikely to produce meaningful blood pressure reduction. So more broader behavior or system-level interventions are needed. And how about self-monitoring blood pressure? In one study using electronic home blood pressure monitors and medication compliance reached 92% in intervention group versus 74% in the control group. And this shows that home blood pressure monitoring programs not only enhance overall hypertension management, but also improve adherence itself as patients become more engaged and aware of their treatment goals. Another important dimension is financial incentives to reducing and limiting out-of-pocket costs or providing financial incentive for patients or clinicians. And this is not only for hypertension patients, this is a patient for acute myocardial infarction patients, and shown that lowering co-payment for cardiovascular medications after MI improves outcomes across all patient groups. And self-monitoring and self-titration is also important for young age hypertension group because they are much more self-management. And in this study, although self-reported adherence at 12 months was similar across self-monitoring, because all the adherence much over than 95%, so maybe there is no differences in the ceiling effect, but patients in the self-monitoring and telemonitoring arms achieved significantly greater blood pressure reductions. Those both self-monitoring and telemonitoring can be practical and effective tools for younger patients. These are the abstract of the guidelines, and building on this evidence, recent hypertension guidelines emphasize 3 practical points. First, in patients who appear to have a resistant hypertension or who resemble secondary hypertension, before escalating therapy or ordering extensive secondary workup, we should evaluate their adherence is right. And single pill combination is also second important thing for all the guidelines. And third, recognize that no single adherence strategy is sufficient. Each management, as I shown before, is a multidimensional and team-based care model is needed. Almost same as in 2024 ESC guidelines, and almost the same as in 2025 AHG guidelines. So I will skip this result. And future directions, looking ahead, current reminder tools such as smartphone alert or electronic pill bottles remain limited, as I shown before, and only track reminders, not actual medication taking behavior. So recent studies have explored intelligence adherence systems built on commercial IoT devices. And when the patient opens the smart medicine cabinet, the system detects which compartment is assessed and verifies whether the correct medications has been taken. And if a dose missed, the system automatically sends alert through familiar channels. Some guys are on the internet TV, or some are on SNS, and ensuring that reminders reach the patient through the media they most frequently engage with. This real-time behavior-sensitive feedback loop helps bridge the gap between intention and actual medication taking and promoting sustained adherence in daily life, even in young patients. So this is my final slide. Improvement adherence to young hypertension patients, simplify the regimen, lifestyle modification with once daily or single pill combinations, and support adherence with technology and systems. They are very familiar with using their technology and systems. And verify before intensifying. BP is uncontrolled. We should think about that, check adherence and team-based medication, because the adherence is not just patient responsibility. So clinician simplification, pharmacy coordination, and patient motivation and insurance support is needed. Thank you for your attention.
Thank you so much for the wonderful presentations of various kinds of strategies to improve adherence to antihypertensive therapy in young adults. Okay, now it's time for the panel discussion, and so we invited three professors, Hyunjin Kim from Hanyang University, and Hyunju Yoon, Jeonnam National University, and Eunmi Lee, Wonkwang University. Okay, first, so is there any comments from the audience first? Oh, there's no. Okay, so Hyunjin Kim, would you give some comments or anything?
I'm Hyunjin Kim from Hanyang University. It was very interesting session about hypertension in young adults. I have one question to Professor Young-woo Jang. In young adults, nocturnal hypertension is often associated with lifestyle or sleep disturbance. So, what is your opinion about how feasibility is it to recommend wearable nocturnal blood pressure monitoring in this age group, considering cost or adherence? Wearable.
I think that's a very great question. These days, the ring devices that you can monitor your blood pressure are very prevalent within Korea. We can use it for a very low cost nowadays. And our hospital also started introducing them into our outpatient and also in-hospital patients, very cheap. So I think it will be a very good option for those young patients. And as I already mentioned previously, the young adults these days are going through, I thought I was going through a lot of stress when I was young. I consider myself young, but I think the younger generations these days are going through more stress, because back in the days we had hope because the economy is going up. Now we think it's going down. Although the K-pop Demon Hunter is a big thing in Korea, in the worldwide economy is going down. The stock market is still going up, hopefully, but the real estate market is skyrocketing. So I think we have a lot of stress, and the desperation of not being able to buy a house because of the high cost. Those all kinds of things, I think, are causing a lot of stress. So I think those ring devices for blood pressure monitoring might be a very good option.
Can I ask a follow-up question for you? So when we did our study of high blood pressure in adolescents using ambulatory blood pressure monitoring, we had the participants fill out a questionnaire about how well they tolerated wearing the ambulatory monitor for the 24 hours. And those kids who said that they had poor tolerability had more likely to have high blood pressure overnight. So how much of nocturnal hypertension is actually artifactual, caused by wearing the ABPM device?
I think that's a very good question, and I think it also applies to maybe most of the adult patients within Korea. One of the pre-screening processes that I do before giving them an ambulatory blood pressure device, not the ring ones, but the ones that you wrap around your arm, I first ask them if you have a hard time going to sleep at night. 100% those patients will have a higher chance of developing nocturnal hypertension, not because they have it, just because they have that, cumbersome a device wrapped around their arm. So I think that might be a huge, not only in kids, adolescents, but also in adults, especially middle-aged women patients that have a hard time going to sleep.
Yeah, thank you.
Thank you so much. Okay, the next panelist, Hyunju Yoon. So could you give some comments or
Yeah, I'm
questions?
Hyunju Yoon from Jeonnam National University. Thank you very much for nice lectures. I have just one question to Dr. Lee. Yeah, muscular hypertension is not there in real world nowadays, but these days home BP monitoring is used more often than 25 ABPM or kind of ring. However, since ABPM is required to dictate muscular hypertension or nocturnal hypertension, but I wonder if it is still helpful to check periodically ABPM in young adult patient whose home BP monitoring is well controlled. Is it necessary to periodically check up some kind of ambulatory BP monitoring?
You mean to screen the mass hypertension? So, as I show on the slide, there is an issue of home BP monitoring to diagnose mass hypertension because there can be people measure their home BP at different time period, so there is no diagnostic standard of what time should the home blood pressure monitoring should be measured. So I think because of the current guidelines, the 24-hour ABPM is the gold standard of diagnosing mass hypertension, but for home BP measurement, I think for me, I can check the timing of the home blood pressure monitoring, and then if the timing is met the diagnostic standard of home BP monitoring within 1 hour of waking up and then within 1 hour before going to sleep, and if their home BP monitoring is within the controlled BP range and their office BP is controlled as well, I don't think the periodic ambulatory BP monitoring is necessary to all patients, but for the smokers or for the pre-hypertensive office BP range people and for the people with high cardiovascular risk, I can think of some ambulatory BP monitoring based on person's characteristics. Thank you.
Okay. Will you give some advices for 24-hour BPM?
Well, I think everybody should get it done. So.
Okay, next panelist, the Eun-mi Lee from Wonggwang University. Okay, give some comments or questions.
I have one comment. We use the term nocturnal hypertension and non-dipping patterns, but it's not same term. It's not same term. Non-dipping hypertension is related to altered circadian modulation, but nocturnal hypertension is defined the elevated blood pressure regardless of daytime BP. So we do not use this term confused.
Okay, thank you so much for your comments. Okay, is there any comments or questions from audience? Okay.
My name is Cesar Romero from Emory University. My question is for the last speaker about adherence, and I was curious to see in Korea what kind of testing or how you screen for adherence. You're using chemical adherence or you're just working with questionnaire?
Thank you for your good questions. This data, as I shown before, in 2025 is a national health insurance database, and it is counted by how many medications they are prescribed and how many days they didn't get the medications. So these are only the medical calculators, not catched up by some biochemicals or patient information. So this is a limitation of the study.
Wait, don't go. I have a question for you. I thought it was interesting when you talked about synchronized prescription refills as a way of increasing adherence. There's also data on, dispensing 90 days worth at a time versus 30 days worth at a time, and just wondered what your thoughts were on that.
Yes, in almost same data mentioned that 90 days prescriptions is much more better than adherence than versus 30 days. So long-term adherence, long-term prescription is maybe affect to the much more good adherence, but in some patients, too many medications or in initiative of hypertensive medications, they should control their medications a little bit earlier rather than long-term long-lasting hypertensive patients. So I think 90 days will be great options, but in initial hypertensive treatment patient, also in young patient, we should frequently see on the outpatient department. And after they control well, and it will be the good options.
Yeah, so start them out with 30 days and then
Yes,
90
I started
days
in
once they're stable. Yeah.
Right.
Okay, I have one question. And in young adult hypertension group, there will be those who had the hypertension since childhood, but some young adult hypertension people will have the new hypertension. So during the childhood, normal, but after smoking or alcohol, heavy weight gain. So have any of you have ever find any papers the target organ damage might differ or anything like that? So this kind of patterns of the BP patterns are differ between them. So.
I just heard about that. One article mentioned that ECG changes of the left ventricular hypertrophy only detects of the younger patient hypertension. I remember, but I'm not sure that the other things such as echocardiographic findings or urinary microalbuminuria. So I'm not sure that.
So there might be very few study on that. So because the children eventually be the adults, and some new patients or young adult hypertension be very interested field. So we can, the pediatricians and adults, the doctors cooperate in this field, I think. Okay, thank you so much for joining this session, and so thank you for the invited speakers and panelists and audience. Thank you. Yeah, thank you so much. Oh, thank you so much.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
예, 아마 밑에 세션이 조금 늦게 끝난 것 같긴 합니다. 근데 시간이 돼서 시작하도록 하겠습니다. 안녕하십니까? 대한고혈압학회 총무이사 김광일입니다. 하이퍼텐션 서울 2025 제63회 추계 학술대회에 참석해 주신 모든 분들께 감사의 인사 말씀 드리겠습니다. 지금부터 추계 학술대회를 시작하기에 앞서 대한고혈압학회 회장이신 충남의대 정진옥 회장님의 인사 말씀이 있으시겠습니다. 모두 박수로 환영 부탁드리겠습니다.
안녕하십니까. 존경하는 학회 회원 여러분, 그리고 내 기빈 여러분, 고혈압 학회를 맞이하여 여러분을 이렇게 한자리에 모시게 되어 매우 기쁘고 영광스럽게 생각합니다. 고혈압이 아직도 많이 조절된다고는 하지만 여전히 세계적인 건강 문제이고 우리 모두의 헌신과 노력이 필요한 상태입니다. 이번 학회의 주제는 Healthy BP, Healthier Life라는 주제입니다. 이번 학회가 새로운 지식과 협력의 장이 되기를 기대합니다. 바쁘신 가운데 참석해 주신 여러분들께 감사드리고 뜻깊고 유익한 시간 되시길 바랍니다. 유튜브가 송출되고 있어서 영어로 간단하게 인사를 좀 해달라고 해서 그냥 짧게만 인사하겠습니다. Good morning, esteemed colleagues and distinguished guests and friends. On the behalf of the Hypertension Society, it is my great honor to welcome you. We are united here by shared mission to achieve healthy BP and healthier life. This meeting is not only a platform for sharing knowledge and innovation, but also a celebration of collaboration and dedication. I'm deeply grateful for your participation and your commitment. Thank you.
네, 회장님 감사합니다. 다음으로는 대한고혈압학회 이사장이신 한양의대 신진호 이사장님의 인사 말씀과 추계 학술대회 소개 및 주요 사항을 발표해 주시겠습니다. 모두 박수로 환영 부탁드리겠습니다.
안녕하십니까. 이렇게 추계 학술대회를 시작할 수 있게 돼서 대단히 기쁘게 생각합니다. 이번에 정해진 주제는 Healthy Blood Pressure, Healthier Life라는 주제가 되겠습니다. 이 healthy라는 말 자체가 좀 심하게 표현하면 약간 이모셔널하고 드라이하게 표현하면 좀 퀄리터티브한 그런 면을 가지고 있는 것 같습니다. 그래서 혈압 자체를 바라보는 관점이 이제 질적인 측면을 고려해야 되고 서바이벌뿐만 아니라 later stage of life에 있어서의 그 quality of life를 maximize하는 그런 어떤 질적인 문제까지 저희가 확장되는 그런 사이언스를 추구하는 그런 의미가 되겠습니다. 본 학회에는 평점이 보시는 바와 같이 그 의협 평점, 본과 전문의 평점, 그다음에 내과 전문의 외부 학술회의 평점으로 구성되어 있습니다. 그래서 참고하시고요. 그리고 저희 세션은 어제 진행됐던 주요 약물 치료 스트래티지와 그다음에 에피데미올로지 그리고 퍼블리케이션 관련된 세션이 있었고요. 오늘 세션에는 이미징 파트, 그다음에 커플레스 블러드 프레셔 모니터링, 가이드라인 세션이 있겠고 라이프스타일 체인지에 관련된 세션 준비되어 있습니다. 그리고 뉴로엔도크라인 하이퍼텐션에 대한 세션과 AI 세션, 그다음에 하이퍼텐션 리서치에 관련된 세션이 있겠고요. Korean Society of Cardiovascular Prevention 학회하고 조인트 세션도 준비되어 있습니다. 저희가 이번에 모신 패컬티 분들은 굉장히 국제적으로 저명하신 분들이고 각 영역에서는 거의 최고봉에 계신 교수님들이 되겠습니다. 그래서 많은 도움이 되셨으면 좋겠고요. 저희 학회는 구성이 포스터가 별도의 세션으로 구성되어 있는데 6층에 가시면 포스터 관련된 프레젠테이션 존과 이 포스터가 웨비나로 진행되고 있으니까 웨비나에 가셔서 많은 피드백과 커뮤니케이션을 진행해 주시면 되겠습니다. 저도 간단하게 유튜브 때문에 영어로 인사 말씀드리겠습니다. Good morning, ladies and gentlemen. It is my great honor to welcome you to this wonderful hypertension meeting, Hypertension Seoul 2025. We have a theme for this meeting, healthy blood pressure, healthier life. I believe that this theme leads us to the idea that the increasing lifespan by controlling blood pressure is important, but also augmentation of the quality of life is maybe more important. So we need to maximize the quality of life for our survival, for our life, until the very later stage of our life. Sometimes will be maybe more important. So we need to expand our researches and knowledges to that standard. I think it's meaningful theme. So I welcome all of you to this meeting and have a great opportunity to meet internationally distinguished scholars and expand your knowledges and inspire your researches. Thank you very much.
예, 신진호 이사장님 감사합니다. 이어서 학술대 이벤트를 간단히 소개해 드리도록 하겠습니다. 먼저 폐회식 경품과 관련된 내용 설명드리도록 하겠습니다. 예, 그 학술대 마지막 세션 종료 후에 내일 이 자리에서 폐회식 때 시상식과 경품 추첨을 진행합니다. 명찰에 부착된 경품 응모권을 응모함에 넣어주시면 1등부터 4등까지 보시는 바와 같이 아주 다양한 좋은 경품을 준비하였습니다. 끝까지 참석 부탁드리고요. 응모함은 내일 11월 8일 토요일 12시부터 오후 3시 30분까지 안내 데스크에서 운영되니 많은 관심과 참여 부탁드리고 행운이 같이 하시기를 바라겠습니다. 예, 다음 슬라이드 주십시오. 예. 그 스탬프 투어 관련된 내용입니다. 스탬프 투어 이벤트를 진행합니다. 이번 학술대회에 많은 후원사의 참여가 있었는데요. 등록하실 때 현장 안내 데스크에서 받으신 스탬프 투어 용지를 지참하셔서 전시 부스에 방문하시면 스탬프 투어 참여가 가능합니다. 또 대한고혈압 학회 마스코트인 내린이가 학회장 곳곳에 있으니 내린이 스탬프도 꼭 찾아보시기 바랍니다. 많은 분들의 적극적인 참여를 부탁드리겠습니다. 다음 슬라이드 주십시오. 예, 5층 포토존에 가시면 보시는 바와 같이 좋은 배경 화면에 최근에 캐더헌으로 갓쓴 저 복장이 굉장히 유행이라고 하는데요. 여러분도 아마 주인공이 되실 수 있을 것 같습니다. 그래서 5층에 포토존에 가서 사진 찍으시고 조금 시간 지나면 저희가 출력해서 사진을 드리니까 많은 분들이 또 그 기억에 남는 그런 사진 받으시기 바라겠습니다. 다음 슬라이드 주십시오. 대한고혈압 학회 마스코트는 이제 내린이입니다. 기린이 굉장히 높은 혈압을 갖고 있음에도 불구하고 이제 고혈압과 관련된 합병증이 생기지 않는다라고 해서 저희 고혈압 학회에서 혈압을 잘 관리해서 합병증을 예방하자라는 저희 취지와 맞기 때문에 저희가 이제 기린을 마스코트로 하고 보시는 것과 같이 이제 다양한 굿즈를 제작해 했습니다. 본 학회 기간 중에 6층 휴게 공간에서 저희 마스코트 내린이 굿즈를 만나보실 수 있고요. 머그컵이나 3단 자동 우선, 담요 등 이제 다양하게 준비되어 있으니 학회의 소중한 추억을 귀여운 내린이와 함께 간직해 보시기 바랍니다. 내린이 굿즈와 관련된 판매 수익금은 대한고혈압학회 홍보 활동에 활용될 예정입니다. 학회 발전과 인식 제고를 위해서 많은 관심과 참여를 부탁드리겠습니다. 예. 다음으로 이제 대한고혈압학회 정진욱 회장님께서 개최 선언이 있으시겠습니다.
지금부터 하이퍼텐션 서울 2025년 개회를 시작하겠습니다.
예, 참석해 주신 모든 분들께 감사 말씀드리고요. 이제부터 본격적인 모든 세션 시작하도록 하겠습니다. 저희가 준비된 이런 프로그램들이 여러 선생님들께 많이 도움됐으면 합니다. 감사합니다.
영어는 맞는데요. 외국 사람이 하면 소미 조는 이제 하버드라고 돼 있지만 오면 얘기해 주세요.
Good morning, ladies and gentlemen. Welcome to Hypertension Seoul 2025. This is a session of Young Investigator Award. My name is Jong-won Ha from Severance Hospital. It is my great honor to co-chair with Professor Il-seok Son from Gyeonggi University. On this session, we have a 6 contender for the Young Investigator Award, and we have also 3 judges. Let me introduce 3 judges. Professor Hyunjin Kim from Hanyang University, Professor Mi Hyang Jung from Catholic University, and Professor In Jung-jo from Ewha University. I'd like to introduce 3 first presenters, and Professor Son will introduce remaining 3 presenters. The first presenter of this Young Investigator Award session is Dr. In Tae-jin from Yonsei University. His title of talk is Association with Invisible Blood Pressure Variability with Cardiovascular Disease and Mortality Among Individuals Without a History of Hypertension, research from the UK Biobank. And the presentation will be 7 minutes and 4-minute discussions. Dr. Jin, please.
Yeah, thank you for introduction, Chairman. My name is In Tae-jin from Severance Cardiovascular Hospital, and I am very honored to present my abstract in Young Investigator Award session. Today, I'd like to talk about the association of within-visit blood pressure variability with cardiovascular disease and mortality among individuals without a history of hypertension. Traditionally, elevated BP is a well-established risk factor for MACE, as shown in large-scale clinical studies. But more recently, BP variability, which can result from several physiological and patient factors such as arterial stiffness and increased sympathetic tone and drug adherence, has emerged as a significant CV risk factor independent of mean BP levels. Regarding the relationship between BP and cardiovascular outcomes, contemporary guidelines recommend targeting systolic BP to around 120 to 129 millimeters of mercury. However, the clinical role of BP variability in guiding treatment decision is limited. There are 2 main reasons. First, we don't have causality between BP variability and CV events. And second, the strategies that aim to reduce BPV itself have not shown additive benefit beyond the BP reduction therapy. There are several types of BPV, from very short-term and to long-term BPV. The long-term BPV, such as visit-to-visit variability, is associated with subclinical organ damage and thereby increased CV events and mortality. This association has been shown in large cohort studies. Patients with high visit-to-visit BPV have higher all-cause death and coronary heart disease, stroke, heart failure, and renal disease. By contrast, very short-term BPV is still poorly understood in terms of its association with CV events or mortality. For example, within visit BPV, the variability we see in the outpatient clinic just by repeating BP measurements has not yet been clearly shown to be associated with mortality, MI, or stroke. Therefore, the aim of the study is to investigate the association between within-visit BPV and CV outcomes in the large community-based prospective cohort. Our patient population comes from the UK Biobank, the prospective multi-center cohort in the United Kingdom with more than 500,000 participants. We excluded individuals with missing BP data or covariates and patients with pre-existing hypertension or cardiovascular disease. Then we divided enrolled patients into quartiles according to within-visit BPV. Our primary outcome was all-cause mortality, while secondary outcomes are MI, stroke, heart failure, and new-onset hypertension. We use 3 adjustment models, and in fully adjusted model, we included the baseline BP, comorbidities, lifestyle factors, and socio-economic status. This is the baseline characteristic across quartiles of within-visit systolic BPV. Overall, quartile 4 has higher systolic and diastolic blood pressure and heart rate, and the proportion of dyslipidemia, diabetes, and the use of preventive medicine were also higher in quartile 4. And this figure shows the fully adjusted Kaplan-Meier curve for new onset hypertension. We can see a clear stepwise increase in risk with higher within-visit BPV, and quartile 4 has the highest incidence over follow-up. These findings are consistent for the cardiovascular outcomes. As within-visit systolic BPV increases across quartiles, the cumulative incidence of all-cause mortality, MI, stroke, and heart failure also increases. When we modeled BPV as a continuous variable, we observed a significant linear association between higher within-visit BPV and the higher risk of the cardiovascular outcomes. We can see similar pattern for diastolic BPV. We see with higher BPV associated with higher risk across all outcomes. There are several limitations in our study. First, the within-visit BPV was defined as the absolute difference between 2 consecutive measurements rather than using conventional variability indices. This may reduce measurement accuracy, but it is simple and clinically practical in real-world outpatient setting. Second, the observational nature of the study can cause selection bias, so residual confounding cannot be excluded, and that limits the generalizability. Third, the BP was not always measured under fully standardized guideline-based protocols, so our measurements may not completely align with current guideline definitions. And lastly, we didn't have out-of-office BP data, so misclassifications such as white coat hypertension could be happen. In conclusion, this large prospective cohort study, higher within-visit BPV was independently associated with an increased incidence of all-cause mortality, as well as an elevated risk of subsequent major cardiovascular events and new onset hypertension. And these findings highlight the clinical relevance of within-visit BPV, suggesting that even the difference between 2 consecutive BP measurements taken during a single visit may serve as an early and accessible marker for long-term cardiovascular risk. Thank you for attention.
Thank you, Dr. Jin. This presentation is open for questions or comments.
Congratulations on the success of your study. First, I'd like to ask the method of blood pressure measurement, because this is the study with within-visit blood pressure, so a method for BP measurement is very, very important, I think. And second one is you said that in the limited section, the absolute difference of blood pressure was used to define within-visit blood pressure variability. Am I right? Then absolute difference of blood pressure is usually influenced by the baseline blood pressure. Usually, if the patient has the higher blood pressure at baseline, the difference might be more larger. So how was the baseline blood pressure influenced the result of the study?
Firstly, we checked in the UK Biobank, the BP measurement was checked by over the 10-minute rest of the patient, and the time difference of the BP measurements was less than 1 minute. When we can see the baseline characteristics, the BP variability, quartile 4 has the highest BP, systolic and diastolic both. So the BP variability is influenced by the baseline BP, but we adjusted the BP, systolic and diastolic BP. And so after the adjustment, and the result was consistent with the unadjusted models.
Congratulations, your nice work. I have one question. I think the UK Biobank code is very good and useful data. So do you have any plan to explore seasonal blood pressure variability or visit to visit BP variability in the future?
Unfortunately, the database of UK Biobank have only BP measurement of the within visit variability, and the follow-up such as the visit to visit variability have lots of the missing data or covariates. So it has have a limitation about the visit to visit variability investigation, I think.
I have another question. There is a quite overlap between quartile 1 and quartile 3 of systolic BP variability, but the diastolic BP variability of quartile 1 and 4 are quite different, and it is, do you think the diastolic BP variability is better than systolic BP variability to predict severe events?
In our data, there is more linear association in the, it seems to be more association in the diastolic BPV than systolic BPV, but the within visit BP variability have the lots of the measurement error or something. So diastolic BPV, the result of diastolic BPV, causes the interpretation of the result.
Okay, time is up, and let's move on to our next presentation. Next presenter is Dr. Jong-hyun Lee from Yonsei University. Title of talk today is Aldosterone Excess, Blood Pressure Control and Kidney Outcomes in Chronic Kidney Disease, Findings from the Cardiovascular and Metabolic Disease Etiology Research Center High Risk Study. Dr. Ji, please.
Thank you, Chairperson. I'm Jong-hyun Ji from Gangnam Severance Hospital and the Neurology Department, and I sincerely apologize for my bad voice because of the flu. And it's a great honor to have a presentation here today, and I'll be presenting on aldosterone excess, blood pressure control, and kidney outcomes in CKD. Apparent treatment-resistant hypertension is highly prevalent among CKD patients. Its prevalence increases with increasing amount of albuminuria and becomes even more pronounced as eGFR declines. This indicates that worsening kidney function is closely associated with an increased frequency of resistant hypertension. The important point is not only that resistant hypertension is common in CKD, but also that it truly worsens clinical outcome in cardiovascular and kidney among CKD. So these findings indicate the importance of recognizing and actively managing resistant hypertension in CKD. Aldosterone excess is a key mechanism that contributes to resistant hypertension and subsequent target organ damage. Sodium retention by aldosterone excess yields high blood pressure and consequent oxidative stress or vascular remodeling process, leading to atherosclerotic changes in the vessels and eventual clinical events. Therefore, aldosterone excess may serve as key factor for risk stratification in hypertension patients. So this study aimed to evaluate the association between relative aldosterone excess with BP control and kidney outcomes in non-dialysis CKD patients. This study was a prospective observational study using data from CMOC high cohort, which includes patients at high risk of cardiovascular and metabolic disease from Severance Hospital. After excluding those with already SKD or having normal kidney function or missing data, a total of 745 non-dialysis CKD patients were analyzed. The patients were categorized into 3 groups based on BP control status determined by ambulatory BP data. We determined uncontrolled BP group as BP of greater than 125 or 75 with using less than 3 antihypertensive medications, and resistance hypergroup as with blood pressure of greater than 125 and 75 with using more than 3 medications, including diuretics or more than 4 medications. And lastly, controlled BP group was with blood pressure of less than 125 or 75 with using less than 4 medications. The uncontrolled BP group was treated as reference group for the analysis. To evaluate the association of aldosterone excess, relative aldosterone excess was defined by baseline serum aldosterone level greater than 10 with aldosterone to renin ratio ARR greater than 30 despite using RAS blockers. The primary endpoint was composite kidney outcomes. The baseline characteristics among 3 blood pressure control groups showed that there were no differences in age or sex among groups, but the levels of BMI were lowest in controlled BP group. The prevalence of previous cardiovascular history was highest in uncontrolled BP group, followed by resistant hypertension group. Baseline kidney function showed that the levels of eGFR was highest in controlled BP group, whereas the amount of albuminuria was greatest in resistant hypertension group. In terms of ambulatory BP data profiles, the proportion of non-dipper was highest in resistant hypertension group, whereas that of reverse dipper was highest in uncontrolled BP group. Those in resistant hypertension group were using diuretics much frequently than others, and only 2.3% of study subjects were using spironolactone. The baseline ARR was highest in uncontrolled BP group, followed by resistant hyper group, even though baseline aldosterone level was highest in control group. But the prevalence of relative aldosterone excess was higher in the resistant hyper group compared to uncontrolled BP group, reaching 13.6%. To evaluate the association and BP control status, we first perform a multivariable logistic analysis between aldosterone excess and uncontrolled hypertension, which was additionally defined as ambulatory blood pressure greater than 125 and 75. The model showed that relative aldosterone excess was associated with 3.7-fold higher odds for uncontrolled hypertension. Additionally, when risk for aldosterone excess was evaluated according to primary hour exposure, the 3 BP control group, it showed that the controlled BP group was significantly associated with lower odds of aldosterone excess. Next, we performed Cox analysis to evaluate the association between blood pressure control status and kidney outcomes. We found that the controlled BP group exhibited 42% lower risk of composite kidney outcomes compared to uncontrolled BP group. Finally, to examine whether the relative aldosterone excess modified the association between BP control status and kidney outcomes, the interaction term between the relative aldosterone excess and between BP control groups was incorporated into the Cox model. In this interaction model, the combination of resistant hypertension and aldosterone excess identified a subgroup with a 3-fold higher risk of kidney outcome than the reference group, whereas resistant hypertension alone, that means absence of aldosterone excess, was not significantly associated with this risk. In contrast, patients with controlled BP control status exhibited a significantly lower risk of kidney outcomes regardless of presence of aldosterone excess. From our study, we conclude that aldosterone excess is independently associated with uncontrolled hypertension, and aldosterone excess positive resistant hypertension confers a markedly higher risk of kidney outcomes. Controlled blood pressure is protective regardless of aldosterone excess status, underscoring the critical importance of achieving effective blood pressure control in CKD. So therefore, aldosterone excess monitoring may enable risk-based management in hypertensive CKD, and that means patients who could particularly benefit from MRI therapy. Thank you for your attention.
Thank you, Dr. Ji. This presentation is open for discussion and comments.
Thank you for your nice presentation, and I think it is a very interesting and important study. And the BP cutoff of ambulatory monitoring for defined resistant hypertension seems to be quite low, as 125 over 75. Then what is the prevalence of resistant hypertension in this patient group?
As you can see from the subject flow, there was less than 15 to 20% of the patients were classified into the resistant hypertension group.
Thank you for your nice presentation and congratulate your nice work. I have one comment. In your study, you exclude the dialysis patient, but because I think your primary outcome was kidney outcome, but many clinicians curious about the uncontrolled blood pressure in ESRD and hemodialysis patients. So it would be interesting to show the association between aldosterone excess and blood pressure control in ESRD group.
Thank you for your good comment, but the number of ESKD patients in our cohort was really limited, so that was our limitation point.
We think a high ARR is associated with primary hyperaldosteronism. So have you excluded those with primary hyperaldosteronism? And I think there was, I see that there was a difference between baseline medications. So, and the medications also affect ARR. So have you any consideration about that?
Thank you for your good comment. And I completely agree with you that we have to exclude the primary aldosteronism patients, and we try to exclude that patient, but it was really hard. And as you can see, the number of patients who are using aldactone previously was largely small, so we assumed that there was a highly small portion of primary aldosteronism. So yeah, so we used that definition. And as you commented, the using antihypertensive medications or diuretics are really variable between patients. So maybe next time we were gonna adjust that points to the multivariable model.
So regarding the measurement of ARR with the renin-angiotensin system blockade, but I think the effects of medication between AC inhibitor and ARB are quite different in terms of ARR. So do you altogether include it in the renin-angiotensin system blockade, or?
I put all together.
All together, okay.
Yeah, it's a nice comment, and next time I'm gonna separate between them. Thank you.
Okay, thank you, and we'd like to move on the next presentation. Our next presenter is Dr. Byung-woo Yu from Hanyang University. Title of presentation is Association Between Systemic Inflammation and Long-Term Mortality in Patients with a Hypertensive Crisis Visiting the Emergency Department. Dr. Yu, please.
Thank you for your kind introduction, and good morning, everyone. My name is Yu Byung-woo from Hanyang University College of Medicine. Today, I am honored to present our study entitled Association Between Systemic Inflammation and Long-Term Mortality in Patients with Hypertensive Crisis Visiting the Emergency Department. As a fourth-year medical student, it's a great honor for me to contribute to this research and gain the opportunity to present its results here in Hypertension Seoul under the guidance of my mentors. Hypertensive crisis refers to a sudden and severe elevation in blood pressure, often accompanied by acute hypertension-mediated organ damage, or HMOD. Although it affects only about 1 to 2% of hypertensive patients, it accounts for a notable portion of emergency department visits and is associated with high morbidity and mortality, even despite prompt treatment. However, long-term mortality remains high, suggesting that better prognostic factors are needed. In this context, systemic inflammation has emerged as a potential contributor to various cardiovascular diseases, including development and progression of hypertension and HMOD. Therefore, this study aimed to evaluate the association between systemic inflammatory indicators with long-term mortality among patients with hypertensive crisis who visited the emergency department. We also compared their predictive performances to identify which marker provides the greatest prognostic value. This is a retrospective single-centered study. We reviewed 172,105 patients who visited the emergency department between 2016 and 2019. Of them, 10,083 patients met the blood pressure criteria for hypertensive crisis, which was defined as systolic BP being more than 180 or diastolic BP being more than 110. After excluding cases with missing data or unclear diagnosis, a total of 5,320 patients were included in the final analysis. Patients were divided into tertiles based on each inflammatory indicator. Acute hypertension-mediated organ damages included the cardiovascular comorbidities mentioned here regarding previous guidelines. 5 systemic inflammation indicators were evaluated, which are NLR, LMR, PLR, SII, and CRP. Data were collected using electronic medical records, and we collected baseline data and outcome during the index hospitalization and follow-up period. The primary outcome was 3-year all-cause mortality, and survival data were obtained from the National Health Insurance Service database. The median follow-up period was 2.9 years. We demonstrated Kaplan-Meier curves for survival probabilities and performed multivariate Cox proportional hazard regression analysis to identify the predictors of 3-year all-cause mortality. We adjusted 4 clinically relevant variables such as age, sex, blood pressure, comorbidities, and components of HMOD. Additionally, we conducted restricted cubic spline modeling to examine their nonlinearity and time-dependent ROC curves analysis to compare their predictive ability. I would like to offer data of NLR principally and leave the data of rest of the indicators as supplementary. This table shows that higher NLR tertiles were associated with older age, a higher prevalence of cardiovascular risk factors, and worse diagnostic test results associated with HMOD. During the follow-up period, the mortality rates were also assessed. The mortality rate tended to increase with higher tertiles, being 28.1% at 3-year point of the highest tertile. Kaplan-Meier survival curves demonstrated a stepwise decrease in survival with increasing NLR tertiles. This tendency was more dramatic in patients with HMOD, but exhibits similar curves in patients without HMOD as well. This tendency was consistent across other markers such as PLR, SII, and CRP. Conversely, patients in the higher LMR tertile showed better survival outcomes. After adjusting for potential confounders, patients in the highest NLR tertile had a 1.6-fold higher risk of 3-year all-cause mortality compared to those in lower tertiles. These associations remained significant even after adjusting for age, sex comorbidities, and hypertension-mediated organ damage. Also, the odds ratios were markedly higher for patients with acute HMOD than without acute HMOD. In the restricted cubic spline analysis, the inflammation indicators showed diverse patterns of curves NLR and SII demonstrated linear positive relationships with mortality, while LMR, PLR, and CRP showed nonlinear associations. Especially LMR showed negative hazard ratios, indicating its negative association. In terms of predictive performance, CRP showed the highest area under curve at 0.677, followed by NLR, LMR, SII, and PLR in sequence, showing AUC values of approximately 60 to 65% in common. We can sum up the major findings of this study into 3 points. First, elevated NLR, PLR, SII, and CRP were associated with increased risk of all-cause mortality, while elevated LMR demonstrated a negative correlation. Second, there were linear positive associations for NLR and SII, and nonlinear associations for LMR, PLR, and CRP. Third, among the indicators, CRP demonstrated the highest predictive performance, followed by NLR and LMR. Our results indicate that incorporating systemic inflammatory indicators could aid in identifying patients who may benefit from more intensive surveillance or early intervention. Therefore, the role of systemic inflammation as a key contributor to hypertension and the need for new therapeutic strategies modulating inflammatory pathways should be emphasized. Thank you for your attention.
Thank you, and this presentation is open for questions or comments.
Thank you for your presentation. As a medical student, I think you did a very good job. And I just want to ask a simple question about a study population. It is regarding a hypertensive crisis defined as BP of more than 180 over 100 or greater. But there are some patients with hypertension with such a elevated blood pressure, and there is also a patient without hypertension with transiently elevated blood pressure levels. Does your study also include the second case of patients?
Thank you for your great question. That's an excellent point. We included the systolic BP over 180 and diastolic blood pressure 110 for tight collecting of the population. That's because we needed to collect more number of patients, and also the transient increase of the blood pressure was not adjusted, so that's a limitation of our study.
Then you mean just simply elevate blood pressure without having hypertension is also included in this study?
Yes, but this blood pressure check was measured in the emergency department, so we could not distribute the causes or the transient elevation of blood pressure.
First of all, I'd like to ask why you define the primary endpoint as all-cause mortality. If you want to see the association of blood pressure, then I think the cardiovascular mortality or cardiovascular disease would be more proper for primary outcome. And you showed from Kaplan-Meier curve, the mortality is usually occurred in very short time, within 6 months, first six months. So then it might be associated with systemic infection or cancer like that. So have you excluded those patients with infection or cancer at emergency department visit?
Thank you for your question. That's an excellent point as well. So we collected the data from Certificate of Health Insurance Eligibility, which is 보험 자격 득실 확인서 in Korean. So by collecting the data this way, we can only check whether the patient's eligibility of health insurance has changed to ineligible in 2019 compared to 2016. So we were unable to deeply classify the cardiac mortalities, whether we check whether the mortality actually happened. And second, sorry, what was your point?
The cause of emergency visit would be the infection or cancer, which is usually associated with high mortality, and your Kaplan-Meier curve show the higher mortality during the first 6 months. So I'd like to ask, have you excluded these patients, or they all are all included in the study?
Yes, we have excluded the systemic inflammation or other diseases that can affect the systemic inflammation status.
Okay, thank you, Mr. Yu. So we will move on to next presenter. I'd like to introduce next speaker, Soo-Jung Park from Hanyang University. She will present the study titled with Age at Hypertension Onset and Long-Term Risk of Cardiovascular Events and Renal Outcomes, a community-based Korean cohort study. Dr. Park, please.
Thank you for your kind introduction. Good afternoon, everyone. My name is Soo-Jung Park from Hanyang University Hospital. Today, I'm here to present my study investigating how the age at hypertension onset influences long-term cardiovascular and renal outcomes based on data from a large community-based Korean cohort. Let me start with some backgrounds for this study. When hypertension develops early in life, prolonged exposure to high blood pressure causes hemodynamic stress on vessels and organs, leading to hypertension-mediated organ damage and eventually cardiovascular and renal events. Although this mechanism seems biologically plausible, clinical evidence remains limited, especially in Asian population. Therefore, we aim to investigate this relationship using a large Korean cohort. Clinically, this study is meaningful because young hypertensive adults are often under-recognized and undertreated. According to the 2024 Korean fact sheet, their awareness and treatment rates remain very low, highlighting the need for early detection and active management. Overall, evidence of the age of hypertension onset is still very limited, especially among Asian population. Therefore, we aim to evaluate whether early onset hypertension is associated with a higher risk of MACE, mortality, and chronic kidney disease. Let me now explain the study design and methods. This study was based on the Ansan cohort, which is part of the Korean Genome and Epidemiology study. Since 2001, a total of 10,030 adults aged 40 to 69 years living in Ansan and Ansong have been enrolled and followed up 6 times over 14 years. This slide shows the selection process of our study population. Among 10,030 participants in the Ansan cohort, we excluded those with missing data on hypertension diagnosis or onset age, and those with pre-existing major cardiovascular disease. Finally, 9,644 participants were included in the analysis. They were classified into normotensive control and 4 hypertensive group according to the age at hypertension diagnosis, less than 45, 45 to 54, 55 to 64, and 65 years or older. In this study, hypertension was defined as a self-reported physician diagnosis. Participants indicated whether they had ever been told by a doctor that they had hypertension. The age of onset was also self-reported based on their first diagnosis. Next, I'll go over with the outcome definition. HMOD was evaluated cross-sectionally at baseline. Although HMOD can include various indicators, only 3 measurable components were available in this cohort: LVH in ECG and proteinuria greater than 1 positive, and eGFR less than 60, and participants meeting any of these were considered to have HMOD. In contrast, CKD, MACE, and mortality were assessed prospectively during follow-up. MACE included myocardial infarction, coronary disease, stroke, heart failure, peripheral disease, and cardiovascular death. And incident CKD was defined as new onset eGFR less than 60 among those with normal baseline function. Baseline characteristics were compared across onset age groups. We used logistic regression for baseline HMOD and Cox proportional hazard model for incident outcomes. All analyses were adjusting for key covariates, including age, sex, BMI. Now let's move on to the result of our study. This table shows the baseline characteristics according to the age at hypertension diagnosis. Overall, the study included 9,644 adults with a mean age of 52 years. Participants with younger age at diagnosis were more likely to be male and urban residents and had a higher BMI and dyslipidemia. They also showed higher prevalence of current smoking and alcohol use, indicating that individuals diagnosed at a younger age were more likely to have unfavorable lifestyle habits. This slide shows cross-sectional association between age at hypertension diagnosis and HMOD. All hypertensive groups had a greater likelihood of HMOD than normotensive individuals, with the highest likelihood in those diagnosed before 45, about 2.4 times greater after adjustment. However, no clear linear trend was observed. When we looked at each component of HMOD separately, participants diagnosed with hypertension before age 45 had about a 2.4-fold higher odds of LVH, twofold for proteinuria, and a remarkably 7.6-fold for reduced kidney function compared with normotensive individuals. This slide shows the result for MACE. All hypertensive groups showed a higher risk compared with the normotensive group, with the highest risk in those diagnosed before 45, about twofold higher after adjustment. The hazard ratio decreased within older age, and P4 trend was 0.014, showing a significant linear trend. And this slide shows the result for all-cause mortality. No significant increase in mortality was observed among participants younger than 55 years at the time of hypertension diagnosis, whereas the risk of all-cause mortality was significantly increased in those aged 45 years or older. Finally, this slide shows the result of CKD. Participants with a younger age at diagnosis had a significantly higher risk of developing CKD, and the risk gradually decreased with an older age at diagnosis, with a P4 trend was 0.014. To summarize, an earlier age at hypertension diagnosis was associated with greater HMOD and higher risk of CKD and MACE, but not with all-cause mortality, likely because cumulative damage has not yet led to death during the follow-up. Our study has a few limitations. HMOD was assessed using only 3 measurable components. The age at diagnosis was self-reported, which may have caused recall bias, and individuals unaware of their hypertension were not included. And we had no detailed data on medication use or BP control. Finally, this is the conclusion of our study. An earlier age at hypertension diagnosis was consistently linked to a greater burden of organ damage and a higher risk of cardiovascular and renal events. And this suggests that when hypertension begins may matter as much as how high the blood pressure is. Recognizing the age at diagnosis could help identify high-risk individuals early and guide more timely intensive prevention strategies. Thank you for your attention.
Thank you, Dr. Bach. It's time for discussion. Judges, please.
Congratulations on the success of your study. Do you have any data regarding duration of the hypertension or the medication history and BP control status? Because your data show that patients with diagnosed hypertension at younger age showed lower baseline age. So patients are usually shorter duration of hypertension, but they showed higher risk for end organ damage. So this might be some kind of selection bias. So do you have any data about duration of blood pressure and control and adherence like that?
Thank you for your great question, and I agree with you. Actually, HMOD assessed at baseline reflects cumulative burden of subclinical organ damage and already present. I think it helped us better understanding of baseline risk across age at diagnosis group. But I think the duration is very important information for this study. So we are now doing additional analysis using duration from diagnosis to enrollment are in progress. And I think BP medication and BP control data is a very major limitation of our study. But we observed clear patterns of a younger age at diagnosis have consistently higher risk of clinical outcomes. So while our studies are not complete, I believe our study will provide valuable context. I hope to include more detailed data in the future research.
I want to ask about the higher risk of earlier diagnosis of hypertension. I want to ask the meaning of earlier age of hypertension is more have higher risk than the what comparator? Because I want to ask this question because most epidemiologic study shows relative risk, not the absolute risk. So in most epidemiologic study, the younger patients have more higher relative risk, but that does not mean that they have higher absolute risk. So in this study, I think the higher relative risk for the younger patient means just higher relative risk. What is the comparator of the relative risk?
That's a good point, but I haven't thought about before. I'll look into it and follow up later.
Okay, Dr. Kang, thank you. I'd like to move on to next presenter. Next, Ji Kang from Seoul National University. She will deliver talk about genetic predisposition recalibrates blood pressure threshold for cardiovascular risk. Dr. Kang, please.
Thank you for the kind introduction. The title of our research is Genetic Predisposition Recalibrates Blood Pressure Threshold for Cardiovascular Risk. I have no financial conflicts of interest to disclose. So to start with, according to hypertension is, as you all know, the most leading modifiable risk factor for cardiovascular disease. Blood pressure thresholds associated with increased cardiovascular risk continues to change over time. According to the 2025 AHA guideline, the general treatment goal is to maintain blood pressure below 130 and 80. Recent advances in genomics have provided new tools for precision medicine, and polygenic risk scores, known as PRS, is a key tool for personalized medicine by enabling individualized prediction of disease risk. To elaborate further, PRS is calculated as the sum of effects of numerous genetic variants. Each genetic variant contributes a small effect in which the effect size is derived from genome-wide association studies. The weighted sum represents an individual's overall risk, genetic risk to a disease or a trait such as blood pressure. Recent studies have shown that blood pressure PRS enables the identification of individuals with elevated cardiovascular risk. So by using polygenic score, the genetically predicted SBP of each individual can be calculated. Our goal was to suggest a personalized blood pressure target based on genetically predicted SBP to prevent major adverse cardiovascular events and target organ damage. We first analyzed data from the UK Biobank, including participants without prior hypertension or cardiovascular disease. The polygenic score for SBP was calculated, and participants were randomly divided into training and test set in a 7:3 ratio. In the training set, genetically predicted SBP was estimated using the calculated polygenic scores through a rank-based inverse normal transformation model. Subsequent analyses were conducted in the test set using the resulting genetically predicted SBP. The primary endpoint was major adverse cardiovascular events, MACE, defined as a composite of cardiovascular death, myocardial infarction, stroke, or heart failure with up to 13 years of follow-up. This slide shows the distribution of measured and genetically predicted SBP in the UK Biobank test set. Although, as you can see in the left, the overall distribution looks similar, but there were substantial individual level discrepancies between measured and predicted SBP. The baseline characteristics are shown here. Participants were divided into 3 groups according to the genetically predicted SBP, below 120, 120 to 139, and over 140. Measured SBP increased slightly across groups. However, the absolute difference was very small, with a median value of 134, 135, and 137 in each group. Participants had a mean age of 55 and a mean BMI of 26 across groups. There was no significant difference in sex, diabetes, dyslipidemia, antiplatelet use, smoking, or income. This slide shows the adjusted risk of MACE by 10 millimeter mercury increase of systolic blood pressures, stratified by predicted SBP groups. As you can see on the right panel, adjusted hazard ratios for MACE increased with higher predicted SBP. A 10 millimeter mercury increase in measured SBP was associated with a hazard ratio of 1.08 in the low predicted group, but 1.11 in the high predicted group. And here's our main result. We compared the risk of MACE across SBP categories using measured SBP below 120 as the reference. In the low predicted group on the top, the risk of MACE became significant only at measured SBP above 160. In the intermediate group, the risk significantly increased, seen in red, from 140, with adjusted hazard ratios of 1.51 and 1.74. In contrast, in the high predicted group on the bottom, the risk was already evident at measured SBP 130 to 139, with an adjusted hazard ratio of 1.28, and it rose further at higher pressures. Overall, individuals with a higher genetic predisposition to hypertension were more vulnerable to even the modest elevations in measured blood pressure. We next examined each component of MACE separately rather than as a composite outcome. Similar trends were observed, but more prominent in cardiovascular related deaths and stroke compared to myocardial infarction or heart failure. The overall pattern was consistent across subgroups, but the association was stronger in women and in younger individuals. We then examined whether our findings were consistent in an independent external cohort with different ethnic background. We used the Gini cohort, which consists of individuals who underwent self-referred health checkups at Seoul National University Hospital healthcare system. The primary outcome in this analysis was target organ damage, which was defined as the presence of damage in at least one of the following organs. In the Korean cohort, we found same trends as in our main analysis. As you can see in the right forest plot, the threshold for a significant increase in target organ damage risk was 130 in the intermediate predicted SBP group, while it was 120 in the high predicted SBP group. In summary, we were able to generate a genetically predicted SBP value by using genomic data. There was substantial individual level discrepancies between measured and predicted SBP. Individuals with a higher genetic predisposition to hypertension were more vulnerable to even the modest elevation in the measured blood pressure. Similar trends were observed across individual outcomes, but it was more prominent in cardiovascular death and stroke. And finally, findings were validated in the independent Korean cohort using target organ damage as the outcome. In conclusion, genetic predisposition can provide personalized blood pressure threshold for cardiovascular disease prevention. Thank you for your attention.
Thank you, Dr. Gang. It's open for discussion. Judges, go ahead.
Thank you for your nice presentation. I have one question. Polygenic risk score were derived from European GIAS data. So how do you address potential ethnic or population bias for when validating in Korean code?
The UK Biobank PRS was calculated by using European summary statistics, but in the Gini cohort we used a different summary statistics from the Biobank Japan. So we were able to exclude the ethnic difference and the genetic causes of it.
Thank you for your nice presentation and wonderful results. I think it is very interesting. But in translating the clinical practice, what is your opinion about in our daily practice?
Thank you for the wonderful question. I think it's a really good point. So I think the clinical importance is that we usually as I mentioned above, the AHA guidelines says to maintain blood pressure below 130 and 80 in all population. However, I believe that guideline may not be relevant and may not reflect the cardiovascular risk in all individuals. For instance, as we've seen in the Gini cohort, participants with high genetic predisposition to hypertension showed target organ damage above 120. So it might mean that a stricter blood pressure threshold may be required for people who have higher predisposition to genetic predisposition to hypertension.
Congratulations on the success of your study. You said that a higher blood pressure target may be applied to high predicted group, but you also showed that low predicted group showed a minimal risk with a higher blood pressure about 150. So then we may lower higher blood target for those. Your data also say that we can apply higher blood pressure target for low predicted group. Can you say it? And also your data show that blood pressure target is also 130 over 8 millimeter mercury. In high predicted group, the cardiovascular risk increased over this value. So what would be the clinical relevance of this data saying?
If I answer the second question first, as I mentioned before, the target organ damage, we believe that target organ damage reflects develops before the development of cardiovascular disease. So as I mentioned, lowering blood pressure under 130 might not be enough for a high genetic group because they already get target organ damage above 120. As for the first question, I highly agree with your point, and it might be a limitation of our research, but because we only looked at MACE and other TOD as our outcome, we did not look at other comorbidities such as diabetes or other metabolic disease. I do not think that this results can say that in low genetic group we can have high blood pressure.
Okay, thank you, Dr. Gang. I'd like to introduce next and the last speaker in this session, Somi Jemmajo from Harvard University. Her presentation title is Blood Pressure Polygenic Score Predicts Long-Term Blood Pressure Control and Treatment-Resistant Hypertension. Dr. Jo, please.
Thank you for the kind introduction. Hi everyone, my name is Somi Jemmajo from Master Brigham in Boston, and I'm delighted to present my work on blood pressure polygenic score predicts long-term blood pressure control and apparent treatment-resistant hypertension. Here are my disclosures. So with recent clinical trials like BP Rotor Esper supporting intensive BP lowering, even among patients with complex cardiorenal conditions, clinical guidelines are increasingly lowering blood pressure threshold to diagnose hypertension and set target BP levels. And even the latest 2025 American guideline also remains steadfast with its 130/80 milligrams of mercury threshold to diagnose hypertension. But the guideline actually encourages SPP lowering below 120 whenever tolerated. But nevertheless, suboptimal blood pressure control is highly prevalent across the world. So perhaps genetics can address clinical guidance gap and more efficiently prioritize candidates for intensive BP lowering earlier on. So here, my prior work shows that genetically predicted blood pressure augments CVD risk prediction than done by measured blood pressure alone. Here, individuals with normal measured blood pressure, denoted in blue, but with high genetic risk score for SVP, so towards on the right axis, actually had comparable future CVD risk with individuals with untreated hypertension who are illustrated in orange in the middle. So you do see that risk overlap across genetic risk score, regardless of your measured SBP. But to date, genetic epi research only tests the association between genetic alleles and blood pressure measured at a single occasion or with a hypertension binary endpoint. So as such, the objective of the study was to explore whether BP genetic risk scores independently predict long-term blood pressure control and treatment-resistant hypertension in adults with established hypertension. So our main primary analysis used the Mass Gen Brigham Biobank, and Mass Gen Brigham is actually the largest New England healthcare system with genotype measurement and real-time linkage to electronic health records. To quantify the extent of blood pressure control, we set a 5-year assessment period beginning 2018 to project the adoption of the 2017 ACCHA BP guideline that substantially lowered the BP threshold for hypertension from 140/90 to 130/80. At the end, we identified 22,456 adults with established hypertension without prior history of heart failure with reduced ejection fraction, end-stage kidney disease, or terminal stage malignancy. The exposure was BP polygenic score, and thanks to the previous speaker who explained in details what PRS is. So briefly, polygenic score is a single value estimate of an individual's common genetic liability to a phenotype, and in this case, blood pressure. So a person with BP polygenic score with 72nd percentile would have a higher genetically determined blood pressure than a person on 32nd percentile per se. Primary measure of long-term blood pressure management was duration lived with above target BP over the 5-year assessment period. Here I calculated the percentage of time an individual lives with SVP above 130 threshold. And a separate outcome for DBP was calculated by applying the threshold of 80 or higher. And the second primary outcome was lifetime incidence of apparent treatment-resistant hypertension defined as shown in the table. Here I first categorized participants into low, intermediate, or high BP genetic risk, then used multivariable regression with time above target and treatment-resistant hypertension as separate outcomes. Second, to evaluate clinical utility of BP polygenic score beyond phenotypic risk factors, I calculated improvements in discrimination and net reclassification after adding BP polygenic score to the traditional risk factor-based model. Validation was performed using population-based UK Biobank study with linkage to primary care data, adopting the NIC BP threshold of 140/90 to calculate long-term blood pressure control. At the beginning of the 5-year blood pressure control assessment period, the average BP of the MGB Biobank core was 132/75, whereas UK Biobank, despite lower mean age, actually had a mean BP of 144/83. Mass Gen Brigham Biobank participants allocated the highest SBP polygenic score decile on average spent 51% of the time with above target SBP, whereas those in the lowest SBP PGS decile on average spent 41% of the time with above target SBP. We also see a gradient of treatment-resistant hypertension incidence across SBP polygenic score, with the highest genetic decile group had 2-fold higher incidence than their lowest genetic risk counterpart. Based on the regression model, in reference to the low BP genetic risk group, high BP genetic risk was associated with 8% longer duration lived at above target SVP and 6.2% above target DBP. And similarly, having high SBP genetic risk was associated with 2.4-fold higher odds of treatment-resistant hypertension. Stratified analysis by demographics, history of diabetes, CKD, and AHCVD indicated no significant effect modification. Interestingly, UK biobanks, so we assumed them to be a little bit more population-based and healthier. The association between BP polygenic score and long-term BP control was more pronounced, with high SBP genetic risk group was associated with 11% longer duration lived above target SBP and 8% longer duration lived above target DBP. We have further observed clinical utility of BP polygenic score beyond traditional risk factors as it meaningfully improved discrimination for treatment-resistant hypertension from C-index 0.74 to 0.78 and net reclassification by 4%. Summary: in large healthcare population-based cohorts of adults with hypertension, BP genetic risk was independently associated with an improved prediction of long-term stability of BP management. Given contemporary clinical guidelines underscore sustained achievement of target BP for all tiers of CVD prevention, our findings permit several conclusions regarding clinical utility of genetic risk assessment toward optimal hypertension management. First, BP-PGIS can be used in enhanced risk stratification beyond family history. And now recent guidelines now permit the use of genetic risk information for certain therapeutics otherwise ineligible based on non-genotypic risk factors. Second, BP polygenic score can be used to anticipate responses to therapy and prioritize patients requiring treatment for treatment intensification. For C, the individuals with high genetic risk have the largest absolute risk reduction from lipid-lowering therapies. So similarly, we can apply the same model for BP-PGS to efficiently identify subgroups who are more likely to benefit from certain therapy, such as zilebesiran or the novel renal denervation. Moving forward, one can strategically harness genetic risk to fill in clinical guidance gap by complementing with routinely measured BP. Improve elucidation of the genetic architecture of blood pressure across heterogeneous population will offer new disease understanding in hypertension. And these are the collaborators, including Dr. McAvoy, who's sitting on the table, and will give a great talk on the guideline comparison right after this session. Thank you.
Thank you, Dr. Jo. This presentation is open for discussion. Judges, please.
Thank you for your nice presentation and congratulations about your nice work. I have one question. How do you balance the clinical value of blood pressure polygenic score against other modifiable factors such as adherence and lifestyle modification and or secondary hypertension?
Thank you for the great question. So unlike other standard modifier risk factors, genetic risk is very static, so it's not modifiable. But to my understanding, at least for CVD risk prediction, a lot of the novel inflammatory biomarkers or a lot of the known standard risk factors, after your disease risk has been stabilized to a certain extent, don't give additional augmentation for future risk, and they have a very modest discrimination abilities. Unlike genetics, in a very if you defined a target population in a very clinically homogeneous way, I think that's when it comes best serves as the best risk discriminator among that very similarly profiled patients based on phenotypic risk factors.
Thank you for your nice talk, and I think you are better for the more large lectures. And I heard you about you do very good study from the Hogu Lee from San Francisco.
Oh yeah, Dr. Lee, who's at the AHR right now.
Yes, yes, and. What is your opinion about the genetically predicted BP, genetically predicted blood pressure? What is the best suited population? What is the most suited population, such as CKD or diabetic patient, and so on?
Thank you for the wonderful question. So. Actually, a lot of the subpopulations, such as those with stage 1 hypertension defined by the American guideline, So like those with SBP between 130 to 139. Actually, we don't have a lot of clinical trials data on whether, what their optimal target BP level is per se. And I don't think that, they're on the top of the list for clinical trials data because they have a very low 10-year risk per se. So I think, at least from what I'm working on right now, for populations that we don't have a lot of trials data on, what their optimal target BP level is, or when to initiate treatment, I think genetics can best serve to discriminate, who are at the exceptionally higher risk among those apparently healthy group per se. But I think the similar paradigm can use for those with already complex cardiorenal disease, but with a very poor BP management, despite high adherence. If we do like a cell type specific polygenic scoring per se, then we can better elucidate the pathobiology behind hypertension that's responsible for uncontrolled blood pressure.
It's very important study, and I have a simple question. Blood pressure control is also influenced by social, economic, and behavior pattern like adherence. So, have you ever adjusted these factors by calculation?
So because Master and Bergen Biobank is a real-world healthcare utilization data, we don't actively ask for a lot of the standard SES variables as done in course. The best we could do was their healthcare utilization pattern defined as interval or number of healthcare visit per year, or their health insurance study, because it's American study, so not everyone has health insurance per se, which is very largely correlated with SES measurements. We haven't done adherence factor in it because American data, EHR doesn't have a prescription refill data, but we hope to actually employ we hope to link it with a lot of our partner pharmacies and the future cohorts, and to see whether, if it's like the patient factor, medication injection and prescription factor that's affecting the poor management, or even if those with high adherence, if they have a poor responses to drugs, maybe genetics can serve to explain why that's the case.
Thank you, Dr. Jo. It's time to close this session. Thank you all the speakers, and good luck to all of you. Thank you, everyone. 좋은 제안 주셨고요.
여기다 두시면 제가 하겠습니다.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고, 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며, 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데, 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해 줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해 봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해 주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Whatever you want, whatever it is. In Seoul,
Hello. Welcome to this plenary session. I'm Jin Ho-shin from Hanyang University. I am the president of Korean Society of Hypertension. As a representative of our society, it is great honor to introduce the speaker today, Professor Bill McAvoy. I would like to introduce him briefly. He studied in Ireland, and he trained at Johns Hopkins Hospital, and he majored in cardiology and preventive cardiology. And you will know that his name is quite familiar because he's the co-chair and the first author of the 2024 ESC guideline for the elevated blood pressure. Because the majority of our society members are composed of cardiologists, clinical cardiologists, and epidemiologists. So we are very closely follow the ESC guideline and also AHA guideline for the management of hypertension. So this time it's going to be a great opportunity. The story insight and that inspiration or background of the recommendations in the these two cardiology society supported hypertension guideline. So his topic is reflections on key messages in the 2024 ESC and 2025 ACS-AH blood pressure guidelines. Professor McAvoy, please.
Thank you, Mr. Chairman, Professor Shin, and thank you to the Korean Society of Hypertension for inviting me to give this plenary lecture. Thank you to you all for being here listening to me. My name is Bill McAvoy, and as mentioned, I was co-chair with Professor Rian Taus, who's at the back of the room, of the 2024 ESC guidelines on elevated blood pressure and hypertension. I will say at the outset that I'm a half-time cardiologist, clinical cardiologist, so I spend half my time looking after patients, and I consider myself more of a humble clinician than an academic. And so I'm a little nervous making this presentation to a room of experts in hypertension. And I think these guidelines are written in large part for non-experts. But nonetheless, I'll share my reflections on the ESC guideline and on the more recent American guideline just released. I don't have any conflicts of interest to report. Because of the title of this talk and due to time constraints, unfortunately I won't be covering any of the many excellent Asian blood pressure guidelines or many of the other excellent blood pressure guidelines around the world. I'll just focus on the ESC and the AHA ACC guidelines. These are the ESC guidelines that are available for free to access at the European Heart Journal, and we're very proud of these guidelines. Included 25 task force members who were coming from all disciplines, including geriatrics, nephrology, neurology, and clinical psychology, as well as 2 patient participants. These are the American guidelines just released this summer and just published in Focus issue of JACC last week, chaired by Professor Jones. For the ESC guidelines, we wanted to try to keep things as simple as possible, recognizing the audience was largely targeted to clinicians who are not experts in hypertension. We defined 3 blood pressure categories as non-elevated for office systolic of less than 120, diastolic less than 70, elevated 120 to 139 in the office, or a traditional definition of hypertension which we maintained at greater than or equal to 140 over 90. How does this compare to the American guideline? In many ways, there's a lot of similarities, more than may first catch the eye. The non-elevated blood pressure group in our ESC guideline equates to a normal blood pressure according to the ESC guideline in large part, certainly for systolic blood pressure. A little insight into the background with the ESC. We discussed whether or not to call our non-elevated blood pressure category normal, but we decided against that because normal is a fairly philosophical question. We arguably don't know what normal blood pressure truly is. Certainly from evolutionary biology and even from prognostic information, it may be argued that normal is systolic of 100. So we decided to go with the term of non-elevated blood pressure. We wanted to ensure that we motivated people to maintain this non-elevated status and maintain a healthy lifestyle at all costs. Our elevated blood pressure group correlates with the US elevated blood pressure group, so same term, but also overlaps with their stage 1 hypertension group. And then our hypertension group, which is traditional for European guidelines, equates to the stage 2 hypertension category for the US guidelines. So really, the discordance, if there is one, is in the elevated blood pressure range, which for the ESC guideline encapsulates blood pressures of 130 to 139, which in America would be considered stage 1 hypertension. That brings up a philosophical question again, not just what is normal, but what is hypertension. And you can get into a debate on this too. There is really no universally agreed on approach to defining hypertension. Many people will come back to Jeffrey Rose, who's pictured here, and this seminal paper where he said that hypertension is the blood pressure value above which net benefits of antihypertensive treatment have been established from trials. And so you'd say, okay, trials, that's fairly objective. Problem is that there is some subjective differences in how you interpret the data from trials. So it does feed into some of the differences between the two guidelines in how to define hypertension. This is a commentary we published in The Lancet after the ESC guideline. This is actually before the most recent American guideline, but the blood pressure threshold for defining hypertension did not change from 2017 to 2025 in the US. And where we came to this discussion about what is hypertension, we said this is the most likely explanation that the American guideline felt that, of course, there's prognostic information, but from a Jeffrey Rose point of view, SPRINT did enroll participants with systolics over 130 and did treat to less than 130, arguably even lower. And so for that reason, that was a reasonable approach to redefine hypertension from the Jeffrey Rose perspective. At the same time, it does increase by 10, 20, even higher, depending on your age, percent the population who are overnight now diagnosed with a potential, it's an international classification of disease, it's, hypertension. And so the ESC took a more pragmatic approach. And we felt that, well, yes, SPRINT and subsequent intensive treatment trials did enroll participants over 130 systolic, but only a subset of the population who were also at high cardiovascular risk, not the entire adult population over 130. So we thought it was best to keep 140 because that's a threshold above which trials have demonstrated benefit from blood pressure lowering for everyone. So that's just a bit of insight into the differences between the two in respects to defining hypertension. With regards to out-of-office blood pressure, huge amount of similarity, and this isn't really new from the previous iteration of both of these guidelines. In the ESC on the left, we recommend out-of-office blood pressure is preferable for diagnostic and for ongoing management. Interestingly, in America, also recommending out-of-office for diagnosis with either ABPM or HPM, and likely due to a long history of not having ABPM in the US, not being reimbursed, not being widely available, to be frank, when I was training there, which is contrary to Europe, where every GP has an ABPM service in many countries, certainly in Ireland. They, in America, recommend for ongoing management, priority be given to HBPM, so home blood pressure monitoring, over ABPM. So slight differences, but generally the same. Out of office is recommended if available and possible. And that's important because we have different thresholds to define hypertension depending on an office and out of office. and we also have different thresholds for the elevated blood pressure group. And these largely align across the US and EU guidelines. Coming back a little bit to the approach to management and differences between the guidelines, similarities as well. Here we have the three categories proposed by the ESC, and you can see that we wanted to keep things simple, as I mentioned, but align this with treatment as well. And so non-elevated blood pressure patients do not need to be treated with blood pressure lowering drugs. They shouldn't be. They should maintain a healthy lifestyle. The elevated blood pressure group, it depends. Some of these patients may benefit from treatment, and that's based on trial evidence. And then certainly for confirmed hypertension, everybody, irrespective of their age, in large part, or their cardiovascular disease risk status, should be treated. And so this is a very simple categorization from the ESC perspective, which largely aligns with the American guideline as well. Why do we take this approach, and why do we want to look at patients with elevated blood pressure to see who among them may benefit from blood pressure lowering treatment? Well, one of the reasons is that about a third of all cardiovascular disease disability adjusted life years happen in patients with blood pressures in this range. So if we completely ignore them, say, okay, they're not hypertensive, no worries, you are potentially ignoring the opportunity to prevent about a third of overall cardiovascular disease events. At the same time, in the orange box, you can see that this group is quite heterogeneous. The bar chart, the colors of this bar chart are different cardiovascular disease risk levels over a 10-year risk score. And the light blue is low cardiovascular disease risk. So you can see that most of the patients who have elevated blood pressure, 3/4 or so, are in that light blue, low risk. And these patients we don't have evidence from outcomes trials that we should be treating patients with elevated blood pressure who are low cardiovascular disease risk. So most of these patients can be excluded from treatment by a risk assessment. On the other hand, for hypertension, the red box, you see a lot less of that light blue because most of these patients are high risk, certainly over a 10-year time horizon, but even more so over a longer time horizon. So that orange category of elevated blood pressure for the ESC, we need to try and identify from who amongst those may benefit from treatment. And we have a stepwise approach which is based on risk. And I'll show you what the US guideline says, very similar in many ways. The first is to assess for high-risk conditions. This is the low-hanging fruit. People who have a history of CVD, CKD. In our case, we recommend hypertension-mediated organ damage, diabetes, and FH. If you have those conditions and you have elevated blood pressure, you can go down the right-hand side of this pathway and be considered for potential treatment if after 3 months of lifestyle, the systolic blood pressure remains over 130. If you're not one of these high-risk conditions, you move to step 2 and predict 10-year risk. In Europe, we recommend the SCORE 2 models. There is a SCORE 2 Asia-Pacific, which may be relevant for your patients. And in America, of course, they recommend the more recent PREVENT equations. The thresholds for risk are slightly different, which is, I think, a little bit unfortunate, to be honest. The prior American guideline used the Poole-Cord equation, and they recommended over 10-year risk. We maintained that for SCORE 2 in our 2024 guideline, but the most recent American guideline has dropped from PCE of 10% to a PREVENT of greater than 7.5%. I'll show you that. But largely speaking, we're looking for those who have high risk by a 10-year risk equation. And if they have elevated blood pressure, according to EU ESC guideline, we'd recommend they be treated if after 3 months of lifestyle, the systolic remains over 130. Pretty much everyone else can be managed with lifestyle. There is a bit of nuance to this. This audience, probably many of the members here have done research on these various different approaches to redefining risk. And I won't get into detail on this, but we do have other risk modifiers and risk tests that you can consider for an intermediate range 10-year risk score population who have elevated blood pressure. How about the American approach? Very similar. If you have hypertension, which for them is stage 2 hypertension, so greater than 140/90, you are treated if confirmed. That's the same as the European guideline. If you're in the 130 to 139 range, which we would consider to be in the elevated blood pressure range, Americans will call that stage 1 hypertension. Again, you do a risk assessment. No different than the ESC guideline. The first step is to look at these high-risk conditions. If the patient has high-risk conditions with a blood pressure 130 to 139, then they should be treated. And then the next step is the risk assessment with the PREVENT equation. So very similar to the European approach. One difference that I was surprised a little bit about, I will say, is in the American 2025 guideline, they're now recommending that even those who are low risk, who have stage 1 hypertension, be treated if after 3 to 6 months of lifestyle the blood pressure remains over 130. And that's based on one trial, which was not an outcomes trial, it looked at blood pressure over follow-up. So a little bit provocative. I think you could argue that this is a mentality of treat now for blood pressures 130 or more, whereas ESC is a bit more of a mentality of treat later, because many of these patients will be low risk in ESC and therefore not be treated. But ultimately, many of these patients do progress to hypertension. So you can pick which one you prefer. I think the evidence is more compelling for the only treating high-risk stage 1 hypertension, or in the ESC guideline, high-risk elevated blood pressure. So how about lifestyle? Very similar across both guidelines. Both of them now give a class 2 recommendation for salt substitutes that are enriched in potassium, particularly in people who add salt to the diet. It's less effective, of course, if you're just looking at people who take salt that's in the food that they're already eating. Both guidelines recommend dietary supplementation of salt, with fruits and so on, but this is particularly for salt substitutes, class 2 in both guidelines. Both guidelines give a class 1 for aerobic and resistant exercise. There's probably an update from prior documents where the data for resistant exercise are very strong, not just for aerobic exercise. And similarly, both give recommendations for salt restriction. Slight differences between the two. ESC say less than 2 grams of sodium a day. ACCHA say the ideal is less than 1.5. Very hard to achieve that, to be fair. How about the approach to treatment? For elevated blood pressure, again, that 130 to 139 high-risk group who would be recommended for treatment by the ESC and who would be recommended for treatment by the ACCHA, it's recommended to start with monotherapy, so 130 to 139 monotherapy. In the ESC document, we also recommend monotherapy be started for hypertensive patients, so 140 or higher, who are moderate to severely frail, who have orthostatic hypertension, or older than 85. The US guideline doesn't really make that distinction. It seems to recommend treating everybody over 140. But both guidelines do say for most patients with hypertension, so that particularly non-frail, very elderly patients with hypertension, that you start with a low-dose combination. In the EU ESC guideline, you can see start with a low-dose double combination, increase to a low-dose triple, and then maximally dose triple. At any point, you can add in a beta blocker. 3 first-line meds are RAS inhibition, calcium channel blockers, and thiazide or thiazide-like diuretics. And once you're at a maximally tolerated triple dose and still not controlled, you're in the apparent resistant hypertension range. That's largely the same as what the Americans say. Americans say first line meds are the same 3 classes. Stage 2 hypertension, initiate with 2 first-line agents, ideally single pill combination, just the same as us, except this is hypertension for us. And the stage 1 hypertension, which is our elevated blood pressure, monotherapy, is reasonable. I think that, by the way, implies that you can also start with dual combination therapy, but I'm not sure. How about targets? You all know this very well, but just to revise, ESC recommend once you're on treatment to target a systolic of 120 to 129. 120 is considered the optimal point in the range if it's tolerated. We recognize that the blood pressure measured in trials often differs from the blood pressure in real practice, and trial populations don't always generalize to real practice either. So we wanted to give a little bit of wiggle room, which is this 120 to 129 range. That applies for pretty much everybody, including diabetics, CKD, as long as you're not very low EGFR, where you can individualize treatment, stroke, and cardiac disease. The ESC tried to take a simple and pragmatic approach. So we also recognize these are guidelines. These aren't rules of law from on high. Patients may not be able to tolerate this target of 120 to 129. So we also said that if they're not able to tolerate this target, or if they have advanced age, orthostasis, frailty, or limited lifespan, that we can target a blood pressure as low as reasonably achievable, the so-called ALARA principle, preferably less than 140, but we have to be pragmatic. Sometimes we can't get patients even to that target, just as low as we can get them within reason. We did emphasize in the ESC that the target really is the systolic of 120 to 129. We're not as interested in a diastolic as long as you can get the patient's systolic to 120 to 129. And we do prefer that that be confirmed with out-of-office assessment to ensure you're not over-treating the patient. And then this is a comparison of the American and the ESC guideline targets. So for America, less than 130 for all, and actually now a new update to ideally and encourage to try and target less than 120 by systematic office blood pressure measurement. Very provocative, I think, in some ways, targeting less than 120 in the office. Yes, the trials would suggest that's the way to go, but applying trials to clinical practice, there's a little nuance there. This is provocative in my view, but both recommend less than 130. We recommend 120 to 129 and state that evidence suggests that 120 is the optimal point in the range. And that's based on these trials, which I don't have time to go into. I would probably give, by the way, a green for ACCORD, but we can have a conversation about that later. That's just my own opinion. This is from a figure adapted from another paper. How about treating resistant hypertension? This is the ESC approach. Fairly straightforward, no major surprises, I would argue here. If the patient's on 3 or more medicines, including a diuretic, they have apparent treatment-resistant hypertension, you want to assess for adherence and so on and so forth, rule out secondary hypertension. If they have true resistant hypertension, then fourth-line treatment would be mineralocorticoid receptor antagonist, spironolactone, or if not tolerated, a eplerenone. If they aren't already on a beta blocker at this point, beta blocker is very reasonable to add on at that point because beta blockers are effective at lowering blood pressure. That's not the reason they're not first-line med in the 2024 ESC guideline, nor were they in the 2018 ESC-ESH guideline, a first-line med. But they can be added here if they haven't already been added for compelling indication. Then you're talking about somebody who's really challenging to manage, and these patients, many of them are in the hypertension clinics like the ones that I run every Wednesday. And so we have choices to make for these patients, as you all know. We can add in intensified pharmacologic therapy with agents that lower blood pressure but maybe have less evidence for cardiovascular disease efficacy. And now we thankfully have an alternative option, which is renal denervation. And the ESC gave a Class 2B recommendation for renal denervation, which is the exact same as the American recommendation. So both guidelines came on as Class 2B. In fairness, that's probably the weakest recommendation you can give something, but it is a recommendation nonetheless. Slight differences, nuance between the ESC-HA with regards to resistant hypertension. It's interesting, the ACC-HA defined resistant hypertension as a blood pressure over 130, over 80 on 3 hypertensive meds. So you're talking about a lot more resistant hypertension in America than in Europe because it's a very different definition. Besides that, everything else is the same. There's one caveat that is based on the FDA approval on the back of the Precision trial, and this is not available in Europe, so we don't have it in our guideline. You can consider a dual endothelin receptor antagonist as one of the options for pharmacologic treatment for resistant hypertension. Okay, wanted to stop a minute here and just mention this, and that is screening for primary aldosteronism. I have a resistant hypertension clinic that I run with an endocrinologist and a nephrologist every Wednesday. I think this is really important. We see a lot of this in our resistant hypertension clinic, and the more you look, the more you find. Both guidelines on the ESC on the left and the ACC-HA on the right now recommend screening for primary allosteronism in all patients with blood pressures over 140/90. This is not talking about people with stigmata, let's say, of secondary hypertension, so hypoclemia, the usual indications for a secondary workup, young patient, very, very resistant patient, so on and so forth. This is everybody over 140/90. Now, it's a class 2 recommendation in both guidelines, so not the strongest recommendation, but it's certainly a change from prior guidelines in both sides of the Atlantic. I think this is provocative. Neither guideline require you to stop interfering meds to do initial screen, and endocrine guidelines have been recommending this as a class 1 recommendation for years, so it just shows you the different mindsets between specialties. We in cardiology have been maybe a little bit more uncomfortable measuring renin-aldosterone ratios on patients who are on interfering medicines, but this is now something that we all need to start learning if we don't know already how to interpret aldosterone-renin ratios in patients who are on interfering medicines. And I'd be happy to talk to you offline about that if that's something you would be interested in, but you can find the information in the guideline. But it's very important, I think, now that we all have an understanding of how to interpret ARR testing depending on certain medicines that patients may be taking at baseline. Some patients, we do need to stop interfering meds based on their first screen to get a confirmatory diagnosis using a clean screen, but there are many patients who we can make a diagnosis on interfering meds, and we need to learn how to do that if you don't know how to do it. And then the approach to multidisciplinary care. I think this is also very important. Whether or not guidelines will impact on clinical practice in relation to these recommendations, I think remains to be determined. We also have to acknowledge that, unfortunately, guidelines have a checkered past of implementation and appropriate implementation in terms of targets and detection and so on and so forth. But part of the reason for that is that there's too many people with hypertension and there's too few physicians to manage them. And physicians who are seeing patients, myself included, general cardiology clinic, we're often dealing with more pressing issues, acute issues, ongoing symptoms, chest pain, heart failure, so on and so forth. And the blood pressure can sometimes be left, unfortunately, to last and never get addressed in the clinic because of competing time and other issues. And so I think we need to democratize the approach to treating hypertension. I would argue that the trial evidence, and there are randomized trials of this approach, are quite compelling, and it's not just one or two trials, it's multiple trials showing that when you democratize the approach to managing blood pressure, i.e. you involve non-physician healthcare workers in the management of routine hypertension, generally speaking that's under collaborative practice agreements. Obviously every country is different with regards to regulation for prescriptions from non-physicians, but most modern countries are moving in the direction of allowing non-physician nurse practitioners, clinician assistants, and so on to prescribe under supervision of a clinician or physician. And for the reason that that's something that is now available in most countries, and because of the trial data showing efficacy in both blood pressure lowering and in reducing cardiovascular disease events, the ESC, for the first time, I believe, gave a class 1 recommendation, 1A, to multidisciplinary approaches to managing patients with elevated blood pressure and hypertension, including appropriate and safe task shifting away from physicians. That's somewhat provocative to say. This is from a group of largely physicians. And similarly, in the recent 2025 ACC-AHA guideline, they also recommend for adults with uncontrolled hypertension, so not elevated blood pressure, but again, that's arguably the same thing because it's both over 130. A team-based approach is recommended to achieve and maintain blood pressure control. And when you look at the document, what they mean by a team-based approach, it's very much a similar concept as multidisciplinary approach, including task shifting away from physicians. So I'll summarize here, and this is a viewpoint that we were asked to submit to Jack. The focus issue on the blood pressure guideline was out last week, and I would argue that, and this is true, I think, not just of DSC, but also of other European guidelines, the ESH guideline, and many of the Asian guidelines, that there's now convergence of opinion, a general agreement that's a better situation than we had historically. We still need to probably think more about how to make these guidelines more unified, but there are so many similarities now between the guidelines that I think that's a good thing. Big difference would be the hypertension diagnosis, whether or not that's something that a conversation that needs to be had at an international level, that we can get agreement on this. I think that might be worthwhile. But right now there is still a difference between Europe and many Asian countries and America with regards to defining hypertension. So that's still work that needs to be done. But with regards to out of office, I would say a lot of agreement, both sides of the Atlantic and around the world, with regard to out of office for measurement, for detection, and for management of hypertension. Everybody over 140, if it's confirmed, so anybody over 140, over 90 should be treated, irrespective of cardiovascular disease risk. In large part, the ESC and the ACHA agree that you should treat all patients, even if they're old, even above 80, as long as they can tolerate treatment. Then for the elevated blood pressure group or stage 1 hypertension group, it's a risk-based approach. Guidelines are slightly different, but ultimately very similar. You do a risk assessment for most patients. A little difference now with the ACCHA also recommending treatment of low-risk patients with blood pressures 130 to 139, but after 3 to 6 months of lifestyle. And arguably now the targets are very, very similar. 120 to 129 in Europe, less than 130 in America. 120 is optimal in Europe, less than 120 is optimal in America. So I think there's general agreement, lots of consistency between the guidelines, and I think that's a good thing. We need a little bit more in the future, but I'll finish there and thank you very much.
Thank you, Professor McAvoy. This is a plenary lecture, so there's no question and answers chance. I think it's really, really good for the understanding and inspiration for the direction of our guideline for the future. Thank you. Thank you. I will close this session. Thank you very much.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Good afternoon, ladies and gentlemen. This is a luncheon symposium entitled Cough-Free BP Monitoring Opportunities and Clinical Perspective, which is kindly sponsored by SkyRab. I'm Sang Nim from Catholic University of Korea. As we know, the field of blood pressure monitoring is undergoing a paradigm shift, moving from traditional cup-based device toward continuous, convenient, and non-invasive technique. So today we are privileged to have two distinguished speakers. Now I would like to introduce the first speaker, Professor Gianfranco Palati from Italy. As you know, he is a world-renowned expert in hypertension and cardiovascular medicine. He is now honorary professor of cardiovascular medicine, Department of Medicine and Surgery, University of Milano Bicocca. Now he is president of World Hypertension League. Especially Professor Palati has made outstanding contribution to ambulatory blood pressure monitoring. He will share his insight on cough-free blood pressure monitoring opportunities and clinical perspective. Professor Palati, please. Welcome, Professor Palati, with applause.
Good afternoon, everybody. Thank you for the introduction. I'm really very grateful to the Korean Society of Hypertension for the invitation to be here and to Skylabs for supporting my presence. I'm very happy also to have some time to discuss with you an important issue, which is related to how we can diagnose hypertension better. These are my disclosures. And let me just start with a very recent WHO report on hypertension, where there is a clear evidence that hypertension remains a major global public health threat. We have 1.4 billion people with hypertension in the world, and only 320 million are controlled, which means a very high risk of cardiovascular disease and cardiovascular events, as you know very well, with a lot of social, economical implications. And the high prevalence means that we need a stronger prevention effort. But at the same time, the high number of people uncontrolled means that we need to do better, starting from diagnosis and then going to management. You've been listening before, the nice lecture of Professor McVoy on the guidelines. There is a lot of work to be done. And definitely Korea is doing something fantastic. In the WHO report, there is a clear evidence that you were increasing treatment rates, control rates, reduction in sodium consumption, and cardiovascular disease. And this has been done through many different interventions, including a better blood pressure monitoring. Indeed, if you don't measure blood pressure accurately, all our discussion on hypertension control remains worthless. This is blood pressure. Basically, as you can see, is not a number, it's a series of waves, and which implies that blood pressure is dynamic. This is our position paper published a few years ago on blood pressure variability, where we were classifying blood pressure changes in different types depending on the time window. And you see that we go from the within beat variability to the very short term beat by beat, the short term within the 24 hours, the day by day, and the long-term seasonal or visit-to-visit variability, which requires blood pressure measurement with different methods, and this can be a methodological issue. Indeed, we need to improve the technology for blood pressure monitoring to face the complexity of blood pressure behavior. And here is an example where possibly cuffless blood pressure monitoring might be a very interesting perspective. I will try to touch with you these 4 points. First of all, why are we unhappy with the conventional cuff-based monitoring? Then, just very briefly, how do cuffless devices estimate blood pressure? Why they are so attractive, but also, honestly, why we still need more evidence before recommending them in clinical practice. So starting from the basics, why we are unhappy with the cuff-based monitoring. Well, we have several possibilities. The classic office approach, which has been changing from the time of Rivarocci in Italy, 1896 was introducing the sphygmomanometer. Now we are not longer using the mercury, but the technique is very similar. We are using the oscillometric approach. And then we have the same approach for the home blood pressure and for the ambulatory blood pressure, all based on cuff measurements with different frequency, which can provide a different perspective on blood pressure behavior. What are the limitations? Well, there are many. First of all, we only have intermittent measurement, which means you cannot identify the fast changes, daily life challenges. That's a typical example. There's a nocturnal recording. The red line is a continuous recording of blood pressure, and these are 4 blood pressure peaks due to obstructive sleep apnea. If you're using an ABPM with measurement every 30 minutes, the black dots, you can identify only one of these 4 blood pressure peaks. The other cannot be seen because the frequency of measurement is not high enough. Other problems are related to the use of the cuff itself, can introduce an error, and it may also be disturbing the patient during the day and the night. The auscultatory readings might be affected by bias and DG preference, as you know very well. But even if you're using the oscillometric reading, you might face errors, in particular in case of arrhythmias. And finally, the cuff measurement itself might disturb the patient, interfering with the measurement during the day, the Wycott effect, or during the night. There's another example during night. You see that the cuff inflation is responsible for an arousal up here, and after a few seconds you have an increase in systolic and diastolic blood pressure measured continuously. And the error can be as big as 30 millimeters of mercury in this case. And this was a German study. On average, due to the cuff inflation, there was a change in pressure up to 24 millimeters of mercury, which is not trivial. Other problems are the point that if you are using isolated cuff-based readings, you cannot account for blood pressure variability. That's one of our intra-arterial recordings. You see clearly that a spot measurement with the cuff is absolutely unable to give you a precise assessment of the burden on the cardiovascular system due to the continuous fluctuations in blood pressure. And that's important. In our paper, we're highlighting that the different types of blood pressure variability I was mentioning before have all been shown by many studies to be associated with an increase in organ damage, cardiovascular events, cardiovascular and all-cause mortality. So all these changes mean something, and we need to quantify them better. That's probably the first paper ever that was showing the clinical value of blood pressure variability. I published this paper when I was a much younger doctor. Unfortunately, I'm getting older. But at that time, we were using intra-arterial ambulatory blood pressure. It was the only technique available. And we divided our patient in quintiles of mean blood pressure. For each quintile with the same mean pressure, we have 2 subgroups, the yellow and the red, with a lower or higher blood pressure variability respective. The lower panel refers to the organ damage quantified by a score, and you see that for any given mean blood pressure level, those with a higher variability, the red bars, have a greater organ damage score, which means that variability is independently contributing to cardiovascular damage for the same mean blood pressure levels. Many other studies show the same with the ambulatory blood pressure variability, but also when considering home blood pressure. That's a nice study by Dr. Yoshida and co-workers. You see that those in the highest quartile of home blood pressure variability at a higher rate of cardiovascular events. The same applies also to the visit-to-visit variability. These are data from Peter Rothwell in his retrospective analysis of the Ascot trial. And you see again that those with an increased visit-to-visit variability has a higher risk of stroke, coronary events, and cardiovascular events in general. So blood pressure variability is important, and you need to quantify this, but the different blood pressure measurements don't give us the same assessment. That's a nice Finnish study showing that when you consider the blood pressure levels obtained with different techniques, the ability to predict outcome is different. The office pressure is the weakest predictor. Then we have the daytime, the office, the 24-hour, and the best prediction is nighttime blood pressure. The same for diastolic values. Nighttime and 24-hour pressure are the best predictors, but these are still based on cuff readings with all the problems I was mentioning before. And these limitations include the fact that the highly accurate and validated devices are not always available in all countries, mainly in low-resource settings. So we need better solutions, no doubt. So the cuffless can be a solution, but how do they work? Well, we have different types of wearable devices. Some are cuff-based, some are cuffless. We might have some devices with the incomplete compression, that the Peñas method implemented in the Finapress and the Portapress device that we validated against intra-arterial line many years ago, which is very sensitive and very accurate in monitoring blood pressure changes, but is also quite expensive and difficult to use. Or this is a tool for research, but not a tool for a clinical application. Then we have other wearables with a cuff-based measurement. Some watches, including the Omron Heart Guide, the Huawei Watch D2, and the EBP Doctor Pro, are all watches measuring blood pressure with a little cuff in the bracelet. So they are not cuffless, but they are wearables, and they can help in some conditions, but still based on the cuff inflation. And finally, we have the cuffless, which are using different technologies, PPG, photoplethysmography in a smartphone application, optical imaging technique, ultrasound or volume control to provide us information. That's a paper we published within the ESH, tried to provide some information on how these devices might work. As you see, there are different techniques picking up physiological signal in different ways, either by assessing the pulse transit time or through the pulse wave analysis, or using a facial video processing to see changes in microcirculation, or some kind of oscillometric pressing on the phone, ultrasound or volume control. All these devices might need a calibration through a cuff inflation, or sometimes using demographic data, while some of them don't even ask for calibration, which is opening the question how they estimate blood pressure accurately. Basically, they work in a simple manner, in a way they are sensors picking up physiologic variables. These physiologic variables are quantified. This is not blood pressure. These are physiologic variables, including the velocity of the pulse, the amplitude of the pulse, or some other changes in volume or imaging. You need then a calibration on these physiologic signal, and then through artificial intelligence, you may derive an estimation of blood pressure values, and also an estimation of the blood pressure changes over time. So blood pressure is not measured, it's calculated. Basically, the same is done with the ring by Skylabs. It's doing the same to the PPG signal analysis. You derive a pulse wave analysis, you put a calibration on it through artificial intelligence, you derive blood pressure values. This is a very delicate process, and this is where we need a lot of validation study and research. Basically, why are they so attractive then? Well, you can well imagine they provide us with the ability to detect fast changes in daily life during sleep or during wake without any interference with the subject behavior in a real life setting. This is a dream for us because this is what we need to improve our hypertension management. They avoid cuffs and all the cuffs-related issues, including errors, interference with the life, disturbance with sleep, and all the inconveniences I was showing you before. And then theoretically, they might give us information on the circadian blood pressure changes, on short-term blood pressure variability, allowing a more accurate diagnosis of the blood pressure phenotypes during daily life. If you compare the user comfort and the measurement frequency, definitely the worst possible position is the classic office readings. You have very few measurements in a situation which is not reflecting daily life, and you cannot pick up what I call them mass hypertension. You might do something better with the home blood pressure, which is very useful in a clinical setting. But again, you remain on the left side of the graph because you don't have so many measurements available. ABPM gives you more measurements, but is still based on cuff inflation and might give you some inconveniences due to the interference with daily life. So in this setting, obviously, cuffless monitoring could represent a solution because you have much more data available in a much easier way with less discomfort for the patient. Of course, theoretically, the promise that this might give us better diagnosis and more accurate identification of daily life blood pressure changes. That's an example taken from the database used with the Skylab's Ring device, where you, based on their preliminary data, seems to be able to identify the changes during sleep and during wake, which is one of the key issues here, without any need of cuff inflation. Of course, these data need to be validated against a reference to provide a solid demonstration of their accuracy in daily life. And that's the last point. If this is so attractive, then why the guidelines do not recommend it? As you know, all guidelines at the moment are not yet recommending cuffless monitoring. I'll try to give you an explanation. Well, there are several pending issues. First of all, we need to understand how to use them. You are not in a standardized condition. You pick up a value in daily life, but you need to understand when this should be used and what are the threshold values to diagnose hypertension. All the guidelines give you a threshold for standardized measurements, with the exception of ABPM, which is based on outcome evidence. But we don't have any data yet for the cuffless. We also need to interpret the values in different behavioral conditions, maybe exercise, sleep, work, family issues, whatever, and in particular during the night, how can we interpret the values we obtain? We have to account for the position of the sensor. We need also to, that's important, avoid any neurotic use by our patient. They already do this with the home blood pressure sometimes, which is something we don't want to see. Might be even more easy with a wearable device. People can get measuring continuously without a need. But importantly, we need a multidisciplinary approach now to improve the quality and the usability of these devices. And most importantly, we need to provide an answer to the question, how accurate are they? And that's the point. We need to learn how to validate wearables. We cannot use the classic protocol design for the cuff-based measurement because these are based on static readings at rest. We need a validation that might include the ability of these devices to track changes. Well, there were several proposals for validation. The IEEE started with a comparison, again, the auscultatory method, just to give you some idea under some blood pressure changes. The ISO-3 was focusing on the continuous cuffless recordings, asking to use the intra-arterial approach for comparison and validation. And in DSH, we provided a protocol to check the changes induced by some stimulations against a reference value. And now we are preparing a new ISO-7, which is on the way, might be ready next year, to give us more indications. That's the ESH protocol, where we are recommending to test the cuffless devices at rest, after moving the sensor, after taking a pill to see what the treatment effect is and how you can detect it, comparing day and night against ABPM, using exercise to induce blood pressure changes, and finally, to test what happens after a calibration. Very few companies have done this so far. So we need this information is not yet available. An example, the Actia bracelet from Switzerland is already on the market, but you see it's not accurate. If you see the ability to follow the day-night changes, the blue line is the classic ABPM, that's the Actia bracelet is unable to pick up the dipping. You give a pill, you want to see a change in pressure. With treatment, you can pick up the change, the blue line, with the conventional method. The Actia bracelet is unable to give you this information, so you have to be very careful with these devices. And this is an example how something on the market is not accurate at all. Well, the Skylab's ring is under testing. They started with the classic validation protocol, which is not ideal for the cuffless, but is a starting point. And now they're implementing also the ESH protocol, and some preliminary data seems to show that this device is really able to follow day-night changes, but we need, of course, to see more consistent data coming, but it's very promising here. So just to conclude, what can be then a take-home message at the moment? Certainly, the blood pressure measurement by wearables is a fast-growing and promising field with novel technologies. The wearable cuffless approaches have to face specific accuracy issues different from those that we are facing with the classic cuff-based measurement, and we need to develop accuracy standards based on specific protocols that might test these devices in the conditions in which they have to be used. Their clinical usefulness to be tested in healthy people and in hypertensive patients. And last but not least, we need to also care about regulatory policies, also concerning patient privacy, which is still an unresolved issue. Until these questions have been answered, the guidelines are not recommending cuffless devices, but as you can see, we have a future waiting because they might give us a better strategy to approach the patient, not only study readings, but checking the variability. You can adapt treatment to the changes, which is not done commonly. You can also consider the way to buffer variability as a target, because you can measure it with these approaches, and you can then implement your preventing strategies. So hypertension is a killer. It's still a problem in the world. We need to improve hypertension control, also implementing better technologies. And this requires for us more research to remove the barriers against digital health implementation, to ensure delivery high-quality devices, and to properly develop and validate cuffless technologies. Thank you again for the invitation and for your patience.
Thank you for excellent talk. So he give us, we don't need any question, and because our this session is a luncheon symposium, because many people enjoy the meal. Let's move next talk. Second speaker is Professor Jiwoon Kim. He graduated from Sungkyunkwan University School of Medicine. He is research interests are cardiovascular imaging and cardiovascular hemodynamics. So he's now clinical associate professor, Division of Cardiology, Sungkyunkwan University. Today's his talk, clinical validation of ring-type cuffless BP monitoring in Korea. Dr. Kim, please.
Thank you for introduction. I am Jiwoon Kim in Samsung Medical Center. Actually, I am an imaging cardiologist, and I'm so honored to have Dr. Paranti, who is here with us today as a member of Committee of ESH recommendations for cuffless device. So today I will talk about the clinical validation of a ring-type cuffless blood pressure monitor in Korea for CART BP. So the conventional cuff-based device is a standard for that's a new way of using the cuffless device. So in PubMed research, there is a growing interest in cuffless blood pressure monitoring. There are several methods to measure blood pressure without the cuff, and most of the wrist or finger-worn devices use the photoplethysmography like this. Today I will talk about the CART BP Pro, the ring type blood pressure monitoring device without cough inflation, no interruption of daily life, and no specific action for the patients. So it approved the blood pressure monitor, oxygen saturation, atrial fibrillation detection from the Korean FDA. So there are more than 100,000 cases to prescribe CART BP Pro in Korea. So this is a ring-type cuffless blood pressure monitor, estimates blood pressure using photoplethysmography signals like saturation, analyzed with deep learning. So the algorithm, the deep learning algorithm was developed using more than 4,000 of subjects from a tertiary center in Korea, the Seoul University. So this is amazing, you know. You can see the CART BP Pro based blood pressure mimics the intraarterial pressure because it was structured and validated from the intraoperative patients with A-line. But I heard that Skylabs, a member of Skylabs, have been shocked because of these recommendations. This is so strict to control the quality of cuffless devices. So it requires 6 specific validation tests: the static test, or typical accuracy test, and device position test, and treatment test, which reflects the blood pressure drops, and awake and asleep test, maybe for detection of the masked hypertension, and exercise test, which reflects the blood pressure increase after daily life, and finally, the recalibration test immediately before next calibration that is provided the manufacturer. Very, very strict, I think. So it requires less than 5 millimeter mercury, the difference between the reference and the specific device with specific standard deviation, and requires at least 35 subjects for each test. So we performed the static test first because it is a typical accuracy test. We compared the CART BP Pro based blood pressure with standard auscultatory methods from 2 members. Last year, we published this data in Journal of Korean Medical Science, and with 89 subjects, with 53% of female, 20% on hypertension treatment, and 13% with dark skin. In this study, interestingly, there was only 0.1 or 0.2 mean differences between the auscultatory method and the ring-type device. It's very similar, and it passed the ISO criteria and also the ESH criteria. So it is very accurate. In this Bland-Altman plots, the 95% limit of agreement was like this. It is very acceptable. As you know, in the commercial devices, this is ranged from -15 to +15 on average, I think. So it also passed the specific criteria. And very high correlation. The correlation coefficient was 94 for systolic blood pressure and 95 for diastolic blood pressure. And subgroup analysis also showed consistent accuracies across the age, sex, body mass index, and skin color. So it's good. After this study, there have been so many prescriptions in Korea. But this is somewhat become a problem because, as an example, for a wrist device with a maximal lowering of the arm, there may be a 40 millimeter mercury higher than the central BP in local blood pressure because of this hydrostatic effect by the gravity, according to the distance between the wrist and heart. So many devices will have problems to pass this test. And we performed this test and have results. The procedure was comparing the reference blood pressure and device blood pressure with at least 20 centimeters distance from the heart. So we measured the blood pressure at this position and also at this position. And there were 35 patients in this position test to meet ESH criteria. The average age was 46, and about 50% were male. This is a main result. With more than 20 centimeters hand lowering, the ring device maintained agreement with double auscultation, but the mean bias was less than 1 millimeter mercury. So it met the ISO and ESH criteria. There is no study like this so far, but maybe some devices will pass this criteria, but it is very strict, I think. So patients can be free from their position to estimate their blood pressure during the daily life with this ring-type device. This is blend Altman plot, and there was acceptable limit of agreement, similar with a static test. Also, there was a very high and strong correlation between the reference and the ring-type device-based blood pressures with lowering the arm. So this is another validation study using the ambulatory blood pressure monitoring, which was published in Korean Circulation Journal. The mean bias between the ambulatory blood pressure monitoring and Cart BP Pro there was -3.4. It's also good and met the specific criteria. And the main interest in this study is not just this accuracy. The main interest is whether the specific wearable device can track the blood pressure changes from the day and night. So this is the changes between the daytime and nighttime blood pressures, comparing the ambulatory blood pressure monitoring and Cart BP. The PASS criteria is correlation coefficient more than 0.7, so it met the specific criteria. It is fair. However, the ESH recommendations requires the sample size and the blood pressure distribution and the calibration timing. So to meet this criteria, another study was performed, and it will be published. And this test, 35 patients were enrolled, which is required by the committee. And the mean age was 53, and 49% were female, and 37% patients have hypertension, and 70% of patients was on treatment. This is the result, and the difference between the awake and asleep was like this. This is the compare between the reference and the Cart BP Pro based blood pressures. So it met the specific criteria less than 5 millimeter mercury of mean and less than 8 millimeter mercury for the standard deviation. So this is the correlation coefficient, which also met the specific criteria. the limit of agreement was also similar with the previous study, including the static and hydrostatic study. So the ring type device is very user comfortable. No need to keep the arm strictly on heart level, so they can be free from their daily activity. So it maintains accuracy even with frequent arm position changes during daily activities, making it suitable for ambulatory blood pressure monitoring and home monitoring. And it also showed accuracy to track the blood pressure during the sleep. So transition from intermittent cuff-based to continuous cuffless measurement marks a major step forward. However, we need the outcome study and comparing the results between and after the treatment. So this is just the first step to pass the criteria to use for the medical purpose. And the CART-BP Pro meets the recent ESH strict criteria in both static and positional and awake sleep feasibility tests. And the another tests are ongoing to meet the remaining criteria. So I have no stocks, I'm not a member of the Skylabs. I'm just a researcher. But I think this is very accurate device, and I will use this after entering into our institution. So again, it's my honor to have Dr. Bharati here, who makes these strict criteria. Thank you for the attention.
Thank you very much for excellent talk regarding so many data of the CART-BP devices. So I believe today's session will provide valuable insight into the cuffless device, especially CART-BP. I would like to close this session. I'd like two speakers, especially Professor Bharati and Professor Kim, and all audience and Skylab. Thank you very much. Enjoy the meal.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Good afternoon. We'll start this session. This is Gu Young-jo from Seoul National University. I'm pleased to my co-chair, Professor Seung-gi Ryu, who is professor of Ihai University. The theme of this session is Smart Hypertension Care, AI, Big Data, and Digital-omics. I will introduce the first two speakers, and Professor Yu introduced the remaining speaker and organized panel discussion at the end of this session. It's my honor to introduce the first speaker, Yu-King Chang, who is professor of cardiovascular medicine, Department Cardiology, Huai Hospital. He is currently deputy editor in Journal of Clinical Hypertension. He will talk about AI and blood pressure measurement. Please.
Thank you, Mr. Chairman. I also want to thank the organizers to inviting me to here to attend the fantastic meeting of Korean Society of Hypertension. So my topic today is about the artificial intelligence and the blood pressure measurement. As Professor Parati just talked about, the blood pressure measurement, artificial intelligence have been involved in during the past few decades, and also we can find the evolution of blood pressure measurement during the past maybe more than 100 years that we used this mercury speedometer in the 19th century and also in the 20th century. Maybe 100 years, and also oscillometric devices has also been developed in the 1960s, and it was also very well used in the nowadays clinical practice. But also in the current situation, we have many new devices. We use the cough devices, but many situations we would like to many patients or individuals would like to use the non-invasive and also coughless devices to have their blood pressure measurement. But nevertheless, still we have big problems in using these kind of new devices. But also in the nowadays clinical research, artificial intelligence is now widely used in the management of chronic diseases. It's very successful in the imaging tests and also in the chronic conditions, provide some more information for the more accurate or more efficient management of these kind of diseases, especially in hypertension. Also, many data has shown that maybe telemedicine and artificial intelligence also very well played an important role in nowadays clinical practice. You have also omics, many omics today, and genomics and metaomics, and also in digital omics. It's a kind of a new novel concept that integrates multimodal information with digitalized physiological data, medical imaging, environmental data, and electronic health record, and also even environmental record and the biometric data from wearables. There's also a lot of devices are now available. But as for the blood pressure measurement devices, and in nowadays clinical practice, we still follow a basic concept of the measurement of blood pressure based on cough, because we have to inflate the cough and make the blood pressure, make the flow reduced, and can stop the blood flow in the arteries, and then deflate. And we have the cortical sound to hear to know the systolic blood pressure and also the diastolic blood pressure. And later we know that even in the oscillometric devices also follow a similar mechanism in the measurement of blood pressure is based on the cough devices. So whatever in the upper arm cough or even in the wrist cough is also very very popular and widely used during the past few decades, but also now quite available. A lot of new devices have been available in the nowadays clinical market. That's in the market, but still not in the quite. Only a few devices is now in the clinical practice, which are approved by the maybe FDA and the European administrations. But these devices also have some problems because they also have, which have also been indicated by the Professor Parati in his last talk. We also know that we have this very popular device here in CART BP. I used that in the past few years. I think it's accurate in the static position I was asleep. I found it's very accurate, very accurate blood pressure, very my blood pressure quite normal, but when I was get up and then find my blood pressure rise, but it's also maybe morning surge or some kind of like that. But also new devices, so new technologies has been developed to measure blood pressure. All are when we say measure blood pressure, because it's just something like to using transdermal optical imaging technology to have some images or even some videos and show that our faces to may calculate the blood pressure of our blood pressure. It's a very interesting techniques, but still, is it valuable? Is it accurate? That's the big problem for nowadays clinical practice. But also the current devices developed maybe based on the PPT or PSG technologies, which is quite reasonable to measure blood pressure, because the blood pressure level is correlated very well with the possible velocity, and also have a lot of devices nowadays in nowadays clinical practice. But still, there's some big problem because it's been tested a lot. Also have been developed in new devices using different kinds of technologies, such as something like a bioimpedance measurement system for blood pressure monitoring. Some devices have been improved based on the using different kinds of materials in order to get full longer length of artery to measure the changes of pulse velocity and PTT, and also maybe have a very relatively improved calculation on the blood pressure level, so as to also the bioimpedance measurement with altering the current of flowing through external extralos in the vertical structure, in the horizontal structure, so as to calculate the volume of blood flow, and also the test on the speed of the artery stiffness, artery transition. So there are a lot of improvement and this kind of technologies, and also have a lot of tests, validation tests also have been done using these kind of devices. It's also shown that this kind of devices are relatively accurate in subjects with normal blood pressure, but they sometimes not quite accurate in those subjects with higher blood pressure, which means the patient with higher blood pressure than more than 1/3, 140 or 150 mercury, which means that we can only use these kind of devices in the patients with normal blood pressure, but not in the high patient with in the too low or very high blood pressure. So in the many kind of study consistently shown that this measurement device with using PPG only devices can be shown can have shown the acceptable measurement accuracy only in the normotensive categories. It indicates that future development of this kind of devices is needed. That's the devices some years ago, but also there are some new normal blood pressure monitoring devices have been developed. Many kinds using CAR type multi-parameter detector based on PTT, and technology measure bleeding oxygen saturation, and also blood pressure, and using ECG waveform and heart rate, and also PTT test to test the PWV and PPT, so as to calculate the devices, and also ultrasound blood pressure detector also have been utilized in the current development of devices. And also some devices have also been tested in the younger subjects. Also some paper have been published in some journals in patient with subjects with in children and adolescents. That's very interesting, but still face some difficulties. Also, as QSmart technology, QSmart technology includes small sensors, softwares, and also try to improve this kind of technologies to have so as to get some implantable sensors that allow to implant into a patient's artery, very minor outpatient procedure, and also have the continuous, accurate medical grade waveform blood pressure data to be automatically collected, such as continuous blood pressure measurement, but it has to be one of the implantable devices. The big problem is that maybe for research purpose it's fine, but for clinical practice it's maybe not quite practical. It's just indicated by Professor Parati. And the skin, there are also some improvement or some new inventions on the new flexible skin adaptive focus flexible micro machine ultrasound transducers, improve the patch so as that made non-invasive skin invasive tract the bead to bead diameters changes of an artery to reconstruct the high fidelity blood pressure waveforms. It also seems to be accurate during the static phase, which means that the standard deviation is quite low, only less than 2-3 millimeters in systolic and 2.5 millimeters in diastolic, but still in the static point of view. Also, there are some fully variable ultrasound devices to monitor deep tissues in moving subjects. So this kind of thing that into using onboard AI algorithm to can autonomously track the target artery during the patient's movement. Also using the smartphone applications to display the data from the ultrasound devices. That's the improvement in the movement situation. And also there's many kinds of devices that have been developed. Also similar cuffless blood pressure estimation. That's something we have to consider that the current blood pressure measurement of cuffless devices not only maybe not measure, but also to calculate or estimate blood pressure, not directly measure the blood pressure. Though there are many limitations in nowadays development of kind of confidence devices, because we know that we have to follow a very complex validation process, which was indicated by the European Society of Hypertension. And also the measurement accuracy is also a big problem, because only in static situations we know that maybe correlate very well with the standard measurement of blood pressure using oscillometric devices or mercury devices. But the problem is that if we know that there are many differences, significant differences between the routine office blood pressure measurement and even unattended office blood pressure measurement, with no nurse or doctors appears in the clinic, their blood pressure, the patient blood pressure may be lower than that in the presence of nurses or doctors, which makes the clinical judgment more quite different. So based on this condition, that if we use the this kind of cuffless devices at night, we can find that maybe not disturbed by the cuff devices, which is usually used in the nowadays ABPM, maybe because that the threshold of the definition of hypertension is relatively maybe different than that of using normal cuff devices. So that's also some other defects in using that. That's why the European Society of Hypertension indicate that we should not use, for this reason, at present time, that cuffless devices should not be used in the diagnosis or management of hypertension in clinical practice. And even special conditions, special validations are required for cuffless devices, just indicated by Gianfranco's lecture. You can find we have to follow the static test, the device position test, treatment test, and also awake test, using exercise tests. And we know that the CART BP is going through many kinds of these tests, but still some studies still underway. And also, it should also emphasize that the International Society of Hypertension, also ESH, and the other societies also indicate that in clinical practice, this will be very promising thing to use the optimal to optimize blood pressure management in future clinical practice. It's optimal, but we need some time to improve that. Thank you. Thank you very much.
Thank you very much for your informative lecture. We'll move next speaker. Next speaker is Seung-Chan Yu, who is a Translational Research Professor, Department of Preventive Medicine, Yonsei University. He'll talk about leveraging AI in prediction management of hypertension. Please.
Thanks for a kind introduction, and good afternoon, everyone. Today I will be discussing about how we can leverage AI in prediction and management of our hypertension. I'm Seung-Chan Yu from Yonsei University College of Medicine. This is my disclosure. So artificial intelligence means machine stimulates human intelligence to enable machines to learn, reason, and make decisions. And AI have evolved from basic algorithms in the 1950s to today's sophisticated generative AI system. But it is really hard to define artificial intelligence because we do not know the human intelligence is. So because there is no very clear definition for human intelligence, there is no clear definition for artificial intelligence. So today's presentation will be focusing on more machine learning, because machine learning is a subset of artificial intelligence focused on algorithms that can learn the patterns of training data and subsequently make accurate inference about the new data set. So what can we do with the AI in prediction and management of hypertension? We can predict development of hypertension, predict blood pressure, measure blood pressure, predict cardiovascular risk in hypertensive patients, and refine blood pressure targets. I will introduce some of the studies about these fields, and then I will address the gaps in advance or the challenges we have. So in this study, using more than 1 million patients, the researchers extracted some of the predictors such as type 2 diabetes, lipid disorders, CVD, or social determinants from EHR data, and used XGBoost, one of the technique of machine learning, to predict 1-year incident hypertension risk among these patients. And then they found that machine learning can stratify the risk of the incident hypertension among these patients. Another study shows that when they use the genetic data of patients, they can develop some logistic regression or machine learning with support vector machines to predict incident hypertension. But they found that the performance of support vector machine or machine learnings were comparable to the performance of logistic regressions, and then adding more genetic expression did not increase the performance of the prediction. About predicting blood pressure, this is a study using UK Biobank and IPEX with fundus photographs, and then they developed a deep learning model to predict systolic blood pressure as well as diastolic blood pressure with absolute error of 11 and 6 millimeter mercury. It can be used as a potential screening tool during routine eye exams. You can screen the hypertensive patients by using these fundus photographs. The measuring blood pressure is very extensively covered by the previous lecture, so I'd like to skip this. So later, we can predict cardiovascular risk in hypertensive patients. This study developed a machine learning model to predict CVD risk by using MESA studies population, and then they validated this model on Flamingo study. And then they found that machine learning achieved much higher AUC, which is 0.9, which compared to 0.7 of ACC-AH calculator. At the time, it was pulled cohort equations. So, machine learning can provide some improved detection for the high-risk individuals for CVD compared with the current, at the time, the previous risk calculator. But another study published in Hypertension in 2020, when they developed a Cox regression model and machine learning models for predicting CVD risk in young hypertensive patients, they found that the performance of machine learning was not really superior to the Cox regression models. But both of them are superior to the recalibrated framework risk score model. And then one of the very important field we will be refining is blood pressure target or individualized treatment. So in this study, they used data from the SPRINT trial, and then they developed some machine learning to learn heterogeneity of treatment effects. And then they stratified the patients into two groups. One is those who have benefit from the intensive blood pressure targeting 120, and then the other is, the patient without any benefit from the intensive treatment compared with the conventional treatment targeting 140. So they, in the validation using the Accord BP trial, they found that in the benefit group, intensive treatment resulted in the better clinical outcomes, but in those without benefit group, there is no differences of the clinical outcomes between these two treatment strategies. And then I'd like to address about the gaps in evidence. Just when I assigned to this title, I just the first question I had is that is it useful clinically, predicting hypertension in general population using machine learning? Do we need artificial intelligence to predict instant hypertension among the general population? Is that can be superior to regular blood pressure monitoring? Actually, frankly, I do not think so. Because regular blood pressure measurement is accessible, inexpensive, and very directly actionable. So I think that regular blood pressure monitoring is more, more effective than just developing and using machine learning for general population. And then, prediction models can add more complexity, and then I'm a little bit cautious that they can add more values. So, epidemiology is defined as a study of distribution and determinants of disease, and statistics is one of the core of epidemiology. We can ask, machine learning is different from statistics, and then my short answer is no. They are concerned with the same question, how do we learn from data? But they emphasize different things. Statistics emphasize formal statistical inference and low-dimensional problems usually. And in machine learning, emphasize the good performance of prediction and is focused on software and systems. So, while the researchers in machine learning field tell network graph, weights, learning, generalization, and supervised learning, that statisticians usually tell model parameters, fitting, tested performance, regression, and classification. And then, the grades they can receive can be different. We know that, without any doubt, we know that the predicting cardiovascular risk in hypertension is really important, and the recent 2024 ESC and the new 2025 ACC/AEH guideline both emphasize the cardiovascular risk calculation for treatment decisions, and it is really important. But I wonder, do we need a machine learning or complex model to predict CVD risk in hypertensive patients? In the systematic review published in 2019 found that when they compared the risk of bias in between the machine learning model versus logistic regression, they found that overall machine learning model confers the worse bias compared with the logistic regressions. And then the studies with low risk of bias, they can be comparable, but in the studies with high risk of bias, in the machine learning studies tend to have more bias compared with the logistic regressions. And there are several other challenges in hypertension AI research. Blood pressure measurement is accessible and non-invasive, so there are so many data for that. There should be, but yeah, well-organized BP data in a large database is surprisingly scarce. So most of the EHRs often lack standardized BP recordings, and then even more, single-time BP measurements may not reflect the true blood pressure status of patients. And that is the reason why the NHIS study for hypertension deserves so many attentions. And there will be treatment selection bias, to develop individualized treatment strategy or machine learning. It requires unbiased, high-quality data comparing treatment strategies. But especially in Korea, we have very strong preference for ARP or CCB, limiting comparative analysis. And we need large RCTs because it does not have any bias in terms of the treatment assignment, but only a few RCTs are available publicly. So one of the example is SPRINT trial. So SPRINT trial facilitated this kind of the machine learning studies for hypertension. Because it shares their data, and then it enables multiple AI studies. So I think that we have surprisingly few AI studies in hypertension compared to other cardiology areas. And then and many of them are not so interesting or applicable to the clinical practice. And there is only minimal research on treatment response prediction, which is very important for daily practice. So there is a gap between potential applications and actual research outcomes, and we need to think about why we do not have enough studies for hypertension using machine learning or leveraging machine learning. And I think we need standardized integrated data for blood pressure. Standardization of BP measurement method is essential. If we cannot do this, at least we need to capture the detailed metadata about measurement protocols in our EHRs or large databases. We are facing wearable device revolution. We expect explosive growth in blood pressure data, and then so we have a critical needs for standardization and integration of these data into the clinical data warehouse or data set. So we do have opportunity, but still we do not have any standardization, or we do not have any strategies to integrate those data into our real clinical big data set. And I think we need to learn from radiology. Radiology is leading the AI field in the medicine because they built a DICOM standard for storing their radiology images, which was a global standard. So this global standard enabled rapid data aggregation and model development. And then that's why hypertension needs similar data standardization for BP measurements and capturing those data into clinical data set, especially in EHR. Thank you for your attention.
Thank you for your good lecture. And I'd like to introduce next speaker. Next speaker is Sung Abe from Yonsei University Yongin Severance Hospital. He is a cardiologist, and he published many articles about the interventional cardiologists. The lecture of today, his lecture is big data and digital health for precision hypertension care. Please.
Thank you, Chairman. Thank you for kind introduction. I'm Sung Abe, Yongin Severance Hospital. Today, I'd like to talk about the big data and data health for the precision hypertension care. As you know, that the desire of the entire life is universal. So in the Samachon is a record of the grand historian. Korean name is Sagi. The Emperor Jin Huang is unified China and achieved everything was desired. But his ultimate goal was to live forever. So he said that he ordered his administrator to travel to every corner of the world and bring back the medicine immortality. So likewise, the humanity's the pursuit is always been the lifelong and healthy lives. The key of the live long and healthy lives is I think the most important is risk factors management. The earlier we detect the risk factors than the molecular change before the clinical disease manipulation, then the lower disease burden and the higher the reversibility of the intervention. So shifting the reactive disease management to proactive or health enhancement through the early risk detection is essential to management optimal health throughout the lifespan. So in the outpatient clinic, always patients say that, what should we manage to live long and healthy lives? And at the last year, the Lancet paper, the growth burden and the strength of the evidence, the 88 risk factors in global world say that the most important, the risk factor is high blood pressure. So it is important to tell the patient that the management of high blood pressure is the most critical among the various risk factors. The 10-year, the severe risk factors for the 55 years old patient were the different blood pressure level risk factors combination. This pressure. And so a severe risk factor dramatically increased the PP pressure, rise from the 110 to 170, regardless of the other risk factors, so dyslipidemia or smoking or diabetes. When the risk factors were presented together, uncontrolled hypertension can be pushed severe risk above about 40%, which is why the blood pressure management is the very most important factors to emphasize the patient. As you know, that the gold standard of BP measurement is office BP measurement. So when diagnosis and measuring the high BP in adult, standard method recommended for the accurate measurement and the documentation in house BP. But real-world practice is patients say that sometimes when we check my blood pressure systolic BP is over the 140, but today my blood pressure is normal, so I don't need to take hypertension medication. So we considered about the watchful monitoring or start the hypertension medication. Another factors that influence in office systolic BP reading is physiologic or posture or another posture variables. Especially in recent meal investigation or recent alcohol intake or clinical office setting can significantly influence office systolic BP reading. Particularly for the cold exposure, which can cause because BP elevation up to the 30 milli/30. So it is crucial to ask the patient about the recent cold exposure. So this variable will lead the discrepancy between the office, out-office BP, contributing the misclassification, the normotensive individual, thereby the white coat or masked hypertension. In this study, analyzed about 8,000 untreated patients found that masked hypertension significantly increased the severe risk and stroke. Especially the masked hypertension is approximately double the severe risk and nearly the triple risk of the CV stroke compared to the normal hypertension. In my lab, in the UK biobank data, we checked the BP variability between the measurement 2 times from the 1 or 2 minutes apart. Then the variation of the systolic or diastolic BP was the increase. High BP variability is associated with the increased all-cause mortality risk. And the greater within the BP variability is associated to increased all-cause mortality across all the BP categories. Even among the individual with the optimal BP levels, normal BP levels, the higher BP variabilities remained associated with the elevated mortality risk, suggesting the BP variability is the independent risk factors beyond the absolute BP levels. As you know, the ambulatory BP level is very important. So we can identify the white coat or masked hypertension or measurement real life setting as stronger prognostic evidence, and additional BP phenotyping is important. But this advantage was very important in the patient area that can be uncomfortable and affect our sleep. So in the case report, show that the complication of the ambulatory BP monitoring is a skin problem. So this showed the petechiae in the anterior cubital fossa. So patients say that the last time I did the ABPM test, but my arm hurt so much, so I don't ever want to do that test again. So I say that, in that case, please measure your BP monitor at home and bring the reading with the next time. As you know, the home BP monitor is very important because it's very cheap and widely available and very easily repeated and over a longer period, but with BP variability. But only static BP at rest typically available is the disadvantage. So I give you a BP pressure note that check the blood pressure at the home every morning. Bring it to, make sure that bring it to your next clinic visit. But patients do not measure their BP at home. There's some patients, the home BP not used as a ramen noodle tray. So patients say that I forgot to bring my BP log today, so I will make sure to bring them next time. But most patients never bring their BP log. That's the big limitation. In the Victor and the Professor Victor and Celine say that the future hypertension management required the comprehensive transformation across the 5 key domains. The digital transformation enabled the continuous home BP monitoring and promoted the health behaviors through the wearable device and mobile health application. And digital science and AI drives the precision medicine revolution by creating the precision cord, or allows to predict the patient will respond to which treatment and deliver the truly precise care. The rest is also show that the couples wearability monitoring is that this best advantage is the great potential for the BP screening and monitoring and management. The last year, the Skyrabs, the CAT BP showed the world first ring type continuous BP monitoring. CAT BP Pro was recently approved the health insurance benefit in Korea. So when hypertension patient receive the CAT BP from the hospital clinic where their finger, the 24 hours record the BP pressure changes automatically transmitting the medical staff at the hospital and clinic. The PPG is the technique that is the record the change of the blood volume and skin and blood vessels. So this is the validation paper that this data collection is the Seoul National University operating room. They collect data and PPG and A-line BP and COP BP. So this main algorithm is the AI deep learning algorithm. Then primary endpoint was verification of the international standard that show that the CAT BP Pro demonstrated the excellent performance with both systolic or diastolic pressure errors meeting the ISO criteria rather than the 5 millimeter per mercury, showing the outstanding correlation with the reference measurement. I think that this study is very important in the clinical field. So, because this study to evaluate the accuracy or availability of the CAT BP Pro compared to the conventional 24 hours ABPM. So this method is about 30 patients show that the BP pressure measured were compared with the conventional ABPM and CAT BP Pro within the same arm simultaneous method. Show that about the age was 52 years and hypertension is proportion is about 60 and hypertension medication is about 45%. As the result show that the CAT BP Pro demonstrate the excellent performance with the systolic or diastolic blood pressure errors meeting the ISO criteria rather than 5 millimeter per mercury, showing the outstanding correlation with the reference measurement. And the strong correlation with the BP transition from the daytime to nighttime. Last summer, the CAT BP Pro is hospital and clinic nationwide last September, then adapted about 1,600 medical institutions for the patient care just 1 year. Notably, 30 out the 47 tertiary general hospital nationwide have adopted and are using it. So CAT BP Pro is the world first medical device certificated ring type BP pressure monitor and innovated product combining the accuracy and convenience. So it provides a new barrier for both patient or medical professionals. The CEO says that. But as you know that the corporate BP device monitoring is some gap and challenges. There is a big limitation is the validation. So validation of the CAT BP device required different and more complex procedure than the CAT BP device. And another issue is regarding the calibration type or body position or motion artifact or AI model, and the quality of the data used to train the AI algorithm has not been adequately addressed. In the ESC guidelines say that the CAT device should not be used evaluation for the measurement for hypertension in clinical practice as class level C. So we can't use in or user practice, and the ESC criteria say that there is very insufficient scientific consensus in the accuracy standard and validation procedure, so that there is a coupleless device must comply with the prior to communication. So in viewing in this issue, none of these coupleless measurement modalities is currently recommended for the routine clinical care. But I think the making evidence take a time. As you know that the outdoor PPEs monitoring or autonomy electronic monitoring is class 1B recommendation. But about 30 years ago, the British hypertension guidelines say that the automated and the semi-automated device or recommendation is limited. So the evidence is very important, I think that. So in the clinical trials, you will show that there is currently more than 10 clinical trials on the way, the clinical trial from GOV about the coupleless BP monitoring. Therefore, the evidence the coupleless BP monitoring continues to grow over time, then expect that there will be eventually receive the recommendation, the future guideline. This is a take-home message. The hypertension is the preventive condition through the early detection and accurate the BP monitoring, emphasize the importance of the out-of-office monitoring. The continuous BP, continuous data collection and analysis, the digital health techniques of transforming the paradigm of the hypertension management. And AI-driven analysis enable the prediction the individual treatment response, paying the way to truly personalized hypertension care. And coupleless BP monitoring is technology expected to become the new clinical standard as supporting evidence, but continues to grow. Thank you for your attention.
Thank you very much. I'd like to introduce the last speaker. The last speaker is Professor Mitsuaki Sawano from Daikyo University, Daikyo Academic Research Center. He is a cardiologist, and just before he was associate research scientist at Yale New Haven Hospital Center for Outcome Research and Evaluation. He'll give us lecture about improving adherence in hypertension management, digital tools, barriers, and innovation across Asia. And please.
Thank you for the kind introduction. First and foremost, I would like to thank the two chairs and also the Korean Society of Hypertension for inviting me to give this talk. The title of my presentation today is Improving Adherence in Hypertension Management, Digital Tools, Barriers, and Innovations across Asia. The main topic will be on the implementation side and also focusing on the barriers that we may confront from a bird's eye view. These are my conflicts of interests. So we obviously know that high blood pressure or hypertension is a global problem. We see this in every area of the globe, as you can see here, indicated in the red bars. The red bars indicate the high systolic blood pressure and its impact on the burden of having cardiovascular diseases in each region. When we focus on East Asia, which is on the right bottom corner, Southeast Asia, East Asia, and Oceania, including Australia and New Zealand, you see that there is a very long red bar indicated for high blood pressure and hypertension being responsible for many of the cardiovascular diseases experienced in this region. So addressing this problem is really a huge problem. Now, when we look at East Asia, especially China, Korea, Japan, we do have a good enough medical and digital infrastructure on average. It's largely available, and yet we still see inadequately treated blood pressure. So why is that? And we need to address those barriers and think about the solutions. Digital devices And AI tools are everywhere and expanding rapidly, and they are here to stay. So, and it's constantly evolving. As a cardiologist, I have been fascinated by the rapid and evolving the landmark papers that have been published in the past. And this is just one systematic review that came out from JACC Advances, looking at atrial fibrillation. Wearables have shown some promise in detecting cardiovascular conditions, but with caveats. So, smartwatch AFib detection is highly accurate, but limited by poor recordings and biased study populations. False positives may cause anxiety and unnecessary care, especially in younger or less tech-savvy users. Cost effectiveness is also a major concern, and ongoing trials in the case of AFib may reshape screening recommendations. That's where we're at in terms of AFib care. But it's kind of the same, and kind of, well, in hypertension, we have somewhat of a little bit of a different picture. So this is the current guideline that just came out from the ACC-AHA as a hypertension guideline that has been updated a month ago. And they do have a dedicated section on the use of cuffless blood pressure devices. Unfortunately, at the current moment in time, or when this guideline was created by the guideline committee, the recommendation was there is no benefit, and the recommendation is that in adults, the use of cuffless blood pressure devices is not recommended for the diagnosis or management of high blood pressure. And why is that? Well, this is echoing our previous speakers and also the luncheon seminar, if anyone were attending. So at the current moment in time, the recommendation stands that no cuff, no trust. But I just want to add yet to this statement. No cuff, no trust yet. Not just yet. There are limitations, as I have labeled in these bullet points. So there are issues on the calibration limits. Cuffless blood pressure devices need cuff calibration and can't reliably track individual blood pressure changes. There are accuracy issues. Studies have shown that at the population level accuracy, that it may be accurate, but major errors may be there, especially at the individual level. And then, importantly, this has been mentioned over and over again, there is the validation gap. The current standards don't address wearable challenges like motion or posture. So these, there's definitely need to be work done in this field. So I think that but we shouldn't take that as a setback. This is not a setback, but I want to say this is an opportunity. I don't want to sound pessimistic. I want to be positive about this. It's an opportunity, a chance to do more high quality research in this field. We just need more evidence that actually allows us to use cuffless devices and also other digital innovation to move this needle forward and advance blood pressure care. The picture that you see on the right, keep calm and science I'm not going to say the word that's in this box, but science out of it. This is a phrase that has been used in this movie. I'm not sure you have ever watched it. It's called Martian. But this person, this main character, is in a situation where he has to think about ideas on how he can survive on Mars until his other crew members come back to Mars and pick him up. But he's a botanist, and he has to be creative, and he has to create his own ways in order to survive. And that's kind of the same situation that we are in terms of digital devices in the blood pressure field. So I'm going to talk about barriers and challenges upon implementing these digital devices. I've had a chance to work with Yuan Lu and Huang Yuan to write this mini review paper and identifying barriers and challenges, especially focusing on Asian Pacific region. And we try to focus on these 5 themes, and I'm going to talk about 3 of them today. So the first barrier that we noticed is a challenge in controlling dietary salt intake. So if you can see on the right-hand side, the colors that are indicated in more red color are the countries that are reported to have high dietary salt intake. And you see that mostly around East Asia. Now, I'm a Japanese. I love sushi. I love miso soup. I love soy sauce. And that's kind of goes the same, probably, for many Koreans and Chinese as well. These are in the traditional culinary, the culture and the food that we eat. So that's one challenge that we have to face, but it's really about tradition. So we can't really change that overnight. How do we challenge ourselves in terms of monitoring our dietary salt intake? Now, traditionally, we have done this by collecting urine samples. So but there are limitations to that standard method. Now, 24-hour urine collection and spot urine and dietary surveys, now these all come with very shortcomings and impractical and often maybe inaccurate. So there's definitely a need for precision, and an effective sodium control requires daily and per meal quantification. But that requires a lot of data, and that accumulation of data may mean something, but we haven't reached that point yet. Now, there are emerging mobile health approaches. There are several companies who are doing GPS meal tracking to link dining locations with nutrition databases. There's also some providers or services that have done AI imaging analysis using deep learning to estimate sodium from photos of people who are taking the food or the dish in front of them. And these enables context-aware automated and personalized sodium monitoring. But again, I mean, it's not reaching to the entire population, and there's definitely a limitation in terms of generalizability. The second barrier that is quite unique, although other countries are also catching up, is the problem of aging. So with that, it comes with the problem of digital divide among older adults. So low digital adoption is commonly seen across many nations, and even in Singapore, which seems to be very tech savvy as a nation, they only have around 7.1% of older adults in Singapore using digital tools for hypertension management. And why is that a problem? That's because the aging population or the older adults are probably the ones who are going to likely to benefit from blood pressure management. And we need to reach out to them or make it easy for them to use this technology. So this is just to illustrate the point that blood pressure overall is likely to be more beneficial for anyone who's above the age of 80. And if you decrease it to a further extent, going beyond 130 or 90, 85, it seems that the benefit is still there, and it could be that we need to lower blood pressure even further. Now, people would say, hey, wouldn't that result in orthostatic hypertension and other adverse events? But there are evidence that suggests otherwise. For instance, I haven't shown this in my slides, but there is a study from the STEP trial in China looking at older adults and who have been achieved those type of lower blood pressure management under systolic blood pressure 120, but never really resulted in higher rates of adverse events. So those may be actually the future goals for blood pressure management in older adults. But the point is that we want to measure blood pressures in older adults and also make it available and create feedback loops so that people would be able to act upon it. So the digital divide. So we need to advance miniaturized and seamless sensing, as I mentioned earlier. So obviously cuffless wearables, smart toilets to detect maybe urine sodium, potassium, hydration, and smart homes for integrated sensors that could support health and independence may help in this aging population. And that's where we want to be at, but has not been implemented yet. The third barrier that I'm going to talk about is the sustainability part. So blood pressure itself wouldn't mean a whole lot if it's only about 3 months, and then afterwards you just see a whole bunch of people with increased blood pressure. It has to be a long-term engagement. So we do see short-term success from many of the devices or AI systems. Many tools show initial BP reduction, but long-term impact is really uncertain. So the major challenge is the user engagement declines over time, and especially in digital health apps. We do need interactive features and gamification, boost motivation, and a kind of like a human-in-the-loop approach. This is kind of a terminology that is used in the AI model developments. But so if you have a physician involved or a person that the patient would respect and also hear, then that also helps to implement and actually achieve a longer term and sustainable management. So physician involvement in digital adherence programs may strengthen support and behavioral changes. And this is just one example of how blood pressure management has been conducted. This is a paper that has been published maybe 2 or 3 days ago that popped up in JAMA Network Open. In this study, the study investigators used text messaging and video stories to support hypertension self-management in Black veterans. The uniqueness of this intervention was that people were asked to watch 5 to 7 minute videos of Black veterans discussing hypertension management, and then the follow-up stage, they chose a favorite storyteller and received 6 months of narrative, educational, and bidirectional texts. And the control group just received the standard care. Now, we didn't see a major change in systolic blood pressure management change. However, we have to keep on trying. And this is just one attempt. There are many more coming, but I think the important part is to continue and to produce good and high quality evidence. So in summary, driving innovation and addressing barriers and the call to action, now is the time to accelerate rigorous research and innovation to make smart hypertension care reliable, equitable, and scalable worldwide is going to be important. And with that, I would like to end my presentation. Thank you very much.
Thank you very much for your excellent lecture. And we are now open for questions or comments. And for active discussion, we invited 3 experts, Dong-ho Shin from Professor Dong-ho Shin from Yonsei University, Professor Jae-yong Shin from Yonsei University, and Professor Ki-hyun Jeon from Seoul National University. And any question or comments from the floor is also welcome. And now start the discussion.
So I have a question for Professor Chang. Yes, thank you for visiting and thank you for a nice lecture. In Korea, we have a very long and complicated approval process for the medical device from technology to medical device. How about China? Do you have a long process, or how many devices you can use in real clinical practice?
Thank you for your very important question. Actually, in China, you can get approval for the devices used in the hospital. Not quite long time, but for example, many devices without validation have been used in blood pressure management in hospitals. That's the current situation, because the device can be approved only after you do some tests, maybe 200 patients, not according to the AMI or ISO protocol, just in the ordinary person to test that is it's equivalent to ordinary blood pressure monitoring devices, such as mercury devices, can be approved in use in the hospital. Not very difficult. But the problem is that now more and more hospitals require that the manufacturers to provide the validation tests so as to get the hospital approval to go in to be can be accepted. Because most of the doctors realize that if you write scientific papers, the devices should be listed, and only validated devices can be accepted for journals. So that's the different kind of situation. But in the home blood pressure monitoring devices, actually there are a lot of devices without validation are now in market in China. That's the current big problem, actually. But nevertheless, for doctors, we accept that the device is only which will go through validation. That's the priority for doctors in China. Thank you.
Thank you for the nice lectures, professors. And I have a question for Professor Yu. Thank you for the very informative lecture. And I agree that machine learning and deep learning predictions seem better than traditional approach with risk factors. But I think it is very difficult to use the AI predictions in the clinical setting unless EHR support automatic calculation from medical database by their models. So I think the barrier is not from the physician side, but from the EHR or the hospital and the company problems. So do you think if we can persuade hospitals or EHR companies to adopt better prediction tools into our EHR systems?
Yeah, thanks for a very thoughtful comment. And then I agree that that is really real challenge we have, and then that is a very the challenge in adoption of the risk model too, such as prevent score model or scores for the ESC guidelines. So that is so the recent prevent score emphasize that it can be adopted in the EHR system. I don't know whether it is really adopted in the US EHR system, but in their papers and then in their clinical guidelines, they emphasize that prevent score can be applied to the EHR system directly. So I think that it is really important, and then that is the similar challenges that usual risk score models also have, and then EHR needs to be revised to provide some kind of integrating tools for that. And then, yeah, it is possible for some of the EHRs in Korea, but because the Korean EHR system varies across the hospitals, which is very different situation compared with US, because US there are only 2 or 3 dominant vendors of EHRs in the United States. So the real challenge we have, especially in Korea, is that our EHR system are so diverse, so it is not easy to find a way to implement this kind of the machine learning or clinical score system in the many EHR systems of Korea. Thanks.
Thank you for presentation. So I have a question to Professor Sawano. So yeah, thank you very much for your very wonderful presentation. So I have a quick question about providers' incentives in Japan. So as you mentioned, we have some barrier from consumer side. I mean, how they can use this technology easily for the elderly. But another one is provider also needs some kinds of motivation to use the technology. Do you have some kinds of incentives or reimbursement system in Japan?
That's a great question, and that's what we're kind of trying to solve in Japan as well. So there is a reimbursement system, and then I'm not sure if you have heard, but there is a company called CureApps who have managed to kind of land this reimbursement from the government side. But that's kind of like an exception. It's not really, it hasn't been done in many companies who are trying to challenge in going to this space. I know Skylabs have been successful in Korea. But there are challenges, and it's also about these digital devices or digital, it's not necessarily only about hypertension actually. So these many companies who are developing AI platforms or using digital devices, if they have to go through all the rigorous clinical trials and in order to provide evidence, it comes down to a business decision where it makes a little bit tougher for industry to actually invest in their product and actually create evidence. But it's also the public and the medical community that if we think that's a reasonable way of managing blood pressure care, for instance, then perhaps there might be a need for more governmental support or a research fund that can aid this kind of like innovation. So I think right now we're a little bit stuck in between the industry side and also the academic side, and there needs to be a little bit more like a blend approach where we can produce good evidence, but also if there is a good evidence, then we can support these, not necessarily individual companies, but like as a consortium or like a way that can aid a meaningful blood pressure care management society. That's how I'm thinking about it.
Okay. I'd like to express my sincere gratitude to all speakers and panelists for their valuable contribution. In particular, I wish to extend my appreciation to distinguished speakers who have joined us from China and Japan. Before closing this session, our society has prepared an appreciation plaque to Professor Yuking Zhang. Professor Zhang, please, would you please come up to the podium?
Plaque of appreciation, Yuking Zhang. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025, in conjunction with the 63rd Scientific Meeting of the KSHE, November 7, 2025.
Now we will conclude this session. Thank you for your attention and participation.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고, 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며, 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데, 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압 관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Good afternoon, ladies and gentlemen. I'm Jang Ho-bae from Kenyang University Hospital. My co-chair will join soon. She is engaged in the other meeting in the same time. This session's title is the cuffless BP monitoring era, innovation, validation, and future directions. We will have discussion after all speakers' talks. I'm pleased to introduce the first speaker, Dr. Hae-young Lee from Seoul National University. He will talk about validation challenges and methodological standards in cuffless blood pressure monitoring. Dr. Lee, please.
Good afternoon, everyone. It is my honor to be here to present my thought about the cuffless blood pressure monitoring technology. I particularly have to introduce my COI because I'm quite positive side in the cuffless blood pressure monitoring device technology. So please consider my content of my presentation in terms of my COI and my thinking, side of thinking. The reason why I am so positive is that times are changing and no doctors can be registerable against this flow. When you think about real blood pressure, it's the blood pressure measured in blood wave, but we cannot measure like 200 years ago. So we made mercury BP monitoring device. If you think about 2018 and 2020, main session of this symposium is regarding can the non-mercury device can replace the mercury device. Many of them thought the negative aspect of the inaccuracy of non-mercury BP monitoring device. But times are passing after 5 years. No one used the mercury device anymore, but we still measure the patient and measure the blood pressure. So it is I think it is the irresistible flow, the movement from cuff-based technology, and many of the measurement system will be done by cuffless device. It is the real situation in Korea. In ABPM, penetration ratio is very rapid. In the early of this year, we got the medical insurance coverage, but just about 8 months, the annual monthly prescription rate is more than 10,000 patient cases in 1 month. So it is the real situation because before cuffless technology, open clinic doctors have no way to measure ABPM. The machine is too big and too costly, and patient discomfort is significant disturbance to measuring ABPM, and most of all, repeated measurement is almost impossible. That kind of unmet need can be solved by cuffless technology. It is the result of such a rapid penetration of cuffless measurement device era. So let me talk about the historical development period. In the early, but the first invention of blood pressure measurement and early one, it is the way of development is improving accuracy. But after early 19th, there is the development regarding the how much accuracy can be guaranteed at the price of much convenience. So it is one way we met today. So it is the standard process is cuff-based BP monitoring device. We two experts hear the auscultated sound simultaneously, and first standard measurement device compared to the some test device. So they first initially entry measurement to make the accuracy of test instrument, and with the time get week, day or week, they made 7 times the validation Alternatively, test standard after finishing 7 times of repeated measurement, and consistency between 2 experts by auscultator sound. But many of the processes cannot be applied to coupleless technology, because coupleless devices do not involve the cuff inflation. We do not make the exact time of measurement and provide continuous blood pressure measurement. And during cuff inflation, we cannot get the blood flow. So simultaneous measurement is impossible. So correlation is just 1 minute or 2 minute time difference is inevitable when we compare the blood pressure value between standard cuff-based mercury device or auscultative device and cuffless device. And lack of standardized calibration method and frequency is challenging and have to be established in the near future. It's not near future because already it's not standardized all over the world. In the cuff-based era, ISO standard will be the standard procedure. In coupleless BP monitoring device, in 2024, ESH, High BP Research Group, proposed the validation protocol. It now seems the standard process in every coupleless device company have to be solved before they got a position as a medical instrument system. There are 5, for me, it seems at least 5 key elements will be necessary for new validation standard. One is the selection of appropriate reference standard. It is not a joke, it is a real situation. When I submit a paper regarding patency of coupleless device system, the reviewer commented me, as it is the continuous BP monitoring device, so standard procedure will be compared by A-line, not the ABPM device. So there are lack of reference standard. For example, when we compare the accuracy of a 24-hour blood pressure measurement device, cuff device, office BP measurement device, and ABPM device certainly have a different level of BP value. So not only A-line, but also clinic BP monitoring device or ABPM device is the one important component of what is the appropriate reference standard measurement device in coupleless device measure accuracy comparison, and standardization, calibration, frequency, and methodology, and how much the signal will be acceptable for evaluate the machine's function. In the ring type device, about 50% of signal, low signals were cut down to make best good signals, but we don't know how much clearing process will be necessary or allowed for PPG signal quality assessment, and how much population will be necessary for evaluate the patency of coupleless device, and long-term validation is another important option. So that's why reason not only ESH guideline, but also recently published AH guidelines still make very conservative approach in the coupleless BP monitoring device as a blood pressure monitoring tool. The reason is like that. When we check the blood pressure correlation between the coupleless measurement device and reference measurement device, the correlation is very excellent. R value as a whole is 0.99, but 1, 2, 3, 4, 5 value, if we check the subject 4, 5 measurement value among single point by coupleless device, the all 5 value is the difference. So in the individual level, the correlation is near 0. It's common to every coupleless device. The average is when you compare the average value between some reference device and coupleless device, average difference is near 0, but standard deviation is always very difficult to accomplish. ISO criteria 5 plus minus 8 millimeter mercury. In that case, 5 average is easy to accomplish, but 8 millimeter mercury standard deviation is always an issue to solve. That is the one reason. Individual difference may be the important problem and important issue to be solved to guarantee the accuracy of coupless device. So ESH working group proposed at least 5 and long-term patient 6 validation protocol. It seems very much hard job, but many companies are going and solved many of them. We already heard the data in the luncheon session, excellent satellite symposium. Let me briefly introduce one. In Korea, we have two kinds of medical device. One is autonomic measurement device, like ring type device. Another one is manually measurement device, like Galaxy Watch. There is two kinds of coupless device currently permitted as a medical purpose use. And important one is long-term patency. How long the patency will be applied for measurement accuracy. Not only Galaxy and also ring type device and all over the device, indicate 1 month is the limitation of patency of initial calibration, but it is not based on the clear scientific background. So when we think the patency duration is long, it is much better for us to apply that the patient. For example, if we measure the blood pressure, 24-hour blood pressure in the baseline, when we did not recalibrate it, we can measurement the initial test result in 2 months and 3 months after the dose titration. It will be much convenient to one person to repeat the measure of ABPM, but we do not have that kind of how long initial calibration data can be applied to subsequent measurement protocol. It is a static test, so one company, link type device company, fulfilled several portion of the occurrence test indication. One is a static test design. This part is O1, is the individual precision. What is the average value is near zero, difference is near zero, standard deviation meeting the 8 millimeter limitation, the distance between reference value and measurement value. And R value is near 0.9. It is all of many current coupless device company fulfilled over 0.9 the static test result. The second one is position test. When you raise the hand or lower the eye, this is replied you can adequately and correctly measure the supine status blood pressure or standing status blood pressure. It is also current device can fulfill the 5 plus minus 8 millimeter mercury. That is the exact point I measured. Standard deviation is always the obstacle rather than average value, because simultaneous measurement is impossible in the cup-based standard measurement device and coupless device. And last one is the 24-hour blood pressure measurement device. The requirement ISO criteria obligated at least 30%, more than 30% patient belong to the hypertensive range, and more than 30% of patient belong to the low blood pressure range. So by this comparison data fulfill the hypertensive range, low blood pressure range, and antihypertensive medication, and hypertension status. The value is fulfill the 5 plus minus 8 millimeter mercury, both SBP and DBP, and correlation coefficient is more 0.74 is fulfill the ESH criteria. So by current coupless device technology always catching up the requirement proposed by the expert society. So it is the limitation problem of time, not the innate limitation of technology itself. one important task should be solved with the long-term patency. Unlike conventional method, PPG-based device require additional validation and specific time interval. We do not know how long the initial validation calibration result will be applicable the next measurement time. In the Galaxy Watch initial development, we make the statistical check the everyday check value and the systemic deviation of blood pressure. By our calculation, the change of SBP, so deviation of PPG signal interpretation, really happens from the 16 days. 16 days there will be the systemic deviation might be happen. The difference will be calculated by 0.02 millimeter mercury per day. So if recalibration performs every 8 hours, 1 month, they make deviation 0.6 millimeter mercury. So we propose 3 months interval calibration will be applicable in the cost of 2 millimeter mercury deviation of blood pressure. So it is my last slide. My proposal is initial validation will be essential. Simultaneous comparison between cup-based technology and cup-less technology, and at least 1 or 2 physiologic status will be checked to the patency of cup-less blood pressure monitoring device, such as exercise, medication, or positional change. Finally, long-term stability will be solved to check how long we can use the initial validation test. Thank you very much for your attention.
Thank you very much, Dr. Lee. I will introduce the second speaker, Dr. Hyungjun Ju from Korean University. He will talk about early clinical experience with cuff-less BP monitoring, patient acceptance, and data utilization. Dr. Ju, please.
Thank you for a kind introduction. It's very great honor to share my recent experience of CAT BP Pro. Is a cuff-less BP monitoring device, but as this device is approved for 1 day monitoring, so we keep this 1 day monitoring is in our mind. My context is patient acceptability of CAT BP Pro cuff-less monitoring device, and then their data quality, and then BP control status driven by the cuff-less BP device, and then their dipping patterns and the hypertension classification, and then potential role in clinical decision making. As you already know that the guideline recommend the importance of out-of-hospital BP monitoring, and then, but there is a challenge in the out-of-BP monitoring because that the home BP is inaccurate, and then correlation between the office BP and then home BP is really bad, and then also the ambulatory BP monitoring is also have a problem of patient discomfort. So there is several opportunities of this kind of cuff-less BP monitoring device. And my institute, Annam Hospital, launched CAT BP Pro February 2000 this year, and then several months later, that Guru Hospital, one of our hospital, launched CAT BP Pro. So maybe 1 month ago, I collect the data, and then we prescribed 1,500 prescription of CAT BP tests from 2 tertiary hospitals, and then it shows that 95% patient among who prescribed CAT BP Pro successfully performed the CAT BP Pro test. It means that maybe a patient is willing to engage with those kind of cuff-less monitorings, maybe likely because of their easier tolerability. And how about data acquisition quality? I analyzed 1,400 CAR-TBP cases, and then there are some items for their validities, and then proportion of more than 70% valid readings was 95%, and then 90% was had more than 20 daytime readings, and then 98% has more than 7 nighttime readings, and then proportion of case met all criteria was 88%. So I think that CAR-TBP shows some very good performance compared to the traditional ABPM, especially particularly for the nighttime measurement. And then I think that 11.6% of overall quality failure rate is quite promising. And then important thing is that this failure rate is primarily driven by the insufficient daytime readings. Compared to the conventional ABPM, is a very massive device. So patient doesn't work or doesn't do anything, but ring type cuffless device they do the work. And so after removing that those kind of noise, I think that I feel that the daytime readings is very important to those kind of device, and then company have to focus on data measurement algorithms and then patient movement and artifact reduction. How about BP control status? I think adoption of target criteria of ESHA guideline. Overall 24 hours BP control rate was 40%. And then importantly, the BP control rate of nighttime was very low. Only 21% of case was achieved the target BP achievement in ring type coupleless BP monitoring device. And then we can also analyze that those kind of dipping patterns. And strikingly, most patients are non-dipper type. Compared to the GEM study is performed in Japan, and this is community-based, I think, the trials. And then our pilot data is based on the tertiary hospitals. So I think that the population between these two populations are totally different, community-based and then tertiary hospital-based. However, the percentage of non-dipper and riser is very big in our pilot studies. And then I analyzed that hypertension classification. We used that 3 office BP, and we calculate the average of office BP, and then we use the daytime average blood pressure estimate from the CART-BP Pro, and then we categorize the normal tension and white coat and masked and sustained. And then, as you can see here, white coat hypertension is almost 20, and the masked hypertension is also 20. But comparative study is Osama study, also performed in Japan, and it is also performed in the community-based trials. And then there is a white coat percentage of white coat hypertension is 12%, and masked hypertension is 16%. So we can assume that our population is have a very higher cardiovascular risk factors. And then importantly, this graph shows that the percentage of cases of nighttime elevated. So this data suggests that most cases of masked hypertension and then sustained hypertension, it is associated with nighttime elevation, which was estimated by CAT-BP Pro. So this study shows that the nighttime assessment could be very important, and then we can use those kind of metrics in the future. And then I analyzed that, this is a pilot study, but I analyzed that the predictor for the white coat hypertension and masked hypertension. Then interestingly, the SBP standard deviation is a variability of CAT-BP Pro shows emerged as an independent predictor of white coat hypertension, and then non-deeper type of CAT-BP Pro is also important predictor for hypertension. And we can easily think those kind of two factors is very important to white coat hypertension, because that the high coat hypertension and masked hypertension, there is a CAT-BP, those kind of parameters are associated with this kind of definition. However, for the predictor for masked hypertension, variability is disappeared, and only the non-deeper type is remain to the risk predictor for masked hypertension, and there is some clinical factors also very important remain to the important predictor for masked hypertension. And the important thing is that this kind of device and test can change our practice. This is also a pilot, so I can conclude anything from this analysis. But among the 1,400 cases, 300 cases are changed their medication after the CAT-BP Pro. But I don't know the physician consider those kind of information or not, but they changed their medication. And then interesting thing is that office SVP and then is office SVP and office diastolic BP is not statistically non-significant between two groups. But when you look at the data of CAT-BP and the daytime blood pressure and then nighttime target BP achievement is significantly different between two groups. So this data suggests that we test this device, and then physicians make their treatment based on this kind of cuffless BP monitoring device. Okay, and so what is the predictor for this kind of treatment change after CAT-BP? The analysis proposed 5 significant predictors: non-deeper patterns, and then antihypertension medications, and then dyslipidemia. But I think we have to look at the data set detail in the future. But I feel that this kind of cuffless BP monitoring device-driven circadian pattern could be very important, provide very important information to the clinicians, and then this information might play a role to change their decision to treat their patient. So physician experience of utilization of CAT-BP, I think common question would be the accuracy, but I don't know how to solve this problem, the accuracy of this device. And I feel that the cuffless device could be helpful to my clinical workflow. The data of circadian BP pattern, and then we can share those kind of information with my patients, and then I can recommend some valuable recommendation of their medication adherence and lifestyles, and then I can feel their when they sleep and when they awake, and then the work is very hard, or the office work, and then outside work, I can assess those kind of information with ambulatory BP information. And then I think that the challenge lies on definitions. My previous studies, from my previous study, office BP is not correlated with home BPs. And then in this pilot study suggests me that ambulatory BP is not correlated with office BP, and I think even the home BP. So conventional ambulatory BP and this kind of cuffless device BP is not correlated. I think this is my feeling. And then, so I think that the new definition or threshold for those kind of analysis should be redefined in the future. And this is my opinions, and my early clinical experience shows that cuffless BP monitoring could be feasible in routine practice, and then quite welcome by patients. And then I think that this device provides much more comprehensive picture of patient BP profiles, and this data and then already influence treatment decision in our institute. And many more readings help confirm diagnosis and guide titration of hypertension therapy in the future. Thank you for your attention.
Thank you very much, Dr. Ju, for your excellent talk.
From now on, I will introduce the third speaker. First of all, I am Unjujo from Catholic University of Korea, and I apologize for late attendance because of the delayed ending of previous session. The third speaker is Hyunjin Kim from Hanyang University. She is an associate professor in cardiology, Hanyang University Guri Hospital. Her topic is translating cuffless BP technology into practice, challenges and opportunities. Please go on.
Thank you for your kind introduction. I'm Hyunjin Kim from Hanyang University. Today I'll be talking to you about the translating cuffless blood pressure technology into practice, focusing on both challenging and opportunities. As you can see here, when I research a cuffless blood pressure in PubMed, I can find the rapid increase in publication over the past decade, and this clearly shows that cuffless blood pressure monitoring is no longer a new topic. It's becoming a major research field in digital hypertension management. However, despite this academic growth, most studies remain algorithm-based or validation-based, and only a few have evaluated long-term outcome and real-world usability. In Korea, the Korean Society of Hypertension has been actively involved in addressing this emerging technology. On the left, you can see the position paper published in Clinical Hypertension titled Smartwatch-Based Cuffless Blood Pressure Measurement. And this paper outlined the society's official stance on cuffless blood pressure monitoring. And on the right, another study, also from Clinical Hypertension, evaluated the feasibility of watch-based blood pressure monitoring in daily life. Together, these publications represent a balanced perspective, innovation plus validation. Now let's look at the current guideline position on blood pressure measurement. This table summarizes a 2023 European Society of Hypertension recommendation. And the first line recommend is still to use automatic electronic upper arm cuff device for both office and out of office measurement, and this is class 1. And importantly, they clearly state that only properly validated device should be used, but in less low, cuffless blood pressure device should not be used for the evaluation or management of hypertension in clinical practice. This is class 3. And in 2024 ESC guideline also mentioned using validated and calibrated devices with strong recommendation for home and ambulatory blood pressure monitoring. And it introduced a section of novel method, including wearable and cuffless blood pressure technology, but clearly note that there is still no scientific consensus on accuracy and validation standard. Traditional ABPM is valuable, but it has clear limitation in daily practice. Frequent cough inflation disturbs sleep and alter nocturnal blood pressure behavior. And it is very uncomfortable for elderly and frailty patients, and it leading to poor compliance, and it's also not ideal for long-term monitoring. In contrast, cuffless blood pressure monitoring allows continuous and motion tolerance recording over multiple nights, capture dynamic blood pressure variability such as nocturnal hypertension and stress-related change, and even enable phenotype-based risk detection. So I think that it is time to shift our focus from accuracy to clinical meaning. Even if a cuffless blood pressure device show good agreement in validation study, what truly matters is reproducibility and clinical interpretation, whether it can capture meaningful pattern or trend that relate to patient outcome. So in which patient might cuffless blood pressure provide added insight beyond ABPM? It could be particularly valuable for identifying blood pressure variability or dipping pattern. And cuffless blood pressure monitoring can help us capture real-life pattern. So in our center, we conducted a direct comparison between ABPM and CART-BP, and we focused on key blood pressure phenotypes such as nocturnal hypertension, dipping pattern, and vascular hypertension, and white coat hypertension. And by examining the concordance between devices, we aim to identify which patient might be better characterized using cuffless monitoring. So total 70 participants enrolled in this study. And here's a baseline data set we collected from our pilot study. And as a result, when we compare ABPM and CART-BP, we found that CART-BP consistently reported lower systolic blood pressure and heart rate, and with markedly reduced blood pressure variability indices across all time period. And interestingly, diastolic blood pressure were significantly higher in CART-BP. And here we compare the absolute nocturnal blood pressure, systolic and diastolic blood pressure. In this figure, CART-BP reduced slightly lower nighttime systolic blood pressure, about 2.3 millimeter mercury, so not statistically significant, and significantly higher nighttime diastolic blood pressure by around 4.8 millimeter mercury. And we look at the relative nocturnal indices, dipping percent, and day-night ratio. And the CART-BP show a significantly lower systolic dipping percent, 3.3%, and highly day-night ratio compared with ABPM. And this means that CART-BP underestimate the nocturnal dipping when expressed as a ratio or percentage. So overall, cuffless monitoring seemed to flatten the nocturnal blood pressure pattern, which may particularly reflect signal smoothing or calibration drift or of long-term use. And when we compare the dipping pattern classification between ABPM and CART-BP, we found some interesting difference. CART-BP classify more patients as non-dipper and riser, while no extreme dipper. And conventionally, this might suggest calibration drift or signal smoothing, leading to underestimate of nocturnal blood pressure. However, there is also alternative interpretation that CART-BP's continuous and motion-free sensing may better capture true nocturnal blood pressure surge, and higher prevalence of non-dipping could indicate physiologic nocturnal variability, not device error. So it may reveal more realistic nocturnal blood pressure pattern. Here we compare nocturnal hypertension phenotype between ABPM and CART-BP. Out of 70 patients, about 75.7% show concordant classification, while 24.3% were discordant. And CART-BP only positive and ABPM only positive case. This means that in roughly 1/4 of patients, the phenotype could be reclassified depending on the measurement method. And finally, we compare the white coat hypertension and masked hypertension phenotype between ABPM and CART-BP. On the left, white coat hypertension show excellent concordance, about 96%, only 2 discordant case. And this suggests that cuffless blood pressure aligns well with ABPM in detecting out-of-office discrepancy. In contrast, masked hypertension on the right demonstrates only 84% agreement, meaning about 1 in 6 patients were reclassified between 2 devices. And this degree of discordance indicates that masked hypertension may be more sensitive to contextual or temporal factor. And this slide shows the logistic regression analysis for nocturnal hypertension discordance, CART-BP only nocturnal hypertension. In this table, higher BMI was significantly associated with a lower odds ratio, about 85% reduction of CART-BP, only nocturnal hypertension. This suggests that body composition and central artery coupling may influence cuffless blood pressure measurement behavior. Other clinical variables were not associated with. And this slide presents the logistic regression for nocturnal hypertension discordance, ABP only nocturnal hypertension. And alcohol consumption emerged as a significant predictor. This suggests that alcohol intake may transiently elevate nighttime blood pressure, which is better captured by cuff-based monitoring, while other clinical factors are not show significant association. Our findings are consistent with recent evidence from Journal of Hypertension in 2025. In this study, 54 subjects were compared using ATIA cuffless blood pressure monitoring versus ABPM. The results show good overall agreement for 24-hour and daytime blood pressure value, but smaller nocturnal dip was observed in cuffless device. This supports the idea that cuffless blood pressure may under-detect nocturnal blood pressure for possibly due to algorithmic signal smoothing or even physiological adaptation during continuous and comfortable monitoring. And in the same study, the author further analyzes how well the cuffless device could identify deepers. Through ROC analysis, they found that when the optimal threshold 2.96%, the device achieved 90% sensitivity and 62.5% specificity, resulting about 79% concordance with ABPM classification. And this finding suggests that the traditional 10% dipping threshold may not be appropriate for cuffless blood pressure device because of different signal dynamic or algorithm. Instead, they propose using device-specific threshold to improve the accuracy of nocturnal dipping. Looking ahead, cuffless blood pressure monitoring enables repeated nocturnal and daily tracking. For example, patient transitioning between deeper and non-deeper riser in during one night. This continuous approach can also help identify masked or stress-related hypertension, and as shown in this diagram, we are now entering transitional zone, shifting from validation to adaptation. So cuffless blood pressure has potential to redefine how we phenotype hypertension in real life, not just in the clinic. So summarize my presentation, accuracy is not only goal, reproducibility and pattern detection and clinical interpretation are equally important. And cuffless blood pressure may not perfectly match ABPM, but it can reveal hidden or dynamic blood pressure phenotype. And phenotype discordance between cuffless blood pressure and ABPM offer insight into patient-specific physiology, not merely measurement error. And recent evidence supporting defining a device-specific threshold rather than direct applying ABPM criteria. And in the future, integrate cuffless blood pressure into clinical workflow through large-scale validation and longitudinal phenotype and AI-driven interpretation. Thank you for your attention.
Professor Kim, appreciate for your thorough review about challenges and opportunities of cuffless BP technology. Let's move on to last speaker. Is Professor Gianfranco Parati. He will present about cuffless BP monitoring ready for clinical use. He is an honorary professor of cardiovascular medicine, Department of Medicine and Surgery, University of Milano, Bicocca, Head Department of Cardiology and Scientific Director, IRCCS Italian Oxology Institute, Milano, Italy. Please, welcome.
Thank you for the invitation again. And well, of course, I'm going to repeat something, but I would like to go to some important details that might help us understanding whether really the cuffless devices are ready for clinical use. These are my disclosures. I will use some material I was presenting in my previous lecture to go to some more details. And basically, I would like to start for the rationale why we really want to have cuffless devices. That's because we are not really happy with the classic approach. I've been doing my life years of research on blood pressure measurement, and we have been able to prove that they can help us in a clinical setting, but we are also very well aware of the limitation, including the intermittency of readings. Blood pressure is not a number, it's a series of waves. So if you not sample the signal with a frequency high enough, you cannot identify the fast changes. The cuff itself is a source of errors. The size of the cuff, the shape, consider obesity, for example, where you might need a conic shape, the position of the cuff are all factors. The cuff inflation is disturbing the patient unavoidably. The quality of sleep, the quality of daily life can be affected. And this is not a nice measure because it's not respecting the physiology sometimes. If you're using the classical auscultatory approach, you know you make a lot of errors. In particular, when you get older, you lose some frequency, so your accuracy becomes much less than when you're younger. And you can also consider the tendency to round up the values that all clinicians do, which is not accurate at all. But even the oscillometric approach provides a lot of problems, mainly with arrhythmias, as we know. The algorithm may not fit perfectly many physiological situations. And finally, in many countries, we cannot have easily available accurate devices for the high cost, so they're not affordable. So these are practical issues we have to face. And in particular, if you focus on the night, that's a critical issue because we have all been showing that nocturnal blood pressure is an important predictor. But measuring blood pressure with the cuff at night is really interfering with what we do. So you cannot pick up the fast changes, you might create arousal during sleep, and you might also have problems due to the body movements, the change in hydrostatic high difference between the cuff and the heart level, which all may lead to over or underestimation of blood pressure, depending. That's an example I was showing before, but that's very important. The continuous line is a continuous beat-by-beat monitoring. This is the oxygen saturation. You have a patient with obstructive sleep apnea. You have 4 apneas with 4 blood pressure peaks. If you do an ABPM with a 30-minute interval between readings, the black dots, you pick up only 1 peak. So you are missing part of the information, and your diagnosis is affected, obviously. That's why continuous monitoring would be desirable. But even if you consider the cuff inflation, that's again an example. During the cuff inflation, you have an arousal. So you are objectively disturbing sleep, which is responsible for an increase in systolic and diastolic pressure measured continuously in the following seconds. That's a German study. They found in this case a 30 millimeter of mercury rise in systolic pressure. The average changes in the study were around 24. In some people this may be less, but certainly something that we cannot neglect. And finally, variability. Blood pressure variability is a recognized additional risk factor at the time where we are living. And as you know, blood pressure is always variable. This was a subject lying supine for half an hour, doing nothing. And blood pressure is always fluctuating. So if you use a cuff measurement once, you clearly see that this is not enough to quantify the burden on the cardiovascular system. That's one of the reasons probably why we are not precise enough in quantifying the impact of hypertension on cardiovascular risk. And isolated office readings or cuff inflation may not help us in this setting. But it's important to understand how the cuffless work. It's important to acknowledge that they are not measuring, they are calculating. And this is not good for us in a way, in principle. I spent most of my life in promoting the accuracy of measurements. I'm not happy to have a blood pressure calculated, in principle. But can be done better, depends on the methodology. That's a paper where we were first trying to quantify the different approaches available for cuffless measurement, and we were identifying the different technologies. They're all different, one from another. When you focus on the parameter that the sensor is detecting, which can be a time, can be an amplitude, can be a volume, can be a change in microcirculation using a camera. So there are several different approaches which require different analysis and different validation. Importantly, some devices require a calibration, but again, you have two types of calibration. One can be a cuff-based calibration. The other one can be demographic data. How are they reliable? How can we trust them? That's a serious issue that is not being clarified so far. And that's one of the major steps where we have to concentrate our research in the near future, in my opinion. But again, it's very important to understand how they work. There are three critical points, in my opinion. The first point where there is a critical need of attention is the accuracy of the sensor. You may pick up different physiologic parameters, pulse velocity, amplitude, volume, whatever, but you need to have an accurate sensor in the condition where it is going to be used, which is not the lab of a company, is real life. And the values you are collecting do not really reflect a calibration. They reflect simply a sensor detecting a physiological parameter. The second critical issue is the calibration, as I said before. It may be done with a cuff, but which device are you using for calibration? They're one different from another. The oscillometric algorithm is not the same in all devices. And you may introduce an error at the time of calibration, depending on which device you're using. That has not been tested in many studies. The same when you consider the demographic parameters, even worse. The last critical point is the artificial intelligence, because from the signal combined with the calibration, you derive the values and the changes. But how are you feeding the brain of the computer? It depends on the information you add. And this is why probably we need more data to get more reliable information. The CardBP is one example, exactly working the same way. You pick up a signal, you analyze the physiologic signal, you add a calibration, you feed the artificial intelligence, and you get a value. The accuracy of this value depends on all these steps that need to be checked carefully. Why, nevertheless, we love them? That's an important point. We have been all discussing this before. The previous speakers were very informative. Definitely, we like to have something measuring blood pressure variability in daily life. No way, is what we dream of. We are happy to avoid a cuff inflation because we get rid of all the problems associated with the cuff. People are not aware that they have the blood pressure measured, which is a great advantage. And then, of course, we may translate this into more accurate assessment of variability, hypertension phenotypes, circadian changes, in principle. But you need to take care of the steps I was highlighting before, which is not commonly done. And I like this figure because it's giving us the potential advantages, combining what is the comfort of use and the measurement frequency. No doubt the worst is the office reading. Very few readings in a situation with a Y-coat effect, an emotional impact, whatever. So it's not the ideal condition. It's our starting point. And the guidelines nevertheless recommend this as a backbone for diagnosis. We are using home blood pressure monitoring much more, which is giving more data. You don't have the Y-coat effect. It's done in daily life condition, but again, you are at rest, you cannot pick up dynamic changes, and there is some anxiety also in this case to be considered. Over the years, we did a lot of research on ambulatory blood pressure monitoring, which is an important step, but ABPM again is based on cuff inflation, so you get more. We know that this is a very informative test with a lot of prognostic value, but it's not perfect. We miss a lot of information. That's why probably the cuffless could be the ideal solution, because you have much more values, very comfortable, no interference. But all these advantages, better detection, better diagnosis, at the moment are just a promise. We need a demonstration of this, which is not available. And this has to be done in normal people and in hypertensive patients as well. So that's the last point, which is a bit sad, but in spite of all the technology, all the discussion, all the interest, these are not recommended yet, full stop. That's a clear message, because we don't have yet solved the pending issues I was highlighting before. And basically, we don't know how to use them, when to use them, which threshold to use. That's a critical issue also for ABPM. If you are running to catch a bus, your blood pressure is going to rise. This is not hypertension, this is physiology. If a patient sees 180, may be scared, but that's absolutely physiology. We have to define what is the threshold. And this requires many clinical studies, also to interpret the values in different conditions, including the night, and to account also for the finger position. Some studies shown today were reassuring that with the cuffless, the position is less critical than with the cuff inflation, but this has to be tested more. And they have to be careful about neurotic use. Our patients, you know, really get crazy when they measure blood pressure too often. We have to avoid this and to provide some clear indication. But the way we build the model requires a cooperation between engineers and clinicians. I don't like the black box. Artificial intelligence now is a black box. That's not acceptable for a clinician. So we need to work together to improve the quality and the usability. And last point is the calibration. The validation is an essential step. You've been discussing this before. We know that we don't know exactly yet how to best validate them. The validation protocols for the cuff-based are not enough. They give you a validation of the static value, not of the changes. So we need to check the changes. And you know, IEEE started providing some indication of how to compare changes against the cuff. The ISO-2 was suggesting intra-arterial monitoring for the continuous cuffless, and the ESH was providing the protocol you have seen before on how to test the cuffless with intermittent readings providing changes. Now we are working on the ISO-7, which is ongoing. We've been working for 1 year. It might be ready next year early, which will be a more complex protocol for validation, but trying to clarify how we can best include some changes in our validation approach. And that's the ESH, you have seen this before, but it's important at least to test the device in some specific condition, including at rest, after moving the limb, taking a pill, doing exercise, and including day and night changes, and the effect of calibration. That's a critical issue. If you do a calibration, the device is following the values for a while. Of course, it's accurate. It's repeating the calibration value. But after a while, when the physiology is changing, then you need something different, and we don't know how frequent the calibration could be. The Actia is a typical example. It was shown in the study not to be able to pick up the dipping as compared to ABPM, but even worse, not to be able to identify the blood pressure changes induced by a pill, the red line. You have shown some other studies from the Actia group showing that they may do better by changing the way they define the dipping. This can be interesting. But what I cannot accept is having a paper including company people among the authors. And those papers were made by company people, so they are not independent. And we need independent validation. And finally, well, Skylabs, they started with a static validation. Now they are testing with the ESH protocol. I can say it's one of the few companies try to implement the ESH protocol in their validation studies, but we need more. So to conclude, this is a fast-growing field. They can give us a lot of information, but they have to face specific accuracy issues. We need to develop these protocols in a better manner. And we need to test them in a clinical setting, including normal people and hypertensive patients. We need also to take care of the privacy. Artificial intelligence can be a problem sometime. So until we solve these issues, they cannot, in my opinion, be recommended for routine use. Although we love them, I'm sure this is the future. But at the moment, we have to be careful for respect of our patients. If I have to take a decision on a given treatment, I want to do this on reliable values. I want to avoid the random numbers. And if hypertension is a stealth killer, we need to improve it, definitely, to provide better digital health approach. There are many barriers in the world that we have to face. We have to devise high-quality care based on reliable values, and we need to provide better validation protocols. Thank you for your attention.
Professor Bharati, thank you for your presentation. Your presentation provides us some thought-provoking issues. And
I think we will have time for some appreciation to Dr. Bharati. After panel discussion, 이라고 합니다. Now time for panel discussion, please.
Okay, I have one question to Dr. Bharati. Yeah. My name is Moon from Gachon University, and I'm a cardiologist treating hypertension patients in my outpatient clinic. Okay, let's not talk about the validation. Let's consider that cuffless BP measurement is perfect, and we use it. We can use it. Let's consider for this occasion. So my question is this: that traditionally, we doctors have used sitting position blood pressure to treat the patient, to define the disease and target, treatment target, to make the treatment target. But the problem is, the cuffless BP measuring is too convenient. So the patients even don't know if their blood pressure is being measured or not. So that is the problem. So basically, all the data from the cuffless BP device is gathered in any given situation, in any given position, and any given surface. So let me put it, my question is, I'm just worrying that all the data from the cuffless BP device is too unstandardized data. So my question is this: do we need to define hypertension again, or is there any special consideration interpreting the data from the cuffless device? Please.
Thank you so much for this question. That's a Nobel Prize question, you understand. So, but nevertheless, you are touching the real world. That's a situation. I mean, blood pressure is a continuous parameter, continuously affecting risk. We have no magic threshold, you know. The higher, the worse, in a way. But we have to define somehow a target to decide where to treat or not. And this has to be based on outcome data, traditionally, this was done on standardized measurement. Research in medicine for years was all in the lab. We were taught, when I was a younger researcher by my boss, to standardize everything as much as possible to be sure of the results. But when you standardize, you miss the real world variability. People don't live in our lab, not even in our office, they live at home. So we have to protect them in their daily life situation. That's a challenge for us, which is the opposite of standardization. So what should we do? You cannot redefine hypertension, no worry, we will not do that. But we need to find a better way to identify where the risk is. So I think there are two types of validation. One is the technical validation. This is essential for the reliance on the values. And I was spotting the three major issues that we have to face: sensors, accuracy, typo calibration, artificial intelligence construction. But we need also a clinical validation. We know very well that ABPM is not accurate. We know very well. But it's highly predictive of outcome. So I would be happy if a cuffless device would be as inaccurate as the ABPM in terms of outcome prediction. And this is not available yet.
I basically agree with you. I'm using it a lot. Thank you.
I have one question to Dr. Hyunjin Kim. In your data, the obesity may reduce the accuracy of cuffless BP monitoring, but even cuff-based BP monitoring, obesity also reduce the accuracy of BP monitoring. So we need the invasive BP monitoring as a reference value. What do you think about that?
Thank you for a nice question. In our data, the registry regression, BMI over 25 decreased the risk of nocturnal hypertension So in obesity patients, the peripheral resistance or the cart BP's mechanism of action to measuring blood pressure measurement method will affect the result. So I think that many number of patients will be needed for the obesity and blood pressure phenotype association, I think.
Thank you. I'm Jong-Shin Woo in Kyung University. I really enjoyed this session. I have a question to Hae-young Lee. I'm still worried about the validation of cuff-based BP measurement, but I also agree with its tracing ability and patient adherence. But so I think about the hybrid approach that means cuff-based and periodic ABPM monitoring. So how about your comment about the cuff-based BP measurement? You need 3 months. 3 months calibration would be enough, but I think maybe periodic ABPM monitoring would be better. So how about think about the hybrid approach to measurement?
Theoretically, hybrid approach will be best, but practically, nearly no patient want to repeat the ABPM measurements. So in the real applicability, repetition of ABPM is impossible in most cases. And I think it is easy to tell cuff-less technology still insensitive to measure the dynamic blood pressure change, but I do not agree with, because when I take the cuff-less device for myself, even short nap between my morning outpatient clinic and afternoon outpatient clinic, my blood pressure changed more than 10 millimeter mercury. In someone tested the cuff-less blood pressure monitoring device, the sensitivity is not so insensitive, it's quite sensitive, and I think the inconsistency between ABPM device and cuff-less device might be solely attributed to the problem of coupleless technology, because in the oscillometric BP monitoring device, we always criticize it. It can measure the SBP correctly, and some limitation in DBP measurement when we compare the oscillometric device and mercury oscillator-based measurement. So it need more experiment, whether it is more cause solely attributed to the insensitivity of coupleless device or the merged combined inconsistency, both oscillometric device and coupleless device. And one more comment, our society in the finalized the outcome study, 4-year outcome study to evaluate whether annual measurement of coupleless technology and control 24-hour blood pressure measured by coupleless device will be beneficial in reducing cardiovascular outcome compared to the conventional office blood pressure measurement device. In order to make the positive result, BP difference between two groups will be essential. I was very delighted to see the Professor Ju's data. When we measure the coupleless device, more than 40% of patients is unmet need and more room to up-titrate of blood pressure. So after watching the Professor Ju's data, I was convinced to the success of our outcome trial. Finally confirm every word will to confirm whether it is beneficial or not to measuring coupleless annual ABPM in clinical practice to reducing cardiovascular outcome.
I have one question to Dr. Ju. Yes, Professor Ju. In your clinical experience review, is there any problem in interpreting the data on atrial fibrillation patient or other arrhythmia? And also one more, is there any recommendation to the period of recalibration frequency?
Actually, the exclusion criteria is arrhythmia. Patient with arrhythmia cannot apply to the CART-BP device. And then calibration is, this is approved for the one-day monitoring device. So I prescribed CART-BP, and then patient was go to the lab, and then they calibrate the ring, and then they go home, and then return the device one day after.
Yes, so this is so early experience, right? Okay. So from now on, there will be a presentation of plaque of appreciation to Professor Gianfranco Parati. Okay, so on behalf of the Korean Society of Hypertension, Professor Jang Ho Bae will present.
Flag of appreciation, Professor Gianfranco Parati. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025 in conjunction with the 6th scientific meeting of the KSH, November 7, 2025.
Okay, this concludes our session. Please enjoy your rest of conference.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압 관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Let me open.
You want to open? Sure.
You will conclude. You will conclude.
Absolutely. Sure.
Good afternoon, everyone. We had a plenary lecture for the guideline, and now we have a chance to have a discussion and make some consensus for the issues. So the topic of this session is controversies and consensus in the 2024 ESC hypertension guidelines. Actually, this program was made before the publication of 2025 AACCH guideline. So, but the important point was issued almost in the 2024 ESH guideline. There was a very exciting, something new. So the program was not actually changed. So we'll move on I'll move on to the first speaker. The first topic is elevated blood pressure category, disease, risk, or opportunity. This topic will be delivered by Professor Gyechul Oh from Catholic University. Professor, please.
Thank you, Chairperson. It's truly an honor to speak here at Hypertension Seoul today. Talking about the new ESC recommendations on elevated blood pressure and hypertension in front of the people who really wrote the article is a privilege and also a very big challenge for me. I'll do my best to get it right and not misinterpret any things, and I'll just start right on. The 2024 ESC guidelines come with a new title, the ESC Guidelines for the Management of Elevated Blood Pressure and Hypertension. This new title signals a broader scope in recognizing that elevated blood pressure is a meaningful category within the hypertension continuum. In the previous ESC guidelines, we classified blood pressure as optimal, normal, high normal, and stages of hypertension. In the 2024 recommendations, this has been simplified into 3 categories of non-elevated and elevated blood pressure and hypertension. The elevated blood pressure group is defined as an office systolic blood pressure of 120 to 139 or diastolic blood pressure of 70 to 89 millimeters mercury. And values below 120 over 70 millimeter mercury are now referred to simply as non-elevated blood pressure without any labeling them as optimal or normals. Because this reflects the idea that even in this range of blood pressure, individuals in this range could still carry a measurable cardiovascular risk, which makes them non-normal patients. So why the emphasis on elevated blood pressure? While the American guidelines, the US guidelines have adopted a stricter threshold definition for hypertension for a couple quite of time now. The changes in the ESC new recommendations are broadly aligned with this trend, recognizing that risk is very wide, risk across a wider range of blood pressure spectrums. The focus on elevated blood pressure reflects the evidence that hazard of developing cardiovascular disease begins at a systolic blood pressure that is as low as 90 millimeters per mercury, as shown here in the multi-ethnic studies of atherosclerosis, which shows that blood pressures of 100 and 110 up to 130 have a higher risk of developing incident cardiovascular disease compared with blood pressures of 90. And in addition, a meta-analysis from the blood pressure lowering treatment trials collaboration here shows that the benefits of blood pressure lowering interventions in reducing major cardiovascular events are present even in those individuals that have baseline blood pressures that do not meet the threshold for conventional hypertension definitions. As shown here with the systolic blood pressure of lower than 140 have a benefit in MACE events with blood pressure lowering interventions. So, but then should we treat everyone with elevated blood pressure? If you have a blood pressure of 128 over 80, should we start them on hypertension medications? That would place a significant burden on both clinicians and healthcare systems. And in reality, the incidence of cardiovascular events begins to steeply rise around an estimated 10-year cardiovascular risk of about 7 to 8%. This is the US REGARDS trial showing on the left. The NHANES data shows that for patients with hypertension, those with systolic over 140 or diastolic over 90, around 70% of the patients have a 10-year predicted risk of 5% or higher. Whereas in those with elevated blood pressure, only about 40% of the proportion of the patients have a 10-year cardiovascular risk of 5% or higher. And these would be the patients who benefit from blood pressure lowering interventions. And the guidelines recommend that we try to investigate for these patients in these elevated blood pressure categories. In an analysis of 18,000 patients from the Framingham, Offspring, and ERIC trials, shown here, the treatment of individuals with elevated blood pressure, these patients with systolic blood pressure below 140, was associated with a reduction in atherosclerotic cardiovascular disease presentations, showing that even early intervention at this stage could yield measurable benefits in cardiovascular prevention. To summarize, the rationale for focusing on elevated blood pressure is that First of all, hypertension is still defined as an office blood pressure over 140 or diastolic 90 millimeters mercury. Elevated blood pressure, not all patients with elevated blood pressure are at high cardiovascular risk, but the new recommendations introduces this elevated blood pressure category defined as systolic 120 to 139 or diastolic 70 to 89 millimeters of mercury. This reflects the understanding that the relationship between blood pressure and cardiovascular disease is continuous and not a binary relationship, and that treatment could be beneficial for individuals with elevated blood pressure and who are at high cardiovascular risk. And this diagram here illustrates what I've just summarized. Another key emphasis of this 2024 ESC guidelines is the role of out-of-office blood pressure measurements. Both home blood pressure and daytime ambulatory blood pressure measurements of systolic 120 to 134 and diastolic 70 to 84 millimeter mercuries are defined as elevated blood pressures. The guidelines further recommend identifying individuals to look for high cardiovascular risk individuals who might benefit from pharmacological treatment. To do this, we first need to screen for major cardiovascular risk factors such as established cardiovascular disease, moderate or severe CKD, hypertension-mediated organ damage, diabetes, or familial hypercholesterolemia. If none of these are present, we next go on to calculate the 10-year cardiovascular risk of each individual. And for the European guidelines, they recommend using the SCORE2 or the SCORE2 older people charts to calculate the risk. In the more recent 2025 US guidelines, they recommend that they use their PREVENT score to calculate this risk. For us here in Koreans, we do not yet have a very established risk score system that we could use. I think we could go both ways here. Based on this individual's calculated 10-year risk, we can then decide whether to, if they have a lower risk, they could either go to lifestyle measures to reduce blood pressure, and if they have a higher risk, they could start lifestyle measures with an intended 3-month follow-up to see if they would need pharmacological treatment for those individuals with blood pressures over 130/80. I'm going to shift gears a little bit and give you a little brief introduction with a case. This is a 44-year-old male with elevated blood pressure, his weight and height, Southeast Asian Korean, increased blood pressure at annual health checkup. His cardiovascular risk, his blood pressure is 128/72, which would have gone as pre-hypertension or currently this would be elevated blood pressure. He does not have diabetes or dyslipidemia, non-smoker, no premature family history. His BMI calculated on his weight and height is 24.3. So first of all, we see if there are any high cardiovascular risk conditions. He does not seem to have any established cardiovascular disease. His blood tests on the right here, eGFR of 112, fasting blood sugar 82, LDL cholesterol 79, no really big cardiovascular risk conditions. Next on, his EKG, actually this is me. Do I have left ventricular hypertrophy? I don't know. Well, his EKG seems to be normal, so my 10-year, next I go on with calculating my 10-year cardiovascular risk. My non-HDL cholesterol is 109, which is somewhere near here. My age is 44, and that would put me right about in this red circle, which would calculate as about 10-year cardiovascular risk of 1 to 2%. For me, my 10-year predicted cardiovascular risk is below 5%. I would go through lifestyle measures to reduce my blood pressure, take my blood pressure annually, and also reassess if there are any additional cardiovascular risks. If I had a cardiovascular risk of 5 to 10%, I would need to consider some more risk modifiers to see if I would need any more therapies. And if my cardiovascular risk was above 10%, that would mean immediate lifestyle measures and a 3-month follow-up to see if I would need pharmacological treatments. So these risk modifiers to see if a patient needs further interventions would have two categories. One are sex-specific, and one are shared risk modifiers. For the shared modifiers, we have high-risk ethnicity like South Asian descent, family history of premature ASCVD, socioeconomic deprivation, autoimmune disease, severe mental illness, and HIV infections. For sex-specific modifiers, they're mostly about pregnancy and deliveries, gestational diabetes and hypertension, history of preeclampsia or preterm delivery, and miscarriages or stillbirth would qualify as sex-specific modifiers and require more intensive interventions. And what if I had a high calcium score? That would also mean another risk modifiers, high calcium scores, or any atherosclerotic plaques in my carotid or femoral arteries, elevated troponins or pro-BNPs, and increased pulse wave velocities would also count as risk modifiers and put me at a higher risk for atherosclerotic events. And after going through lifestyle measures, in adults with elevated blood pressure but do not have high risk of 10-year high risk, blood pressure lowering with lifestyle measures is recommended, class 1. In adults with high risk of cardiovascular disease but with elevated blood pressure, first they were recommended to go ahead with 3 months of lifestyle measures, and after that, if the blood pressure is still over 130/80, pharmacological treatment is recommended as a class 1 indication. Even after you pass the test, even you do not have high cardiovascular risk, you only have elevated blood pressure, you are still required to screen for blood pressure and cardiovascular risk factors every year. If you even have non-elevated blood pressure and above the age of 40, you are recommended to follow up blood pressure every year. If you're below 40 years old, that would be a 3-year term follow-up for risk assessments. And for pharmacological treatment, I think Dr. McAvoy will talk about the combinations and triple combinations in the later session. But for those elevated blood pressure categories, we do not really want to start them on double combination therapies because they do not have a really high blood pressure. So these are one of the categories that initial monotherapies are preferred along with severe frailty and symptomatic orthostatic hypotension and those with age over 85. Some concerns have been raised regarding the treatment of individuals with elevated blood pressure. One relates to the elderly or the frail patients. These individuals often do have higher cardiovascular risk than their younger counterparts, making blood pressure lowering treatment appropriate, but we must ask whether it is safe to apply these pharmacological treatments in those patients who are more vulnerable to side effects or hypotension. Another concern is the potential overuse of drugs in this category, which can increase the economic burden of the individual and for the healthcare system. Although many studies indicate that primordial and primary prevention is actually cost-effective, these issues, along with insurance-related factors such as reimbursement and indication issues, require careful considerations. When we translate these concepts into real-world practice, things become a little bit more complex. This is a recent study published in Circulation from a French general population cohort showing that up to 80% of the individuals in the general population could have non-elevated blood pressures. The burden of screening these patients and managing such a large portion of the population could be a significant challenge for both the clinicians and for the healthcare systems. In addition, while the diagnostic thresholds and the treatment targets, they are getting progressively lower, the global control rates have not kept real pace. There are some regions that are good at controlling blood pressures, like the Western countries and here in Asian Pacific, but globally, the overall control rate of hypertension still remains around 30% and is not really going up that high. One more point I'd like to emphasize is that given the concerns about the overuse of drugs, we must not overlook the importance of lifestyle measures. Measures such as reducing salt and alcohol intake, increasing potassium consumption, increasing the physical activity, and optimizing weight and dietary supplements are really required it's really a baseline requirement before you start pharmacological treatment. These strategies are really clearly outlined and strongly recommended in the ESC guidelines. And finally, patient-centered care. No two patients are the same. We need to assess each patient individually and have a very thorough assessment and treatment option planned out in discussion with the patient. To summarize, individuals with elevated blood pressure, systolic of 120 to 139, or diastolic of 70 to 89, they do have a pre-disease state. I made this word up. This is not in the dictionary. And they are at high risk of developing cardiovascular disease, but they do have an opportunity to mitigate this cardiovascular risk by careful investigation of pre-existing cardiovascular disease or risk factors and early control of elevated blood pressure through lifestyle measures and pharmacological treatments. Thank you for your attention.
Thank you. Thank you, Professor. We go to the next topic. Next one is treat to targets in hypertension. How low should we go? The speaker is Mi-hyang Jung from Catholic University. Please, Professor Jung.
Thank you for your kind introduction. My topic today is treatment to target in hypertension. How low should we go? According to the Korean Hypertension Fact Sheet 2025, which was released just yesterday, prevalence of hypertension is still going up, and it poses a great burden in Korea. In an established epidemiological study, the linear association between systolic blood pressure and ischemic heart disease and stroke mortality is shown, regardless of age strata. Several years ago, our team also examined the association between systolic blood pressure and overall CVD mortality using National Health Insurance Service database. It showed the graded significant association also applied in all age strata, including those with aged 70 and 80 years old. The recent ESC published recent updated of hypertension guideline. It categorized BP status in 3 groups. It is non-elevated blood pressure, elevated blood pressure, and hypertension. And according to the BP status and risk profiles, the pharmacological therapy should be initiated based on these levels. Then, how low should we go? It is my topic of today, and the guideline says a single target of systolic BP of 120 and 129 over diastolic BP of 70 and 79. According to the different guidelines, the American guideline shows a very strict BP threshold and strict BP target of 130 over 80. However, the European guideline remained the hypertension threshold of 140 to 80, and this is similarly applied in Korea. However, compared to the ESH guideline and ESC guideline, the treatment target has been changed. And the previous ESC guideline applied two-step approach, which means firstly, target systolic blood pressure of below 140. Then we further decrease to less than 130 if possible. However, the recent ESC guideline recommend a one-step approach with a single target blood pressure of 120 and 129 over diastolic blood pressure of 70 and 79. If the patient is well tolerated, and it is recommended to confirm with out-of-office blood pressure monitoring, such as home blood pressure or ambulatory BP monitoring. This one-step approach is evidenced by the recent trials of showing benefit of intense BP lowering across most patient subgroups, and this approach is to discourage therapeutic inertia in BP management. So the guideline says to reduce CV risk, it is recommended that treatment systolic blood pressure in most adults should be targeted to 120 to 129, provided the treatment is well tolerated. It is class 1, level of evidence A. However, in cases where BP lowering treatment is poorly tolerated and achieving this target is not possible, it is recommended to target a systolic BP level as low as reasonably achievable. It is called ALARA principle, and it is also class 1, level of evidence A recommendation. It is quite different from earlier recommendation of target BP of 140/90 or in some cases of 150/90. It is largely due to sprint trial. And in this trial, the blood pressure goal for standard treatment was systolic BP of less than 140, and while the blood pressure goal for intensive treatment was systolic BP of less than 120. As we already well know, the intensive treatment group significantly lowered the risk of composite endpoint and all-cause death. And in subgroup analysis, there was no significant interaction between age groups, sex, and racial groups. And importantly, the baseline systolic BP level do not affect the result. So as you can see here, systolic BP of 130 to 132 also benefited from intensive BP lowering. And this is another recent data showing individual participant level data, meta-analysis of randomized clinical trials showing the effect of pharmacological BP lowering effect in patients with and without previous CVD at baseline. This is quite interesting because sprint trial mainly focused on high-risk patients with CV disease. So there was evidence lag in those patients without previous CVD patients. And this study also examined these BP lowering effects by baseline systolic blood pressure. And it clearly showed the reduction of systolic BP clearly reduced the risk of CV event in those patients with and without CVD, about 10% lower risk of CV events. And there was no heterogeneity of treatment effect by baseline status of CV disease and by achieved systolic blood pressure levels. And as the previous speaker already mentioned, the blood pressure of less than 120 or 120 to 129, previous called normal or high normal blood pressure, still benefited from intense BP lowering therapy. This clearly supports the lower BP target proposed in the recent ESC guideline. And similar benefits also shown in older patients as provided by sprint senior trial and step trial conducted in China. And recent study from the ESPRIT BP trial, which included 38% with diabetic patients. These patient with diabetes was not included in the previous sprint trial. So this was the evidence gap. And ESPRIT BP trial addressed this evidence gap. So the result shows the intensive BP lowering therapy resulted in about 12% risk reduction in primary endpoint, but it also elevates the risk of syncope, about 3-fold elevation in the risk. So the guideline states the evidence for systolic BP lowering target is quite strong as class 1 level of evidence A, but the specific diastolic BP target is less strong. It is currently level of it is class 2A indication. This is the key summary of the guideline. The first, it is the single target range. If the patient is well tolerated, the recommended target range is between 120 to 129. It is class 1 indication. And the ideal point of this range is systolic BP of 120 millimeter of mercury. And this is recommended to be confirmed by out-of-office BP monitoring. However, when this is not well tolerated or in patients with symptomatic orthostatic hypotension, advanced age patient, or have frailty or limited lifespan, the LRS principle can be applied, which means as low as reasonably achievable. However, there is one remained question. The lower limit of the BP target, which is ranged between 120 to 129, then the lower limit is suggested. But this is because the potential risk when systolic BP falls below 120, such as falls, dizziness, syncope, and decline in EGFR. However, there is one important question. Is systolic blood pressure of 100 and 1 below 120 actually harmful in real-world practice in younger or middle-aged adults? This needs further study. So, in summary, the recent ESC guideline provides a single actionable blood pressure target to achieve better CV outcomes. In most adults, the recommended target is systolic blood pressure of 120 to 129 millimeters of mercury if the patient is well tolerated and should be confirmed with out-of-office BP measurement if possible. However, if this target is not tolerated, then as low as reasonably achievable is recommended, with a reasonable goal of systolic blood pressure of less than 140 millimeters of mercury. And individual management is also recommended. Thank you for your listening.
Thank you, Professor Zhang. The latter part of this session will be chaired by Professor Luis. Please.
Thank you so much. And it's my great pleasure to introduce my co-chair of the 2024 ESC guidelines. Bill and I worked together for about 2.5 years, every week, putting together these guidelines, and I'm delighted to welcome him. And he will be talking about initial low-dose combination therapy, universal strategy, or context-dependent. Thank you, Bill.
Thank you, Professor Taus and Professor Shin, and again, I'm very happy to be speaking today. This is a topic that I think is somewhat different between guidelines, and an area that probably needs a little bit more research in terms of the stepwise approach to applying low-dose combination therapy. And I'll go through my thoughts on this, some of the areas of discordance between guidelines, some of the areas of uncertainty, and so on. I don't have any conflicts of interest to report. I thought I'd start with this. This is actually from the ACCHA guidelines. I thought the wording of this is better than what's in the ESC preamble, although the ESC says something very similar. But that is that guidelines are intended to define practices meeting the needs of patients in most, but not all circumstances, and should not replace clinical judgment, particularly in the hands of an expert. And we need to remember these guidelines are written for a broad audience, including non-experts, general practitioners, and so many of the recommendations in the guidelines are a balance between the evidence and the science. We always want to get that right, but also implementation, practicality, and simplification for non-expert clinicians. And that feeds into a little bit some of the recommendations around low-dose combination therapy. Okay, we've seen these guidelines before. They're available for free at the European Heart Journal. And again, we've seen these categories in earlier presentations, particularly the excellent presentation to begin the session. And we have these three categories of blood pressure. I think it's important to reflect on these three categories with respect to combination therapy because the recommendations for combination therapy depend on the context with regards to initial blood pressure. So we have the non-elevated blood pressure group. Those patients are doing well. They can continue with healthy lifestyle. As we've discussed, we have the elevated blood pressure group, 120 to 139 office, where we may decide to treat depending on a risk assessment and follow-up blood pressure after 3 months of a lifestyle intervention. And then we have the hypertension category, in whom, once confirmed, we do recommend treatment in pretty much everybody as long as it can be tolerated. The thing about this is that when you have a target of 120 to 129 and you have a patient with hypertension, it's very difficult to get that patient to a target, at least on average, with one blood pressure lowering drug. So it makes sense just from the pure concept of the numbers, starting greater than 140, aiming for 120 to 129, that we think about a combination therapy up front. That's just numbers. So again, for all hypertensive patients, once confirmed, we want to get them treated and treated to a target of 120 to 129, with 120 being the optimal point on the range. And that in large part motivates, like I said, these approaches to combination therapy. So how do we recommend applying combination therapy in the ESC guideline? As was discussed earlier, and an important caveat is that initial monotherapy is preferred if patients have elevated blood pressure in whom there's high CVD risk and they remain above 130 after 3 months of lifestyle. There you can start with initial monotherapy because their blood pressure differential between the pre-treatment and the target is not as wide. And similarly, you can apply your clinical intuition for patients with moderate severe frailty, orthostasis, or are very old with regards to initial monotherapy. But for most patients, particularly most patients with hypertension, so 140 over 90 or higher, that's confirmed, if you're going to treat them and you want to get them to target, on average they need to be on more than one medicine. And so an upfront low-dose combination makes sense. And there are other reasons besides the differential between pre-treatment and target that I'll talk about with regards to the logic and motivation for combination therapy. But in the ESC, we recommend starting with a low-dose double combination. This is where there's some difference between guidelines, and this is where I think we probably need some more evidence to come to a consensus. And the ESC guideline will recommend for a patient who's not at target after 1 to 3 months with a low-dose double combination, preferably, by the way, in a single pill, that we move to a low-dose triple combination. And then if not at target, we maximize the doses of that triple combination. And then if they're not at target at that point, we're dealing with apparent resistant hypertension. At any point, beta blockers can be added. So that's the recommendation from the ESC. I'll discuss a little bit in later slides what the motivation was, but before I do so, I'll show you what the other guidelines recommend with regards to double and triple combination therapy. So again, context, universal strategy or context dependent was the title of the talk. Very much context dependent if it's hypertension and in a patient who you want to get to target, upfront double combination therapy makes sense. If it's elevated blood pressure, 130 or higher after 3 months of lifestyle at high CVD risk, monotherapy. So it is context dependent with regards to upfront initial monotherapy or combination therapy. What do the other guidelines say about this? These are the US guidelines. They're also published in Hypertension, which is Professor Tui's journal. Again, very similar to the ESC guideline. Up front, 3 main classes of medicine, the RAS inhibition, thiazide-type diuretics, and long-acting dihydropyridine calcium channel blockers. For all patients with stage 2 hypertension in the American guideline, which is hypertension in the ESC guideline, that's greater than 140/90, initiation of 2 first-line agents of different classes, ideally as a single pill combination. So the exact same recommendation in the ESC and the 2025 ACC/AHA with regards to hypertensive patients. And again, the American guideline will recommend initiation, well, at least they say it's reasonable to initiate monotherapy, single first-line drug for patients who are 130 to 139. A distinction with the ESC is that the American guideline now recommending treating pretty much everybody with systolics over 130 or diastolics over 80, although they do recommend upfront lifestyle for low-risk patients. And again, to emphasize, the ESC only recommend drug treatment for patients with blood pressures in these range if they have high risk, not if they have low risk. So a little bit of a difference there, but at the same time, for that blood pressure range, that 130 to 139 systolic, upfront monotherapy in both guidelines. So again, context dependent. It depends on what the pre-treatment blood pressure is. Another guideline that came out that I think is salient and informative with regards to the approach of treating patients with combination therapy is the ESH guideline. That was released in 2023. And we have Professor Parati with us who was involved in this. So here there's a slightly different approach, which is interesting and worth reflecting on compared to the ESC. Here, again, same story. Hypertensive patients start with a dual combination. Some caveats, similar to the ESC, maybe a bit more conservative. You can start with a low monotherapy in low-risk hypertension, and if the blood pressure is less than 150 systolic. By the way, in patients over the age of 80, they don't recommend starting treatment till 160, which I wouldn't agree with myself, but that's a recommendation that's based on, concern about overtreatment of older adults. But essentially the same story, upfront dual combination therapy with RAS inhibitor plus a calcium channel blocker or a diuretic. And that will get up to 60% of patients to control, although here control is less than 140. So I would argue that's not control. But that's the same pretty much as the ESC. What's different is that the ESH recommend increasing full dose double if they're not at target. So rather than going from a low dose double to a low dose triple, which is what the ESC recommended, the ESH recommend low dose double, full dose double. And then you can consider adding in a third agent. So slight difference between the two guidelines in that regard, which we'll cover in later slides. And then same again, if patient has uncontrolled blood pressure on 3 medicines, then they're part-resistant hypertension. You want to make sure that it's not pseudo-resistance, it's true resistance, secondary prevention, secondary hypertension workup, etc. How about the targets? Again, like I said at the outset, for most hypertensive patients, if you're targeting a blood pressure of 120 to 129, you almost by default, at least on average, will require 2 medicines. The guidelines are fairly well aligned, I would argue, and this is nice to see. It's nice to see when the guidelines align because it tells you that the evidence is fairly convincing. So AHA, ACC, less than 130. They do say less than 120 optimal or encouraged, but for most adults it's recommended to go less than 130 over 80. ESC, 120 to 129, very similar. They say 120 is optimal. ESC, stating the obvious maybe, but wanting to be clear that we don't want to treat patients that cause symptoms. So we want to make sure that we're being pragmatic to as low as reasonably achievable for patients who cannot tolerate a target of 120 to 129. ESH, again, 120 to 129 for most patients, although age up to 64. A little bit less proactive, I would argue, for older patients. But for most patients, particularly 18 to 64, all the guidelines will agree that we should be aiming for 120 to 129, let's say. And again, if we're starting with a blood pressure of 140 or higher, that's going to require 2 meds. This is an interesting concept. I learned a little bit from reading this myself. This was a viewpoint from Wang and Rogers. Of course, Anthony Rogers from the George Institute, very involved in combination therapies, as you all know. And this is the argument that they make, which is interesting to reflect on. If you want to get a patient to a target of less than 130, you have to think about normal variation, individual variability in blood pressure. And their argument is that if you want the patient to be less than 130 over 80, 80% of the time, so you bring them in, say you brought them in 100 times in a year, which would be crazy, but let's say you did that. You want them to be at their target 80 times out of those 100. If you want them to be a target 80 times out of 100, or 80% of the time, you actually need to really target a mean of close to 120 because of the individual variability. This is assuming just a coefficient of variation of 7%, which is not that high. You know, that's a 7 millimeter mercury differential between repeated measures in somebody with a blood pressure of 100 systolic. So it's not a very high coefficient of variation. And this is also factoring in regression to the mean, which is common when you measure blood pressure in the office. It's usually a bit higher than it actually would be out of office. So they've counted in these very conservative estimates. And again, to get somebody to less than 130, 80% of the time, their average, true average, needs to be close to 120. And so that has implications for double combination therapy. This, in the dashed curves, you can see a patient who has an average office systolic of 150. And if you start with initial combination therapy, you get the blue dashed line. That's the blood pressure you can expect from one treatment, an average reduction of about 10 of systolic blood pressure. That's not close to where we need to be, which is the black line. Even for a patient who is started on double combination therapy, which is an average of hypertension polypills of 18 millimeter mercury reduction, you don't get them to where they need to be. So their argument is that for many patients, particularly those in systolics in the 150s, you won't even get them to target with a double combination. You probably need a triple combination. And that therefore also implies that for patients in the 140s, you need a double combination to get them to this black line. Again, just reflecting on this variability and the fact that if you want them to be a target more than 80% of the time, you need to aim for a mean that's actually lower. Okay, so what's my take on monotherapy versus low-dose combination therapy and the trials? I will say that there's been numerous trials. I don't have time to go into every single trial today. There was a very nice presentation yesterday on, actually a number of presentations, 2 of them, on the various different trials of monotherapy versus combination therapy up front. But I'll summarize them. I think it's fairly established what the summary of these trials is and what the additional benefits of initial low-dose combination therapy are over and above the practicality of you just probably need them to get somebody to target. So what are the additional benefits? Well, better adherence. There's no doubt about that. And that's been shown with prescription refills, with urinary metabolites. The less pills you take or you prescribe, the more likely they'll be taken. No doubt about that. No doubt that the patient who is started up front with initial combination therapy gets the blood pressure target or gets at least blood pressure control. Not many patients are getting to target, let's face it, but gets some blood pressure control more quickly. No doubt about that. I will say that the trials would suggest that initial monotherapy patients will eventually get there, but at a much slower pace. obviously that requires them to follow up with their doctor and so on and so forth. And the studies that have been done in this have been done under research settings. I think in the real world, many of these patients, we might see them once a year, so it might even be slower to get them to target with initial upfront monotherapy. But faster control, there's no doubt, for combination therapy. This might be provocative because you sometimes see that the argument that initial combination therapy is associated with less symptoms. I'm not so sure when I've looked at the evidence myself. I think, and even intuitively, I'm not so sure that makes any sense because you're giving them 2 medicines up front. Yes, at a low dose, but still 2 medicines. What is true, and what I would argue we have no doubt about, is that you get more blood pressure reduction without more symptoms. So you have similar symptoms to a monotherapy approach where you increase the dose to full and then go to the next medicine as you do with an initial low-dose combination. So you don't get more symptoms, but you do get better blood pressure control. So that's better bang for the buck, as they say. Of course, we know that the side effect profile of these antihypertensive meds is very dose dependent, and so at the lower dose range, which is possible with combination therapy, you get less side effects for each of the combination drugs that's included in the combination. But I think overall, when you have 2 drugs or 3 drugs, even though each one has less because they're at lower dose, it's probably about the same side effects as a monotherapy approach, but with better blood pressure lowering. That's the important point. There is observation studies, no trials, that there is benefit on CVD events. I would argue there may be some confounding patients who take initial monotherapy or in studies, observation cohorts of monotherapy versus combination therapy. They may be healthier in the combination therapy side. They may be better looked after. Their doctors might be doing better things, more up to date and so on and so forth. But we do have polypill trials that show benefits relative to usual care. So it's certainly not harmful, and probably there is some benefit on cardiovascular disease outcomes. May reduce costs direct in terms of drug costs, indirect certainly if there's a reduction in blood pressure and cardiovascular disease outcomes. I think it depends a little bit on the country and the context, what combination you're using, but likely there's cost benefits. We touched a little bit earlier on the initial low-dose double combination versus initial low-dose double combination, and then the titration to a full-dose double or moving from a low-dose double to a low-dose triple. I would argue that the logic for combination therapy requires you to go from a low-dose double to a low-dose triple. If you go from a low-dose double to a full-dose double, you're following the same logic as monotherapy. It doesn't make any sense, in my view. Now, what are the caveats? I'll finish up. So it's hard sometimes to get the right combination. I think some of the hype around single-pill combinations was potentially driven by industry early on, although now most are available at low cost. But one of the things that I will say is that we do have evidence that combination therapy may be non-inferior to high-intensity personalized monotherapy. So there's this one study that came out that I thought was very interesting that looked at an approach whereby you trial and errored patients on 4 meds, and you try them sequentially on the 4 meds to see which med got them to lower blood pressure target. And if you use a very personalized approach and you have loads of time in your hands and no patients to see, this might work, where you can get somebody to a better target by trialing and error with all the 4 different first-line meds. And you can get a 4 millimeter, 5 millimeter mercury benefit by trying this trial and error. But I don't think that's practical in real world. So again, I'll just finish up by saying guidelines are for the needs of most patients, but not all, and should not replace clinical judgment. Thank you.
Thank you so much, Bill. All right, this takes us to the last presentation of this very exciting session. And this presentation will be given by Professor Hang-Hoon Lee from Kyungpook National University. And the title of his talk is Beta Blockers as First-Line Therapy, A Step Backwards. Professor Lee.
Thank you, Mr. Chairman. I'm Jang-Hoon Lee from Kyungpook National University Hospital. It's my great honor to present here today. Today's my talk is about the beta blockers. It's a very, very old debate. Beta blockers should be first-line therapy or should be add-on therapy. So today's my topic is just focus on the ESC hypertension guideline. So I'm just focusing on the 3 European guidelines. The first one is 2018 ESH guideline, and the second one is 2023 ESH guideline. And today my focus is 2024 ESC guidelines. So in the early guideline ESC ESH 2018, the beta blockers, the position is just add-on therapy. It's not a first-line therapy, as you know. However, in 2023, in the ESH, beta blockers were upgraded to be considered among the major first-line antihypertensive drug classes. So beta blockers can be used as monotherapy in this guideline. However, 2024 ESC guideline, again, beta blockers are not considered a first-line therapy, just add-on medication. What makes these big changes? There is no new big trial for beta blockers, just a new meta-analysis we can see. So beta blockers, the position is in resistant hypertension and third line. So it's not first line. So in this ESC guideline, we can find the mention that there are 5 major drug classes: ACE inhibitor, ARB, calcium channel blocker, diuretics, and beta blockers. However, in this description, the first 4, ACE inhibitor, ARB, CCB, diuretics, are recommended as first-line option. The beta blockers can be added proportionally in circumstances. So why beta blockers is not chosen as first-line therapy? The reason is described exactly in this guideline. The beta blockers are less effective, higher discontinuation rate due to side effect, increased risk of new onset DM, does not prevent progression of hypertension-mediated organ damage, and also beta blocker increase stroke volume. Therefore, isolated systolic hypertension in patients with isolated systolic hypertension, beta blocker does not help for them, and beta blocker also does not help for arterial stiffness. Because of these reasons, beta blockers just should be add-on therapy. It's a direct comparison, ESH 2023 and ESH 2024. Beta blockers are first-line therapy. In ESH 2023, yes. The nuance is yes, the stance is yes. But ESC 2024, no. So there's a little bit difference between 2 guidelines. In Korea, the hypertension fact sheet in 2025, the beta block monotherapy used 7.5%, and double combination 8%, triple combination 34%. In the practice, beta blockers already regarded as the add-on therapy. So today's debate is that what is the current position of beta blockers? Beta blockers are first-line therapy or add-on therapy. So pros and cons for beta blockers as first-line therapy, I will review some evidence from now on. The first, ability for BP reduction. So beta blockers showed a lot of studies, good effectiveness to BP lowering. However, the problem is that in a CAPE study, beta blockers significantly reduce peripheral blood pressure. However, it fails to reduce central blood pressure and pulse wave, central blood pressure and pulse wave velocity. So it may be related to future cardiac events. However, how about the cardiovascular outcome for beta blockers? It's an interesting study. This study showed heart rate, the association heart rate reduction and cardiovascular events after beta blocker use in hypertensive patients. And from 9 studies, more than 30,000 patients. Beta blockers induced heart rate reduction may increase cardiovascular events and deaths. Especially for atenolol. Atenolol did not improve mortality or cardiovascular outcomes compared to placebo. However, in recent meta-analysis, beta blocker significantly reduced systolic blood pressure more than 10 mmHg and eventually lower the cardiovascular outcome, CV mortality, and also all-cause mortality 13%, more than 20%. The other meta-analysis also showed in all available trials, beta blocker reduced cardiovascular outcome, mortality, and all-cause mortality. In hypertension trials, also beta blocker reduced CV outcomes. Therefore, some debates about clinical efficacy to reduce a clinical outcome for beta blockers. How about the comparative effectiveness of beta blockers? In atenolol study, atenolol increased mortality and cardiovascular events by 1.3 times compared to other antihypertensive drugs. However, in recent analysis showed that even though beta blocker increased CV outcome and all-cause mortality, however, the effect is modest, only 6% increase. However, there is no significant difference in CV mortality compared to other antihypertensive drugs. Therefore, even in the hypertensive patients, therefore, even though beta blocker increase clinical event such as all-cause mortality a little bit, however, there is no significant difference in the CV mortality compared with to other antihypertensive drugs. However, the efficacy of combination therapy of beta blockers is very old study, very old, 2002 study, very famous LIFE study. Losartan, atenolol compared in high-risk hypertension patients with LVH. Systolic blood pressure was significantly lower in losartan-based regimen, and also the primary endpoint. The losartan significantly reduced clinical event compared to atenolol. In the LIFE study, this difference mainly comes from the stroke. So there is no difference in between two groups in terms of cardiovascular mortality. However, in stroke, the atenolol significantly higher stroke rate compared to losartan. In ASCOT BP lower arm studies, in this study, amlodipine-based regimen compared to atenolol-based regimen in high-risk hypertension patients with 3 additional CV risk factors. In this study, blood pressure, systolic blood pressure, diastolic blood pressure were significantly lower in amlodipine-based regimen. However, there's no significant difference in terms of primary outcome between two groups. However, in subgroup analysis, you can see that non-fatal MI, total coronary endpoint, total cardiovascular event, all-cause mortality, CV mortality, fatal, non-fatal stroke is significantly higher in beta blocker-based regimen. ASCOT legacy cohort study is a longer study followed for 16 years. During the 16 years, the stroke rates significantly higher in atenolol-based regimen. However, in all studies, just I mentioned LIFE, ASCOT. In these two studies, just increased stroke rates. However, the other studies, there is no significant difference in the beta blocker combination to other drug combination. No significant difference. Beta blocker combination significantly reduced clinical event compared to placebo, significantly. So, just LIFE and ASCOT study, beta blocker, the clinical result is not good, but the other studies, the comparable effect, beta blocker combination therapy. How about the beta blockers and cause-specific outcomes? Cause-specific outcome means the heart failure, coronary disease, and the stroke. A recent analysis showed beta blocker significantly reduced heart failure and stroke. And more recent study, 2015, the meta-analysis showed beta blocker also reduced heart failure and stroke. And this analysis, all studies, especially for patients with hypertension, beta blockers reduced heart failure and stroke is definite. There is also a known field about beta blocker classes, the impact of new beta blockers. So there are three generations of beta blockers. Usually, the atenolol is second generation. Carvedilol and nebivolol has more vasodilator effect, so classified as third generation. We don't know much about the difference, the class effect, because there are no big study based on the class. However, some studies showed, and in the case of nebivolol, showed they improved arterial stiffness in some groups, and also beta blocker combination, new beta blocker, such as nebivolol combination, reduced systolic diastolic pressure and diastolic blood pressure response when used the combination. And usually beta blocker increased the new onset diabetes. However, in vasodilating property beta blockers, significantly lower incidence of diabetes development. And also, usually atenolol does not decrease central blood pressure and peripheral pulse pressure. However, new class vasodilating beta blockers significantly reduce the central blood pressure and central pulse pressure when added on the calcium channel blocker. So that is my summary and conclusions. So what is the key message in ECSC 2024? This guideline reaffirms the role of beta blockers. Beta blockers does not recommend all subjects. Beta blockers just recommend advanced therapy and also recommend in patients with specific indications. So we should use wisely. And in this ESC guideline, they usually recommend beta blocker can be used as first line in patients with compelling indications. So to avoid metabolic risk, the beta blockers with vasodilative effect has more favorable result. So beta blockers usually can be used as combination therapy. In that case, they showed good efficacy. So beta blockers have a lot of side effects, the higher rate of discontinuation rate. So before you prescribe a beta blocker, you should educate the patient properly. And I think in this topic, beta blockers step backward, not in this guideline, step forward through individualization. So we should choose wisely who need beta blockers as add-on therapy. This is the key message of this guideline. So, however, there is also a known field, the new generation beta blockers, the role of new generation beta blockers regarding the clinical outcome and BP lowering. We don't know much about that, so we need further study about that. Thank you for your attention.
Thank you so much, Professor Lee, for that wonderful presentation. I guess at this point we have the opportunity to open up the floor for our panel discussion. And I'm delighted to welcome Professor Lee, Professor Im, and Professor Zhang, who will be part of our panelists. So are there any questions, comments for our four fantastic presenters?
Thank you very much. The excellent talk. Four speakers. I would like to ask Professor Beckboy. Yeah. So, 2024 ESC guideline recommend the initial low dose combination and low dose dual combination therapy, and then low dose triple therapy. Yeah. So, I sometimes confused. So, standard dose dual combination full dose dual combination, maximal dose fused combination sometimes. So it's very difficult. So do you think which step of standard doses, for example, telmisartan 40 milligram plus amlodipine 5 milligrams, so which step is low dose dual combination between dual combination and low dose triple combination? It's difficult pronunciation.
Yeah, I agree. It can be challenging, and it also is complicated further by the fact that there's now these quad pills that have ultra low dose components. You know, so I mean, I take a kind of practical approach to this. I think if you are considering what's a low dose as part of a combination therapy, I would apply the same classification to the monotherapy. So for me, a low dose of amlodipine is 2.5, and you can go down the list of your medicines, but the lowest dose that you can prescribe for monotherapy would, in my view, be a low dose when it's added to a combination therapy. And then, you know, you can think about increasing the dose if you want. The idea of low dose dual combination moving to low dose triple combination as opposed to low dose dual moving to full dose or standard dose, full dose dual combination therapy is one that's up for debate. The logic, I would argue, is in favor of going from a low dose dual to a low dose triple. And that is because the arguments for low dose double combination therapy to begin with are that you get more blood pressure reduction with the same amount of side effects when you use a low dose in combination. And of course, we also have to remember the pathophysiology of hypertension is complicated, and there are many pathways that can be perturbed. And we unfortunately don't have a way to individualize treatment over and above trial and error, which can be done. I showed you that study from JAMA, but very time consuming. And so conceptually, considering there's a lot of different pathways that can be perturbed, you know, vasoactive pathways, salt handling pathways, and so on and so forth, it makes some sense intuitively to hit the patient with treatments that block more pathways than increasing the dose, doubling down on one pathway by going, you know, initial monotherapy up to full dose. And for similar reasons, I would argue if you go from a low dose double to a low dose triple, you're more likely to get the right pathway or the right pathways that are perturbed or disturbed in your patient. And also, you get more bang for the buck with blood pressure lowering as opposed to side effects going from a low dose double to a low dose triple. But I have to acknowledge that the studies that have been done comparing a low dose double up to a full dose double versus a low dose double switching to a low dose triple are mostly surrogate outcome studies and blood pressure control studies, and they look at speed of control. Ultimately, patients in these studies generally get controlled because they're in research studies. People are very vigilant of patients or participants in research studies. So I think as a clinician you have a lot of leeway, and that's why I had that slide in my talk at the start and at the end emphasizing that these guidelines are guidelines and that they may not apply to all patients, and that clinical decision making, the doctor and the patient, is still a priority. And if you have a reason for a patient preference due to comorbidities of not going from a low dose double to a low dose triple, say you don't want to add in a diuretic or a beta blocker in somebody who's pre-diabetes, then it's reasonable to go to a low dose or go from a low dose double to a full dose double. And while the ESC recommended for most patients to go to a low dose double to a low dose triple, we have to acknowledge that the ESH had a different recommendation, and the American guideline doesn't even cover this. So there's a bit of uncertainty, I would argue, about this.
Thank you very much.
I have one question.
I don't want to take the
low
but yes.
dose combination. There are growing confusion in low dose, but in clinical practice, how to approach, how to apply this low dose combination in clinical practice?
Well, I'm not sure if I'm going to answer this right, but I think it makes sense to prescribe single pill combinations first. There's a difference between a low dose combination and a low dose combination in a single pill formulation. So sometimes the language can get confusing. For the most part, I'm talking about single pill combinations at a low dose. So that reduces the pill burden for the patient. In clinical practice, and I'm a half-time clinician, it really comes down to what's available in your country. And unfortunately, there is a fair amount of heterogeneity between countries in what options you have, both in terms of the combinations you can prescribe, but also the doses of those combinations. I do think that it's improved a lot over the years, and I also should say that the recommendation for combination therapy upfront for hypertensive patients is not new. It was in the 2017 American guideline and the 2018 joint European guideline, and many other guidelines besides. So this isn't a new recommendation, and thankfully, because it's not new, I think there's been more development on the industry side to increase the number of combination pills that are in the market. I'm walking around here, although I can't read in Korean, I can see the doses. I see the 12.5 and I know that's HCTZ. I see the 5, I know that's amlodipine. It looks like you have a nice selection of combination therapies and single pills here. So that's a good thing. In America, in fact, there's a fairly significant dearth of options. So I think America is behind a little bit with regards to options for low-dose combination therapies that come in single pill. So hopefully that answered the question. Maybe it didn't. I don't know.
Bill, I think I'll be very cautious in the explaining the evidence from the intensive treatment because you have cited 6 trials in the guideline in the recommendation of intensive treatment. 2 from the States and another 4 studies from China. Actually, even in China, we have a lot of debates and in 4 trials, intensive trial studies in China, a STEP study, Esprit, BP Road, and the China rural studies. Because these are open level studies, there are without about the bias, especially in the blood pressure measurement, because we know that a lot of debate on the spring study because raised the issue of blood pressure monitoring or problem out of the unattended or attended blood pressure measurement in the spring study. But in China, it's maybe not that case, but another problem have raised because whether these measurements are convincing, we have looked into the data, the published data in the STEP study published in the New England Journal of Medicine, but in the supplement, they show the home blood pressure results. And in the intensive treatment group, the blood pressure remained the same during the whole follow-up period. On the contrary, but in the standard care, the blood pressure rise during the follow-up period, which is not inconsistent with the office blood pressure measurement, so which is reliable. We don't know, because, but in the subsequent published paper of STEP study, we can also find that maybe that this is not an intensive treatment study because even in the intensive treatment group, the left ventricular hypertrophy also increased during the follow-up period. And this published in the Hypertension in your journal. And also in the other journal published in Chinese Medical Journal, in English, the PWV also increased during the follow-up period. This is quite paradoxical because even in the live study or the subsequent studies studying left ventricular hypertrophy. With the blood pressure reduction, the left ventricular hypertrophy improved. But it's not the case in the STEP study. That's the big problem. And also in the aspirin study, they estimated that with the blood pressure reduction, they should have a 20% reduction in the outcome, but only 12%. This is only a quite modest or marginal effect in the intensive treatment group. And also maybe in BP road study is also paradoxical, because the blood pressure was reduced quite significantly, but no improvement in the HbA1c glucose, because these are all patients of diabetes, no improvement in glucose control, and even elevated in LDL-C. So in patients with diabetes, experts of diabetes treat these patients with the blood pressure lowering agents quite effectively, lower blood pressure without improvement in the lipid or glucose. And then in the China rural studies, the estimated incidence of cardiovascular risk is about 14.6%, 10 years. And in the intensive treatment group, the actual incidence, 16%, quite high than estimated. So these results are quite paradoxical. And they also use only few numbers of antihypertensive agents, less than 2. Actually, less than 2 agents can lower blood pressure from 150 to 130 or even 120. That's quite not inconsistent in accordance with our clinical practice. So we still have a lot of debate in China, actually, though it's not have been talked about in the international meetings, because these people never appeared in any hypertension meeting worldwide, but only give their presentation in cardiovascular meetings. That's something we have to consider, whether these results are from because we can only see that the blood pressure difference, and the blood pressure difference can explain the difference of the outcome, whether it's from the reduction of blood pressure or the increase of blood pressure in the standard treatment group. We cannot find from the data. And the STEP study only published one paper on home blood pressure monitoring, but they published more than 10 papers subsequently, but never shown home blood pressure. I think, Ryan, you should be very careful when you handle this manuscript submitted to your journal. Just a comment. Thank you.
Thank you. Yeah, I think that's a very, very good summary of really the difficulty in applying evidence from trials to clinical practice. It's not a perfect science. It's somewhat less black and white and more gray, and it can be a challenge. The 2 points that I think are most pertinent among all of the very salient points that you make are that, number one, the blood pressure measured in the trial, in the intensive arm of the trials, at least to my understanding in what's been published, and it hasn't been published from all the trials, is generally lower in the research setting than what was recorded outside of the research setting. And so, for example, in the SPRINT study, they published the blood pressure readings from the electronic health record during the trial and compared that to the readings at the same time in the participants as measured by the trial investigators. And there was about a 7 or 8 millimeter mercury difference. And that's why we were very slow to recommend a target of less than 120. That's why we went with 120 to 129. And I personally think that's the right thing to do. The other thing I'd say is that the elephant in the room, and one of our great presenters today showed us some of the data of risk to benefit. And we know there's a risk as well to intensive treatment. We saw a hazard ratio of 3 for syncope. Now, the absolute risk increase is still very small for syncope, and it's far more common to have a cardiovascular disease event than it is to have a syncopal event. But when you look at the number needed to treat versus the number needed to harm, and in BP rule, the Lancet paper, which is fantastic, the number needed to harm and number needed to treat were somewhat similar, over a 3-year horizon, maybe about 50 or 60 or so for number needed to treat and number needed to harm. But it's difficult because it's hard to put things like syncope and eGFR reduction, which generally appears to be more mild than severe and somewhat reversible, and electrolyte imbalances on the same weighing scales as a stroke or an MI. And I think that's why the concept of net benefit, which the BP rule investigators pursued, was very interesting. And their finding was that you probably need to have 3 or so adverse events, which are generally more mild in clinical nature, to offset one benefit in terms of CVD. And from that point of view, there's definitely a favorable net benefit to intensive therapy. But again, this is all based on trial data, and applying trials to your own patients and your own practice is somewhat difficult. And that's why we gave that little bit of wiggle room in the AC guideline, not targeting less than 120, which was the target in most of these trials. Not in STEP, but in BP rule, Esprit, and Sprint and Accord, the target was less than 120. We do not recommend that in the ESC 120 to 129.
Yeah, I think we're coming to the end of this incredibly interesting session, and I think that the discussion has really highlighted some of the challenges, the controversies, which was the purpose of this whole session. Professor Zhang, if I may just ask you, just as we sort of close up now, you've really highlighted some very important points. May I just ask you, how are you in China using these data as you start developing your next iteration of guidelines based on some of the challenges you've highlighted? And the other thing I would just like to ask you, and a consideration, I understand that in China, thiazide diuretics are not used very commonly in the treatment of hypertension, whereas in the US, for example, a lot of the studies do use, or we use thiazide diuretics very extensively. And I'm just wondering whether that might have some implication in terms of the fact that you don't have improved cardiovascular risk despite increased lowering of blood pressure. Do you think it might be due to the fact that these patients are not taking thiazide diuretics, whereas in the US, most of the patients with intensive blood pressure reduction are on thiazides? It's just a thought, but it's something that I think about a lot in terms of extrapolating data, say, from the US and data from China.
I think maybe the only difference between the China and the US is about the diuretic is the different kinds of diuretics. In China, we use hydrochlorothiazide, but not used as a monotherapy. Usually, actually, most of the time is in combination. We have, you have been to China last week, and you know that we have a lot of combinations, but only 2-drug combination, not triple combinations. So we use a lot of thiazide in combination, hydrochlorothiazide. And also we use indapamide, also in combination most of the time. So the monotherapy of thiazide or indapamide is quite rare in China. But most of the time we use combinations. That's the current situation. I talked to one of our colleagues from Korea. You have clothalidone. Actually, in China, we don't have clothalidone. We just have hydrochlorothiazide and the indapamide. That's also very popular, but most of the time in combination. We had a recent survey. In our study, we study on the endocrinological hypertension. There's a survey. We tested all the patients in the clinic. Only maybe less than 1% of the patients receive monotherapy of thiazide, but many patients receive the combination in combination. Very effective because in resistant hypertension you have to use that at least. Yeah. And your first question about the guidelines, we noticed that there are these trials, 4 trials actually, in China, but we omit some of the studies, China rural studies. It is not, although it's published a lot of paper in Lancet, but still we know that it is not convincing, convincing trial. So we did not cite the study in our guideline, but in another guideline they heavily cite that. You know,
Adding to
it's
the
politics.
confusion.
It's a politics. And another, and for STEP study, we cited this trial, but we also emphasized for those patients with well-controlled blood pressure, you should not loosen the treatment, should continue to maintain the study agent in those with well-controlled patients. That's when we cite the STEP study, because in STEP study, if you look into the home blood pressure, it implies that the patients were very well controlled. If you loosen the trial, reduce the agents, you may increase the risk of developmental outcomes. So we give a recommendation on that. But they only published one paper on that. Then BP Road, it has only marginal effects, so that's something we did not cite. And for the only, and the BP Road study is carried out by experts for diabetologists, but also quite problematic. But many of our experts do not believe in that this trial. This is not convincing trial. So that's our attitude.
Thank you very much. So, Professor Shin, do you have any questions before we close the session?
Do you believe that is just mainly because it is open label study, right?
I think that's the point, actually, because if you look into the double-blind trials, only the few millimeters difference between the two treatment groups, HOPE-3 or any other trials, even in NARF trial, fever trial, and only 4 millimeter differences. And another trial also in China, with genome study have not been published, only 3 or 4 millimeter differences. But in this open label trial, large difference. I talked to Professor Yan Li, you know, he's doing a home blood pressure study and with a similar design of spring study. It's quite difficult to separate the two groups, blood pressure. Only a few millimeter differences. That's the problem.
Of course, it's impossible to do a treat-to-target trial unless it's open label.
Yes.
That's the other part of this.
Okay, so we have gone a little bit beyond the closure of the session, but I think the discussion was so exciting. Please continue to discuss as we network after the session, and I would really, on behalf of my co-chair and our fantastic presenters and our panelists, thank you so much for this session, which I think really opened many questions, many challenges, but I think we really need to strive for lowering that blood pressure, which at the end of the day is what we need to do with clinical judgment. So thank you so much, everybody. That was a wonderful session. So interesting.
Thank you.